They have to be called, I think. And I think Shweta also is outside. The whole CBR gang is. They started taking about local problems. Grow the roses. Oh, thanks. Thank you, Shweta, for the wonderful talk. Dr. Falguni is here. Thank you, Dr. Falguni, for the enlightening historical talk. Dr. Ramesh, has he left? Okay, as we begin the next session and I hand over the mic to our able students to take forward, but I also will take this opportunity to hand over some more roses to the current session speakers. Dr. Anish Mehta. Thank you for coming and gracing. Sorry, you are preparing your talk. Thank you very much. Dr. Srinivas Raju. It's a pleasure seeing you again, Dr. Srinivas. Dr. N. Shivashankar. Yeah. Not so soon. Dr. Anita Mahadevan. Thank you so much. One more. Thank you so much. Also, we are grateful that we have the company of some of our colleagues here who are going through Parkinson's, and it's our pleasure to also give them a rose. And Professor Mahadevan from Indian Institute of Science, whom I have known for many years, is in the US currently, and he still managed to send us a recording which we will hear. So he's not here in person, but the next person we have is Harish Kulkarni, Senior Manager of Cape Gemini India and PWP. Thank you. Next we have Geetha R. She's a Health Coordinator, People's Health Movement, National Adolescent Health Consultant, Women's and Children Health. Please come. Thank you. Dr. Prathima Kadiyala, MRCP UK, Diploma in Dermatology and Skincare at Tirupati and PW. Dr. Prathima, thank you so much. And we have a late entrance, Dr. Albert and Dr. Lata. Please come forward to collect your roses and for your talks, wonderful talks. Thank you so much. I think I have not missed out on anybody, so forgive me if I missed out on anybody. But right now it's my pleasure to hand over to our able students to take over the session. I would again request, we have done something wonderful in sense of having more and more speakers. We have packed the whole one-day program into a half-day program, and so that can only go forward as planned if you all stick to your time. So as usual, at 13 minutes you'll get a buzzer, and then at 15 minutes you'll get one more buzzer indicating your time is up, and that will leave us some time for a few question answers with an interaction perhaps. Thank you again.
Thank you, Ravi. This session will be handled by Mr. Gokul. He will be the chair of this session. I welcome Mr. Gokul to start the session.
Am I audible to everybody? I hope you can all hear me. Hello? Yes. Okay, sure. Thank you. Yeah. So I would like to welcome everybody to this wonderful session that Dr. Prashant had asked me to come here for. Okay, hello.
Volume
Kelsa idega?
I think would you
I think that's a better one, yeah. I don't mind. Hello, is it better now?
Yeah.
Okay, great. Thank you. I mean, I have some speech issues myself, so you can imagine volume issues. So welcome everybody to this wonderful session. And as I always used to hear in National High School when I was a student, Dr. H. Narasimha used to be our principal there, and some of you may know him. And he always used to tell me that in US there was a prayer, that a part of the prayer of National High School which used to be played even in the United Nations. Okay, and the shloka only I'll tell you. I mean, the point is that they would always preach the universal brotherhood kind of thing. So for everybody in our from our country, so that shloka will be something like this: that sarve chasukina santu sarve santu niramayaha sarve bhadrani pashyatu ma kaschid dukkha bhavet. That means let everybody be happy, and sukina means happy. Let that everybody be niramayaha means without any disease. Sarve bhadrani pashyatu means everybody can have a good, good things to look forward to. And Bhadra means Mangala. Mahakashchi Dukkha Bhavet. No, let nobody be unhappy. That's the kind of thing. That is the kind of prayer that, our country used to propose. So, in that connection, I think I am very happy that Dr. Prashant has given me this wonderful opportunity. And I generally find that, the previous sessions were heavily loaded, I mean, most of it was overhead transmission for me at least. So, at least in this session, we'll like to try to make it a little laughter and other things, mixed with that, and some kind of jokes and stuff like that I would like to put in. So, how many of you are just on Sindopa kind of a drug here? Okay, 1, 2, 3, 4, 5. So when you take the Sindopa or Levodopa combination, right, you have this on and off time. Do you agree? And on time you will be like a 20-year-old person, and off time you will be like a 90-year-old person, and you will never be a 40 or 60-year-old person at all. So in that connection, I would like to show you one song which some of you who know Hindi may be able to appreciate. Do you know, how many of you know Hindi here? Ah, good. I think then you should be able to see this song for yourself. I mean, I'm not going to play the whole song, but I will be just can you hear this? Yeah. Oh. That's what your Sindopa does. So, okay. So that's the kind of the effect of the drug would be. So we are all, I mean, most of us are Parkinson patients here, and so that the kind of feeling we get, and also the caregivers, they will also be kind of able to appreciate the mood swings and stuff like that because of this. Okay. So with that, I would like to welcome Dr. Anish Mehta, if I got his name correctly, yeah. And yesterday I had the opportunity to get some of your biodata, so your very excellent biodata that I have here in front of me. Dr. Anish Mehta is a consultant neurologist at the Ramaya Institute of Neurosciences and Ramaya Memorial Hospital with more than 7 years of clinical experience after passing DM in neurology, right? And please correct me, doctor, if I am telling something wrong. So his main clinical and research research interest is in the movement disorders, especially the Parkinson disease. So movement disorder, okay. Tremors and also the toxin therapy that he has instituted and treated more than hundreds of patients for the toxin therapy that he has instituted, and he has authored more than 85 national and international journals, and then his field of expertise has been in the movement disorders, and he has been awarded the Best Faculty Research Award by Career 316 in March 2018 by Shri Prakash Javadekar, Honorary Minister of HRD, Government of India. So he has been nominated as the top and emerging scientist by the AD Scientific Index, and a lot of professional membership and other things. So I don't want to go on and on because I will be stealing actually the time for the talk itself. So with that, I welcome Dr. Anish Mehta and hand over the podium to him. Thank you so much. Thanks.
Audience to present on recent advances in Parkinson disease. So hello everyone, thank you for being here today. Whether you have Parkinson's or care for someone who does, or are here to learn, your presence means a lot. Dealing with Parkinson's isn't easy. Today we explore the new treatments. Before we start, take a moment, recognize your strength, and let's learn about what are the new advances of Parkinson's, especially the therapeutics. Just a brief overview, what is Parkinson disease? We all know, I'll make it very simple. Parkinson disease is a neurodegenerative condition. There is a region called the substantia nigra which has been affected. So there is a progressive breakdown or deterioration of dopamine producing cells in that area. So the main chemical called as dopamine becomes deficient, and which leads to all the consequences or the presence of these symptoms called as movements, cognition, sleep and quality of life may be impaired. Why does it happen? Already been extensively spoken in the scientific sessions. 5 to 10% reason is genetics, Parkin being the commonest mutation. Then we have the environmental factors which comprise about 70 to 80%. Exposure to pesticides, herbicides, solvents, air pollution, water pollution, head trauma and certain chronic medications. And obviously a few gone bad substances in the brain, Lewy bodies or alpha-synuclein. Now who gets affected? As we know, once we have these symptoms of Parkinson's, the movement becomes slow. There are non-motor symptoms like cognition, sleep, etc. being affected, which affects the activities of daily living like dressing, eating or other routine activities, which again indirectly affects the participation in the career or the family activities or the social activities. And then you have these indirect affection to the environmental factors like family support, friend support and social support. So overall, people with this condition and people caring for people with the condition get affected bio-psychosocially. Now how to beat the PD illness with? I believe these 4 E's are very important to beat the PD illness. Early diagnosis, early treatment, earnest compliance and excel with the knowledge on recent advances. So these are the 4 E's which everyone should be aware to beat the PD illness. This is another slide which I want to tell. If you know these 10 terms as a PD warriors, you will know that you are neuro-informed and you become a hero or a heroine. One is substantia nigra, which is the area which is involved in the brain. Dopamine is the chemical hormone which gets deficient. It's a neurodegenerative condition. Parkin is the commonest mutation involved. Pathologically, there are Lewy bodies and alpha-synuclein. Importance of early diagnosis of Parkinson's, importance of early treatment, importance of earnest compliance and recent advancement in Parkinson disease. So I'm going to speak about recent advances. Before going there, these are the treatment available currently. We have medications which are dopamine replacement agents, which as sir just told that many patients are on levodopa, carbidopa, that is Syndopa. Then we have the COMT inhibitors. We have apomorphine. We have dopamine agonists like ergot and non-ergot medications. Then we have the selective MAO-B inhibitors like selegiline and rasagiline. And then we have the non-dopaminic agents like anticholinergics and the NMD antagonist amantadine. Surgeries which are there and been happening since last 15-20 years now, deep brain stimulation, lesioning surgeries like palidotomy and thalamotomy. Then we have obviously the rehab, physical therapy, occupational therapy, cognitive therapy and speech language therapy. DBS, I'm sure a few of them must be knowing here. It's an implantation of electrodes into the specific areas of the brain, especially the subthalamic nucleus or the globus pallidus, interna, and this acts by delivering electrical impulses to modulate the neural circuits, helping to alleviate the motor symptoms and reduce the off time, and thus improve the quality of life. Yes, it is effective by providing continuous stimulation to the targeted brain areas. It helps to minimize the fluctuations in symptoms. So selective patients are definitely DBS may help. Now, what are the advancements in treatment we have since last 5-7 years? These are some new agents and new formulations for treating Parkinson's which have been approved from 2017 to 2022. Certain medications, they have changed the formulations. For example, we have the first drug, that is the carbidopa levodopa, which is available in segmented, fragmented forms. So it's a scorable tablet. You can break into 1/4, and that gives us a 6.25 and 25 mg per segment. So you can take a precise medicine if you want to. So this is available now. Then we have, for the off periods, we have few medications like levodopa inhalation powder form. So far it's not available in India. So it is a 42 mg of levodopa oral inhalation cartridge, and it contains 2 tablets of 84 mg of inhalation. Up to 5 times a day you can take this. Then you have the sublingual apomorphine. Again, this is not available in India. Its dose is 10 to 15 to 20, 25 to 30 mg sublingual film. This again helps for off periods and adjunctive therapy for levodopa. Then we have the new one, MAO-B inhibitor. It's a reversible MAO-B inhibitor, safinamide, which is available now and very much used. 50 to 100 mg oral tablets. Then we have adenosine receptor antagonist called as istradefilin. That's not available in India. It's used in mainly Japan and US. Again, this is adenosine receptor antagonist used as 20 to 40 mg oral tablets, mainly used as for off periods. Then you have the COMT inhibitor opicapone. It's an OD dose mainly for increasing the on time. So it's an adjunct to levodopa. 50 mg tablets, not available still in India. Then you have for dyskinesias. For dyskinesias you have this extended release NMD antagonist called as amantadine ER, and which are available in different strengths, 129, 193 and 258 mg. It's available in India, these 2 strengths, 129 and 193, and it's very much used for dyskinesias, levodopa induced dyskinesias. Newer drugs, my colleague is going to speak on this for next talk. Now coming to those were about medications which we saw. Now we have the newer devices which have been used since last 5-7 years called as adaptive DBS. Now as I told you, DBS is very much there since last 25-30 years, but there is they have come with a new technology called as adaptive DBS. So these are closed loop adaptive DBS which can deliver individualized therapy at an unprecedented temporal precision for PD. So this uses local field potentials, that is the beta activity, which are related to the PD motor symptoms. So this provides the real-time feedback. So what is required for patient's best response. Then you have the continuous apomorphine infusion. It's an innovative approach for continuous infusion apomorphine, mainly via a portable infusion pump. Then we have the continuous intestinal infusion of levodopa carbidopa gel. This is mainly for continuous infusions to prevent motor fluctuations, mainly used for advanced PD. Now what is apomorphine? Apomorphine is a drug used to treat off episodes in Parkinson disease, mainly sudden offs or early morning offs. This is effective for rapidly relieving motor fluctuations. So it's a very short acting, it's given as subcutaneous route, very short acting, acts in 5 to 10 minutes, and the action lasts for about 45 to 50 minutes. It stimulates mainly D1 and D2 receptors, and this is mainly used again in advanced treatment options for sudden offs or motor fluctuations and dyskinesias. This, if a patient requires more than 5 to 7 injections, subcutaneous injections per day, then we can make it as a continuous apomorphine infusion. We can insert a pump and we can use it as a continuous delivery system. And this is duodopa. This is directly delivered to the intestine. Again, it's an invasive procedure, involves a percutaneous gastrostomy with jejunal port placement and connected to a portable infusion pump. So this is again continuous delivery of levodopa, has a predictable absorption, mainly used in advanced PD. Now these are some non-invasive devices which have been used, not everywhere but few centers do. Non-invasive vagal nerve stimulation, mainly used for pain. It modulates the neural pathways involved in pain perception neural activities. Then we have the peripheral nerve stimulation. It involves the placement of electrodes near the peripheral nerves to deliver electrical impulses. Still under investigation, but shows promise in addressing symptoms, in addressing motor symptoms. Then we have this repetitive transcranial magnetic stimulation. So this technique involves magnetic fields to stimulate the specific brain areas, and this may help in improving the motor symptoms. Then you have spinal cord stimulation. Spinal cord stimulation mainly used for gait freezing or gait difficulty. This involves delivering electrical impulses to the spinal cord. Again, it's a non-invasive, minimally invasive therapy to address PD symptoms. Again, stimulation will be spoken by my colleague in the next talk. Then you have the electrical peroneal nerve stimulation. Involves application of electrical impulses to the peroneal nerve. It helps in gait improvement and motor functions. Then you have some smart glasses, wearable devices, which again will be spoken by my colleague. We have this vibrotactile stimulation come up now, which involves the use of vibration to stimulate the sense of touch, offering to non-invasive approach to improve sensory feedback and motor functions in Parkinson disease. Then you have gloves now available for tremors, which may help in reducing the compression, it acts by compression and stabilization, offering individuals with Parkinson disease to alleviate hand tremors. So this is a schematic representation of various devices, invasive and non-invasive devices used to decrease the PD symptoms. Then we have another advancement with MRI guided focused ultrasound. This is an innovative minimally invasive surgical treatment for PD. This is mainly been FDA approved in 2018. Patients are placed with a stereotactic head frame like this, with a mount stereotactic head frame with an MRI compatible ultrasound transducer. So here what we do is we basically thermal ablate the target, which like it can be thalamus or it can be STN. So here mainly used for tremor predominant Parkinson disease. The advantage is it is an incisionless surgery, real time monitoring can be done and no implantation required. So less of side effects. But disadvantage is the skull characteristics may vary depending on person to person. It can only be done unilaterally. It's non-adjustable and relevant adverse effects can be there, like speech difficulty or gait imbalance. Comparing with DBS, it is still in the early phase. It's a naive, limited studies are there. Few patients and long-term benefits uncertainties exist. Then we have the role of physical therapy and exercise in Parkinson disease, which is very important to overall improve the outcome or the overall quality of life in the terms of aerobics training, resistance training, balance training and gait training. And then we have some newer complementary strategies for managing Parkinson disease. We have art therapy, dance therapy, music therapy and mindfulness. This is the paper which I published recently for Parkinson disease and dance therapy. This was initial experience. We tried for 2 patients initially. Now obviously we extrapolated to 25 patients. So we had a Garba dance for Parkinson patients, and because of the movement, it was quite the movement what the rhythmic movement what it had along with the high beat music. So that was very engaging. So patients did very good in terms of motor and non-motor response. So we are now it's under review with the full original article of 25 patients. I hope it gets published. So this is another thing we can try. So to conclude, levodopa is still the gold standard for Parkinson's. The search for medications for PD has continued with treatment utilizing already existing drugs as well as development of new drugs like newer formulations and then newer devices. Treatment options for motor fluctuations as symptomatic therapy are being developing with novel agents and advances device and formulation technology. Invasive devices are effective more than non-invasive devices in terms of improving motor functions. DBS has a striking effect, especially the adaptive DBS as compared to conventional DBS, pointing to instrumental advances. Exercise as a global intervention for all symptoms of PD continues to be an active area of research, including other unconventional forms like music, dance and art therapy. This is my recent patient with DBS last week. We did an adaptive DBS for her. Thank you. So April 11th is celebrated as World Parkinson Disease Day, and I would also like to invite next Saturday, the PD warriors between 8:30 and 11th at 8:30 and 1 o'clock. We are having PD Carnival, Parkinson Disease Carnival for Parkinson patients. Please join us on next week on Saturday at Ramaya Hospital. You can listen from the experts. You may have some live games and music. You may have some live art therapy, physical therapy, nutrition consult, and speech therapy. I look forward to you all. Thank you. Any questions?
Doctor, adaptive DBA.
Yeah.
Current DBA, do you have to be modified for that, or can it be new electronic?
No. Current DBS, no, sir. Conventional, no. If you use conventional, then no. Different. Yeah. So completely different it is.
So it's a new thing which is coming up for everyone.
Yeah. So just a year or 2 years ago, we started this.
Any more questions?
I want to know about the kicking time taken for the medicine to act.
Pardon?
Kicking time.
For levodopa, ma'am?
Levodopa.
Yeah, so it depends, ma'am. So if it is an oral tablet, it takes about 1 to 2 hours. Inhalation and all, it acts faster. Still, we don't have those inhalation products available here. It depends on basically patient to patient, and it depends on what kind of diet you are in. And so if you take it 30 minutes before food, then obviously the kicking time may be early. But sometimes over time when the disease progresses, there may be motor fluctuations, so there may be unpredictability. So wherein the dose may not get kick in sooner, or it may not kick in at all. So there are various factors which may result in medicine not being kicked in. So
likewise, there are some days, on days like
yeah.
For a week means at least 1 or 2 days there is an off day.
Yeah, so most important is you need to manage your schedule. The time schedule of your medicines and your food need to be very important so that your medicine kicks in the right time.
Thank you.
Yeah, thank you.
Not wrong. For the patient's point of view, actually levodopa from the kinetic point of view, better always to take it with acid media, water with a drop of lime water, lime. The absorbability will be more.
Yeah,
That's
I
what
agree.
the evidence-based
Yeah, I
studies
agree.
have been shown.
Yeah.
And off and on phenomena can be extended.
Yeah. Yeah. So
and another information for sir has asked, DBS is concerned nowadays, Prashant sir, the batteries, the life of the battery now is going up to 10 years or so. No, not like previous.
25 or so.
20, yeah, there are such kind of advances are coming, but only information. Usually, taking up a Simdopa, it should be just before food, along with a drop of
yeah.
So usually what happens when you look into pharmacokinetics, so usually when you take tablet, there is a competition in the stomach along with the proteins. So it may hinder. But in the early phases of the disease, that difference is not that much. So you don't worry about that. But as time goes further, it becomes very critical that every dosage what is being taken has to be fully absorbed so that you have the best efficacy. So at that point of time, we start telling that take the tablets on an empty stomach or 1 hour before the food, or later on we tell that to take it at least crushed with the tablets, to take it absorption to increase, or mix with a carbonated water or with a vitamin C or something like that, or a lime water. However, we should also know that in Parkinson's disease, that is not the only reason. The gut motility is also affected.
Yes.
So because of that, even though you take tablet, you might have thought that you have taken 1 hour before, but it still does not kick in, mainly because it has not moved forward and not got absorbed for other issues. And some days, like Madam told, it does not work out because other factors, your stress, anxiety, food, all those things play a role. So everything has to be tailored for each person's requirement. That is what we call it as personalized medicine. That is where the Parkinson's disease treatment is going from standard treatment to each person-based requirement. That is what we are trying to work on.
See, dynamic conditions will be there in the daytime. For a Parkinson disease person, daytime is not an issue because it will be controlled by the medicine. When once he sleeps, that is in the night, after he takes the medicine, in the night, he will not be dynamic, but the stiffness in the body comes. Whenever he has got an arch, that time he will have a problem. How to get out of this problem?
Yeah, so for that, sir, you have extended control release preparations available for the night dose. So if there are night symptoms like the stiffness or slowness, or you're freezing, you're unable to go to bathroom, or unable to walk or unable to get up from bed, then we have these controlled release preparations which can help you for levodopa. You can consider them.
Acha. These are all electronic devices or
No,
what it is?
tablets, controlled release tablets, yeah.
Acha, but
Levodopa controlled release tablets are available.
Yeah. Yeah, but during the discussion I was told that there are actuators are there. Is it worth or is it advised for having a stimulation so that they can get up and then go for their rest?
Yeah, so there are no definite data to say that it may really help those accentuators what you're talking about. So far we only give these medications. They have been in pipeline. My colleague also will show some of those how it helps for other symptoms. But for 9 symptoms at presently we use this controlled release preparations.
In the interest of time, we'll move on to the next talk. We'll have a question answer session at the end of this session, so we'll move on to the next talk.
Sure. Srinivas Raju. Yeah. And he's a neurologist and he has extensive experience and knowledge in many different branches of neurology. He's working as a consultant in the Manipal hospitals at Taiwan, and he has credentials and are like MBBS, MD in general medicine and then DM in neurology, and he has substantially contributed to the neurological illness by focusing on the career of their knowledge and treatment and stuff like that. So he has got so many publications, international and national, and he's also showcased his abilities in the worldwide by representing India in the video challenge in the 2019 International Congress on Parkinson's Disease and so on. So there are so many things about Dr. Raju, so I'm just running out of time, and let me, without any stealing much more time, let me introduce Dr. Raju for you, and now please take the podium. Thank you, sir.
So thank you. So I'll just quickly run through the slides because there's plenty to cover. So Dr. Prashant has given me this task to look into what could be the future of PD. So wonderful talks from morning. So I'll just, before 2 steps back, before going into the future, we need to recognize people who have done wonderful work, starting with James Parkinson's in 1817. We have come across a lot of discoveries. Charcot, father of neurology, describing the Parkinson's disease, and then moving on, first levodopa in 1961, and then the dopamine agonist in 1974. We have come to the discovery of the genetics, from genetics to microbiomes of the gut influencing PD, and also the MR ultrasound. So it's been a wonderful journey so far, but we are at the crossroads. The next 10 years would be exciting, so that is what I want you to take you through. This is the latest Lancet editorial. People who are interested can go through this, so you could get a clear picture what the future of PD is going to be. So what lies ahead? So there's been a tremendous change in therapeutic landscape with the discovery of a lot of medication for incurable diseases and the neurodegenerative diseases perspective in terms of the ASO therapy for the spinal muscular atrophy, and recent FDA approval for Alzheimer's disease as well with the aducanumab and the lecanemab. So recently there's been a lot of clinical trials for PD. So there's more than 150 registered clinical trials happening. So as somebody was questioning, so where are we now? So what are we looking at? So we are looking at all the 3 aspects, from the preclinical, prodromal to the clinical disease aspect. So the preclinical, we are basically concentrating on the biomarkers, and prodromal factors, we are trying to see a screening algorithm where we can catch them early, and also the clinical parameters as well, where we can give them the symptomatic therapy. The main focus has been, most of the trials, more than 45% of the trials has been towards the disease modifying therapies. So there are various neuropathological aspects happening, so I will go through each one of them so one by one. So we had a wonderful talk in terms of the pathophysiology, genetics and the animal models which are helping us in the therapeutics.
So where are we currently? So there is some amount of neuroinflammation and iron metabolism happening. Okay. So we have had a lot of genetic breakthroughs. We know the Parkin gene, the PINK and the SNCA. So as we are looking at personalized medicine. So we are looking at a lot of clinical trials which are linking the genetic aspect to the therapeutic aspect, wherein the ambroxol and the venglustat. Ambroxol is a cough syrup, so which we all know, we've been using it for decades. So people have been thinking out of the box to give solutions. So we have advancing into phase 3, phase 2, phase 3 trials where it is showing good results. So we just have to wait for more results. And there has been a lot of research happening in terms of the stem cells. So you can see that basically the concentration has been for a more disabling thing, acute spinal cord injuries, to ALS and MS, where there have been a lot of funding. But recently we have seen a lot of trials being, there is a lot of recruitments happening for Alzheimer's disease and Parkinson's disease. I think the basic sciences people are already aware. They're doing a lot of work on IPCs. So we have come a long way from the fetal VM tissue to the human embryonic stem cells to isolated pluripotent stem cells. So how we do this? We take the fibroblasts, we de-differentiate them from the mutant iPSC cells, we create a corrected iPSC line and transplant, and then look for therapeutic benefits. So to want of time, I just move through. So we are more concentrating on the autologous graft because we know allogenic graft, other donors, like we have a vast experience in transplant, like the kidney transplant patients. You take a donor, ABO incompatible donor, you have to give a lot of neuroimmunosuppression for them. So there are a lot of side effects for that. So autologous grafts are the main line of therapy where you can avoid these kind of draft rejections and immunosuppression, but it is an expensive line of process. So moving forward, we need to see how we can take this forward. So going on to the symptomatic treatments, where are we now in terms of the early PD? There's a compound called as tavapadon. It's a novel D1 D5 dopamine receptor partial agonist. It has shown good results in terms of early and late stage patients with motor fluctuations. So there has been improvement in motor fluctuations in early PD. So the second drug is opicapone, where my colleague mentioned about it. And the other one, what I want you to highlight is a low dose combination of two already approved compounds, that is pramipexole and racegiline combination, has been evaluated in patients with early PD. It's undergoing a phase 2 trial. So the results of phase 3 are pending. Moving forward to advanced PD, what do we have for advanced PD? So one of them were asking, how do we, the motor fluctuations on period, off period, so how do we recognize this? In clinical aspect, we have this 1-2-5 rule, where we have 1 hour of troubles, dyskinesias, 2 hours of off periods, and intake of at least 5 doses of levodopa. We consider them as advanced PD patients. So we have, because we were just discussing about the gut, so mechanistically a variable dopamine plasma levels due to a pulsatile oral medications, erratic gastric emptying, and decreasing neuronal buffer capacity can result in motor fluctuations. That's what we were trying to tell you, and that is where there have been innovation. So there is these compounds where inhaled levodopa and sublingual form have been in the market, not currently available in India. Hopefully it will be available soon. And then safinamide was discussed. I want to discuss something about zonisamide. So zonisamide is an anti-epileptic drug. We have vast experience with that, but it has been tried in Japan. It's currently not been tried anywhere else in the other group, so we don't have enough data to use them. So the other drug is suvecaltamide. It's a T-type calcium channel modulator. It's currently being evaluated in phase 2 trials for basically for severe tremors. And my colleague also discussed about the physical aspect. So there has been a lot of trials happening in that aspect as well. Aqua-based therapy, endurance, gait balance, functional and multi-domain training. What are these bringing forward in terms of the motor and non-motor aspect. There are a lot of clinical trials, so there have been a lot of interest in that as well. So our own yoga and tai chi, we have known there's a lot of data already available that they do help in controlling the motor aspects. Moving forward to non-motor, safinamide, my colleague discussed about the safinamide as an add-on therapy for levodopa. But what I want to focus here is safinamide in terms of non-motor. It has good benefit in terms of sleep, fatigue, mood, and as well as pain. And pimavanserin and quetiapine, these are two drugs which are also being tried for depression, the non-motor symptom, and also ondansetron, an anti-emetic, a vomiting medication. So there is a lot of repurposed medications which have already been used. We have good experience with it. We know the side effect profile, and moving forward, I think we need to just hope that these medications do work in some of the non-motor aspects. Moving forward to vaccination, so there have been a lot of data about the vaccination, but initial trials show there has not been a good response. So on one hand, there is a PD01A and PD03A has completed phase 1 PD for PD patients, and AC17104, an optimized formulation, has announced phase 2 trials. On the other hand, there is UB312 having completed phase 1 just recently, and they have also started recruitment for phase 2 trials. So these are the targets for basically alpha-synuclein. So I spoke about most of these drugs. I don't want to get into because we still don't have any breakthrough here, but there are a lot of trials being undertaken. Moving forward to immunotherapy, so there are like multiple sclerosis, we have a lot of immunotherapy available. We have good results that is being extrapolated to other neurodegenerative conditions as well. So two main drugs here, cinpanemab, N-terminal aggregate specific antibody was tried, but it was a failure. So the second drug, so prasinezumab, C-terminal antibody, missed its primary endpoint in phase 2 trials, but it did show a partial response, so they have taken it forward to 18-month more extensive trial to see if there be some response in terms of the immunotherapy aspect. In terms of the ASO, there has been a breakthrough in spinal muscular atrophy, so there is a hope that it will be helpful in Parkinson's patients as well. So it is basically being tried in multisystem atrophy, and the PD investigators do feel if it works for MSA, then this can be extrapolated for PD as well. And anti-inflammatory drugs, so some of the drugs used were simvastatin and verdiprestat, but they were failures. But there are trials for azathioprine and also GLP-1 analogs. So these are GLP-1 receptor agonists have been used in type 2 diabetes. So there have been promising results. This is one of the drug I want you to remember, exenatide. We can have a lot of breakthroughs there. So it is going through phase 2 and phase 3 trials. And recently this was a paper which was published in NEJM. It came a couple of days back. So this is similar to exenatide, a GLP-1 analog. So it has passed its phase 2 trial where it showed good efficacy. So there was not much of progression of the motor symptoms, but the only side effect were the GI symptoms. Hopefully that gets sorted out in the next phase of trials. The other target is the mitochondria. So the disease modifying therapies targeting the mitochondrial dysfunction, unfortunately inosine and pioglitazone were a failure, but there are two other drugs. Ursodeoxycholic acid is currently investigated in phase 2 trials, and also notably the bile acid torso-deoxycholic acid in combination with sodium phenylbutyrate is also being investigated. Reaching the genetic aspects, the LAR2 and the GBA gene, so there are been a lot of trials happening there as well with the DLN151 and the BIB094. So these are also in phase 2 trials. So I did talk about the ambroxol, which was the cough syrup. This is also, I want you to remember this drug. It could be one of the drugs which may do wonders. So initial phase, it has So it's a chaperone of the lysosomal enzyme glycosaminidase. It displayed good target engagement and increased glucocerebrosidase and alpha-synuclein levels in CSF, and it led to improvement in the UPDRS Part 3 scales in an open label study. So it is in phase 3 trials now, so we just have to wait for those results. So these are the targets for GBA. Coming to device assisted therapeutic monitoring. So from the preclinical to prodromal aspect, in prodromal, because most of the patients are not coming to us, so we are not able to identify who are the PD patients. So these device assisted therapeutic monitoring can help us even to know the off and on periods. So there has been a lot of research and a lot of bioengineers, a lot of engineering students in all the universities have a lot of hope because it brings in a lot of money. So this is the market. So you can see in 2026 it's going to be a $1 billion economy. So we do have a lot of devices available currently for monitoring. So it could be a PD monitor, PKG, STAT1, Dynaport. These are different companies using all this. Kinesia, Mobility Lab, and Feet Monitor Inosol. So these are some of the available device assisted monitoring devices. So there has been a lot of data because clinicians basically don't like everything taken away by AI and bioengineers. So that's where these kind of negative comments were made, where they said this could induce risk reduction of frequency of face-to-face appointments, so we can miss patients from moving from Parkinson's to Parkinson's plus disease. So there was an article about this. So coming to personalized medicine, so there's been a lot of device-assisted monitoring available, target specific therapy, and we have come a long way in all this. Also in terms of the biomarkers, how the devices can help us. So in monitoring the sweat, saliva, tears, and the interstitial fluid. So there have been sensors, there have been glasses, there have been mouth devices which have been available. So moving forward, I think we are looking at a great future for PD. I think if we can have a breakthrough all across in all ethnicity, if we can replicate whatever data has been available, I think we are near the stage where we could give a precision medicine. So learning from our diabetic patients as well. So now there has been availability of these kind of levodopa sensor strips. You can just put a drop of blood and check your levodopa levels, and you can top up your dose. So we are moving towards that, as well as like the diabetic sensors, we are also going to have something called these kind of levodopa sensors as well. So there was, I'll quickly place just video. There was this viral video. So where there was great breathing, where they've done a spinal cord stimulation.
Un peu de la fatigue aussi, vous voulez avancer?
De la fatigue.
My role was to implant electrodes over the spinal cord responsible for locomotion. So those are the last 6 centimeters of the spinal cord, and I applied electrodes on the top of the spinal cord that are linked to a neurostimulator located under the skin in the region of the abdomen.
So that's the spinal cord stimulator.
So we start programming the stimulator in order to apply this electrical stimulation to the spinal cord of Mark, and he starts walking better.
So the walking was better. So this is just one patient. There might be a placebo effect. So we need to see if this works in more number of patients. But that was a viral video, and this was in January, where the Harvard group, so biomedical engineers there, came up with this robot suit. Just gives a kick to the hip, so when they freeze and they start walking. So that was with assist. available. So if you want to know more about future, so there is this list called as Parkinson's Hope List, where there is the summary of all the trials. So you can go into those links. It is being managed by Dr. Kevin McFarthing, a biochemist and a person with Parkinson's. Thank you.
Thank you, Dr. Srinivas. We can have 1 or 2 questions.
So basically what we are targeting is the disease modifying therapies for the pathology affecting the mitochondria. So it's a energy cell. I'll show you. So this is the mitochondria. So this is where we get from all the energy from. So that is one of the cells in the body. So there are different targets. That's one of the target.
Doctor, you mentioned about the autologous. Hello. Yeah. So mentioned about the stem cell therapy, and in that connection you mentioned about the autologous stem cells, right? So where do they get these autologous stem cells from? The same body? I mean,
same body, same body.
No, I mean, is there any organ-specific things there are?
No. That's where we have difficulty with. I spoke about the expenses. So how can you extrapolate? So how many donors taking that and going to the lab, building up the IPC's line. So those are the difficulties with. But I think the basic science, I think I think CBR has a lot of programs in terms of the IPC. They are sitting on that side. So Ravi Mudashiti, I think he would have. No, he's not here. Okay.
Okay, sure. And also this calcium channel modulators also you mentioned, right?
Yeah. So that is for daily severe tremor. Okay, so that is still in the phase 2 trial. Hopefully these are all, whatever I showed you are the just trials. There has not been a lot of breakthrough. So only 2, the GLP-1 diabetic medications, the exenatide is one which we are hopeful of, and the second one is the GBA, the ambroxol. So these are the 2 drugs probably we need to look out for. But most of the other things, it could be vaccination, it could be immunomodulators. There have been a lot of unsuccessful trials, but I think they're remodifying. There are a lot of other things which are moving forward, but we are not. We still don't have enough good data to say we will have a breakthrough there.
Thanks. Also, this calcium channel modulator, when I was thinking about, maybe it might affect other things also. No? So how do you make it affect only the neurological aspects?
So that is where the trial. So that is also one of the target.
Yeah.
I didn't focus on that. I basically ran through all of this. So this is the one. So the calcium one. So there are different targets. There's not one target. So people are trying to address wherever. So there's no one approach. So you will have to have a multifaceted approach. That's where I told you about the precision medicine or a patient-centric thing. So you look at the genetics, you look at the pathology, and then you try to give a medicine which can target that. So that is where we are going through.
The whole concept is, some of you wanted to know in Kannada also, the whole concept ಏನಿತ್ತು ಅಂದರೆ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸೀಸು ಒಂದು ಕಾಯಿಲೆ ಅಲ್ಲ, ಒಂದು ಕಾರಣದಿಂದ ಆಗ್ತಾ ಇಲ್ಲ. ಭಾಳಷ್ಟು ಬೇರೆ ಬೇರೆ ಒಂದು ಸೆಲ್ಲಲ್ಲಿ ಭಾಳ ಬೇರೆ ಬೇರೆ ಆರ್ಗನಲ್ಸ್ ಇರ್ತವೆ. ಅದರಲ್ಲಿ ಒಂದು ಮೈಟೋಕಾಂಡ್ರಿಯಾ ಇರ್ಬೋದು, DNA ಇರ್ಬೋದು, RNA ಇರ್ಬೋದು, ಹಿಂಗೆ ಲೈಸೋಸೋಮ್ ಅಂತ ಇರ್ತವೆ. ಒಂದೊಂದು ಕಡೆ ಒಂದೊಂದು ಥರ ಮ್ಯೂಟೇಷನ್ಸ್ಗಳಿಂದ ಆಗ್ತದೆ. ಇಲ್ಲಿ ತನಕ ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ತಾ ಇರೋದೇನೆಂದರೆ, ಏನೇ ಆಗಲಿ ಎಲ್ಲರಿಗೂ ಒಂದು ಲಿವೋಡೋಪ ಕೊಡ್ತಾ ಇದ್ವಿ, ಕೊಡೋದ್ರಿಂದ ಲಾಭ ಬರ್ತಾ ಇತ್ತು. ಆದರೆ ಎಲ್ಲರಿಗೂ ಒಂದೇ ಹದವಾಗಿ ಒಂದೇ ಥರದ ಲಾಭ ಇರ್ತಿರ್ಲಿಲ್ಲ. ಸೊ ಇವೆಲ್ಲ ಸೈನ್ಸಲ್ಲಿ ರಿಸರ್ಚ್ ಮಾಡ್ತಾ ಬಂದಾಗ ನಮಗೇನಂದರೆ ಒಬ್ಬರೊಬ್ಬರಿಗೆ ಒಂದೊಂದು ಥರದ ಅನುವಂಶೀಯವಾಗಿ ತೊಂದರೆಗಳಿದೆ. ಅಂದರೆ ಜೆನೆಟಿಕ್ ಡಿಸಾರ್ಡರ್ಸ್ ಅಂತ ಹೇಳ್ತೇವೆ, ಜೆನೆಟಿಕ್ ಮ್ಯೂಟೇಷನ್ಸ್ ಅಂತ ಹೇಳ್ತೇವೆ, ಅದಕ್ಕಿರೋಂಥದ್ದು. ಸೊ ಈಗ ಭಾಳಷ್ಟು ಥರದ್ದು ಎಲ್ಲ ಒಬ್ರೊಬ್ರಿಗೆ ಹುಡುಕ್ತಾ ಇದ್ದೇವೆ, ಯಾರಿಗೆ ಯಾವ ಮ್ಯೂಟೇಷನ್ಸ್ ಇದೆ, ಅಲ್ಲಿಗೆ ಯಾವ ಥರ ಔಷಧಿಗಳಿದ್ದಾವ, ಆ ಔಷಧಿಗಳು ಕೊಟ್ಟರೆ ಅವ್ರಿಗೆ ಲಾಭ ಆಗುತ್ತಾ ಅನ್ನೋದಕ್ಕೆ ನೋಡ್ತಾ ಇರೋದು. ಸೊ ನಾವು ಜನರಲ್ ಟ್ರೀಟ್ಮೆಂಟಿಂದ ಹೋಗಿ ಪರ್ಸನಲೈಸ್ ಮೆಡಿಸಿನ್, ಅಂದರೆ ಯಾವ ಕಾಯಿಲೆಗೆ ಯಾವ ಪೇಷಂಟಿಗೆ ಯಾವ ಥರ ಒಂದು ಜೆನೆಟಿಕ್ ಡೆಫಿಷಿಯೆಂಟ್ ಇದೆ, ಆ ಡೆಫಿಷಿಯೆಂಟನ್ನು ಅಡ್ರೆಸ್ ಮಾಡೋದಕ್ಕೆ ಇವೆಲ್ಲ ಹೇಳ್ತಿರೋದು ಅದಕ್ಕೋಸ್ಕರನೇ. ಈ ಒಂದು ಹೇಳಿದ ತಕ್ಷಣ ಒಬ್ರಿಗೆ ಕೆಲಸ ಆಗಿದ ತಕ್ಷಣ ಎಲ್ಲರಿಗೂ ಕೆಲಸ ಆಗಬೇಕಂತ. ಲೆಟಸ್ ಸೇ ಎಂಬ್ರಾಕ್ಸಲ್ಲಿ ನಾವು ಹೇಳಿದ್ವಿ, ಆದರೆ ಪಬ್ಲಿಕೇಶನ್ಸ್ ಬಂದಾಗ ಏನಾಯಿತು, ನಾಟ್ ವೆರಿ. ಈಗ ರೆಗ್ಯುಲರ್ಲಿ ಕಾಫ್ ಸಿರಪ್ ಎಲ್ಲ ಕಡೆ ಅವೈಲೇಬಲ್ ಇದೆ, ಆದರೆ ಇಟ್ಸ್ ನಾಟ್ ಗಿವಿಂಗ್ ದ ಸೇಮ್ ಟೈಪ್ ಆಫ್ ರೆಸ್ಪಾನ್ಸ್. ನಮಗೆ ಎಕ್ಸ್ಪೆಕ್ಟೇಷನ್ಸ್ ಇದ್ದಕ್ಕೆ ರೆಸ್ಪಾನ್ಸ್ ಇಲ್ಲ. ಭಾಳಷ್ಟು ಕಡೆ ಏನು ಮಾಡ್ತದೆ ಎಫರ್ಟು, ರೀಪರ್ಪಸಿಂಗ್ ಆಫ್ ದ ಓಲ್ಡ್ ಮೆಡಿಕೇಶನ್, ಅಂದರೆ ಬೇರೆ ಯಾವುದೋ ಕಾಯಿಲೆಗೆ ಉಪಯೋಗಿಸ್ತಾ ಇರ್ತೇವೆ, ಆ ಮಾತ್ರೆಗಳು ಈಸಿಯಾಗಿ ನಾವು ಇಲ್ಲಿ ಉಪಯೋಗಿಸ್ಬೋದಾ ಅನ್ನೋದು. ಅದರಲ್ಲಿ ಇದರ ಎಂಬ್ರಾಕ್ಸಲ್ ಬರುತ್ತೆ, ಈ ಥರ ಬೇರೆ ಬೇರೆ ಔಷಧಿಗಳು ಬರ್ತವೆ. ಆದರೆ ಎಲ್ಲ ಪಾರ್ಕಿನ್ಸನ್ ಡಿಸೀಸ್ ಒಂದು ಕಾಯಿಲೆ ಇರಲಾರ್ದೆ ಇರೋದ್ರಿಂದ ಕಷ್ಟ ಇರೋದು. ಸೊ ಭಾಳಷ್ಟು ಥರದ್ದು ರಿಸರ್ಚ್ಗಳು ನಡೀತದವು, ಯಾವ್ಯಾವ ಜೀನ್ಸಿಗೆ ಯಾವ್ಯಾವ ಥರ ಔಷಧಿಗಳು ಟ್ರೈ ಮಾಡ್ಬೋದು, ಪರ್ಸನಲೈಸ್ಡ್ ಆಗಿ ಯಾವ ಥರ ಲಾಭ ಆಗುತ್ತೆ. ವಿ ಆರ್ ಹೋಪಿಂಗ್ ದಟ್ ಇನ್ ನೆಕ್ಸ್ಟ್ ಫ್ಯೂ ಇಯರ್ಸಲ್ಲಿ ಒಬ್ರೊಬ್ರಿಗೆ ಒಂದೊಂದು ಥರ, ನೀವು ಈ ಥರ ನಿಮ್ಮ ಕಾಯಿಲೆ ಇದೆ, ನಿಮಗೆ ಈ ಥರ ಜೀನ್ ಮ್ಯೂಟೇಷನ್ ಇದೆ, ನಿಮಗೆ ಈ ಥರ ಜೀನ್ ಮ್ಯೂಟೇಷನ್ ಇದೆ, ಈ ಥರ ಮಾತ್ರೆ ತೊಗೋಬೋದು. ಅಥವಾ ನೀವು ಈ ಮಾತ್ರೆ ತೊಗೊಂಡ್ರೆ ನಿಮಗೆ ಡಿಸ್ಕನಿಸಸ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ, ತೊಗೋಬೇಡಿ, ನೀವು ಬೇರೆ ಮಾತ್ರೆ ತೊಗೊಳ್ಳಿ, ಅಥವಾ ಇದು ತೊಗೊಂಡ್ರೆ ನಿಮಗೆ ಲಾಭ ಆಗುತ್ತೆ. ಆ ಥರ ಹೇಳೋ ಲೆವೆಲಿಗೆ ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಇದು ನೆಕ್ಸ್ಟ್ ಒಂದು 5 ರಿಂದ 10 ವರ್ಷದಲ್ಲೇ ಆಗೋಂಥದ್ದು. ಅದಕ್ಕೋಸ್ಕರನೇ ಈ ರಿಸರ್ಚ್ಗಳು ನಡೀತಾ ಇರೋದು ನಮಗೆ. ಐ ಥಿಂಕ್ ಇಷ್ಟು ಈ ಟಾಕಿನ ಒಂದು ಸಾರಾಂಶ. ನಿಜವಾಗಿ ಹೇಳ್ಬೇಕಂದ್ರೆ ಬೇರೆ ಏನಾದ್ರು ಕೇಳೋದಿತ್ತು ಅಂದರೆ ಕೇಳ್ಬೋದು. ಈಗ ಅದರ್ವೈಸ್ ಏನು ಲಾಸ್ಟ್ Q&A ಸೆಷನ್ ಇದೆ, ಅವಾಗ ಎಲ್ಲ ಕ್ವಶನ್ಸ್ಗಳು ಕೇಳಿದಾಗೂ ಆನ್ಸರ್ಸ್ಗಳು ಕೊಡೋಕೆ ಟ್ರೈ ಮಾಡ್ತೇವೆ ನಾವು. ಥ್ಯಾಂಕ್ ಯು.
Thank you, Dr. Prashant. We'll move on to our next talk. I request Mr. Gokul to introduce the next speaker, please. Thank you.
Okay, after that heavy talks, I think they're all saturated. No, not it. Okay. I'm going to give my mic. Am I audible now? Okay. So the next speaker will be Dr. N. Shivashankar, and he's an experienced speech therapist and someone whom I will be looking forward to, because I have myself a lot of slur and stuff like that. So, who has been serving for the patients in Bangalore for over 40 years, okay, specializing in speech pathology and neurology, and he's known for the best voice therapist in Bangalore. So, he can diagnose and treat a wide range of voice disorders, including those caused by vocal abuse, neurological conditions, and congenital abnormalities. So, skilled at identifying voice problems, stuff like that. So I welcome Dr. Shivashankar to the podium without much ado, so that he can take over from here. Thanks. Please, Dr. Shivashankar.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಇದುವರೆಗೂ ತಾವುಗಳು ನಾನಾ ರೀತಿಯ ಸೈಂಟಿಫಿಕ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ಗಳನ್ನು ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸೀಸ್ನಲ್ಲಿ ಮಾಡಿರೋದನ್ನು ನೋಡಿದ್ರಿ, ಕೇಳಿದ್ರಿ. ನನಗೆ ನಾನು ಇಲ್ಲಿ ಆಡ್ ಮ್ಯಾನ್ ಔಟ್ ಅನ್ನಿಸ್ತಾ ಇದೆ. ಮೇ ಬಿ ಎಂಡ್ ಆಫ್ ದ ಟನ್ನಲಲ್ಲಿ ಇದ್ದೀನಿ ಅನಿಸ್ತಾನೆ. ಎಲ್ಲ ಹೊರಗೆ ಬರೋದು ನಾನು ಮಿಲ್ಲ ಬಂದು ನಾನು ಸ್ವಲ್ಪ ಮಾಡ್ತೀನಿ ಅಂತ ಏನೋ ಒಂಚೂರು ಮಾಡೋ ಆ ಟನ್ನಲ್ ಎಂಡಲ್ಲಿ ಇದ್ದೀನಿ ಅಂತ. ಸಾಮಾನ್ಯವಾಗಿ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸಾರ್ಡರ್ಸ್ನಲ್ಲಿ ಯಾವುದು ಈ ನಿರ್ವಹಣೆಯಲ್ಲಿ ಮಾತು ಮತ್ತು ನುಂಗುವಿಕೆಯ ಪಾತ್ರ ಹೇಗೆ, ಸಾಮಾನ್ಯವಾಗಿ ಅಸೋಸಿಯೇಟೆಡ್ ಕಂಡೀಷನ್ಸ್ಗಳು ಬರ್ತದೆ ಇದರಲ್ಲಿ. ಅದನ್ನು ನಾವು ಹೇಗೆ ನಿಭಾಯಿಸ್ಕೊಳ್ಬೇಕು, ಯಾವ ರೀತಿಯಲ್ಲಿ ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇದೆಯಾ, ಎಷ್ಟು ಮಟ್ಟಿಗೆ ನಾವು ಅದನ್ನು ಅನುಕೂಲಗಳನ್ನು ಮಾಡಿಕೊಡ್ಬಹುದು ಅಂತ. ಪ್ರಮುಖವಾಗಿ ಇಲ್ಲಿ ಹೇಳಬೇಕಾಗಿರೋದು, ಈ ಚಿಕಿತ್ಸಾ ಕ್ರಮಗಳು, ಈ ಕ್ರಮಗಳನ್ನು ಉಪಯೋಗಿಸಿದಾಗ ಸಾಕಷ್ಟು ಮಟ್ಟಿನ ಸುಧಾರಣೆ ನಮ್ಮಲ್ಲಿ ಕಾಣಬಹುದು. ಪೂರ್ತಿ ಹುಷಾರಾಗ್ಬಿಡುತ್ತಾ ಅನ್ನೋ ಪ್ರಶ್ನೆಗೆ ಉತ್ತರ ಇಲ್ಲ. ಸುಧಾರಣೆ ಅಂತೂ ಖಂಡಿತ ಕಾಣುತ್ತೆ. ಹಾಗಾಗಿ ತೊಂದರೆಗೆ ತಕ್ಕಂತೆ, ಇಂಡಿವಿಜುವಲ್ಸ್ ಆ ಪ್ರಾಬ್ಲಮ್ಸ್ಗಳಿಗೆ ತಕ್ಕಂತೆ ನಾವು ಸೂಕ್ತ ಚಿಕಿತ್ಸಾ ಕ್ರಮಗಳನ್ನು ಹೊಲಿಬೇಕಾಗತ್ತೆ. ವಿ ಹ್ಯಾವ್ ಟು ಟೈಲರ್ ಮೇಡ್ ಇಟ್. ಸೊ ಅವ್ರನ್ನ ನೋಡಿ ನಾವು ಮಾಡಬೇಕಾಗತ್ತೆ. ನೆಕ್ಸ್ಟ್ ಓಕೆ. ಸೊ ಈ ಥೆರಪ್ಯೂಟಿಕ್ ಪ್ರಾಸೆಸ್ನಲ್ಲಿ ಫೋಕಸ್ ಏನಿದೆ, ಉದ್ದೇಶಗಳೇನು, ಈ ವಾಕ್ ಚಿಕಿತ್ಸೆಯ ಗುರಿ ಏನಿರುತ್ತೆ ಅಂದರೆ ಅಗತ್ಯವಿರುವಲ್ಲಿ ಮತ್ತು ಸಂವಹನ ಹೆಚ್ಚಿಸುವ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಒಳಗೊಂಡಂತೆ, ಅಂದರೆ ಆಗ್ಮೆಂಟೇಟಿವ್ ಆ್ಯಂಡ್ ಆಲ್ಟರ್ನೇಟಿವ್ ಕಮ್ಯುನಿಕೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಮಾತಾಡಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ ಅಂತಂದಾಗ ಬೇರೆ ಯಾವುದಾದ್ರೂ ರೀತಿಯಲ್ಲಿ ಅವರು ಸಂವಹನವನ್ನು ಮಾಡಬಲ್ಲರ ಅನ್ನೋದಕ್ಕೆ ಆ ಆಲ್ಟರ್ನೇಟಿವ್ ಕಮ್ಯುನಿಕೇಷನ್ನೂ ಉಪಯೋಗಿಸ್ಕೊಂಡು, ಹಾಗೂ ಧ್ವನಿಯ ಗುಣಮಟ್ಟ, ಉಚ್ಚಾರಣ ಪರಿಮಾಣ ಅಥವಾ ವಾಲ್ಯೂಮ್, ಒಟ್ಟಾರೆ ಸಂವಹನ ಪರಿಣಾಮಕಾರಿತ್ವವನ್ನು ಸುಧಾರಿಸೋದೇ ಈ ಸ್ಪೀಚ್ ಥೆರಪಿಯ ಮೂಲ ಉದ್ದೇಶ ಆಗಿರುತ್ತೆ. ಸೊ ಇದನ್ನು ವ್ಯಕ್ತಿಯನ್ನು ನೋಡಿಕೊಂಡು ಅವರಿಗೆ ತಕ್ಕಂತೆ ಹೇಗೆ ಕೊಡಬಹುದು ಹಾಗೆ ಅದನ್ನು ಮಾಡಲಾಗತ್ತೆ. ಅದೇ ರೀತಿ ನುಂಗುವಿಕೆಯಲ್ಲಿ ತೊಂದರೆ ಇರತಕ್ಕಂಥ ವ್ಯಕ್ತಿಗಳಿಗೆ ಅವ್ರಿಗೂ ಕೂಡ ಹೇಗೆ ನುಂಗೋದನ್ನು ನಿರ್ವಹಿಸುವುದು, ಹೇಗೆ ಕೆಮ್ಮು ಬರ್ತಕ್ಕಂಥನ್ನು ತಡೆಗಟ್ಟಬಹುದು, ಅಥವಾ ಯಾವ ರೀತಿಯ ವಿಧಾನವನ್ನು ಉಪಯೋಗಿಸಿದಾಗ ನುಂಗುವುದು ಒಂದು ಸ್ವಲ್ಪ ಸುಲಭವಾಗಿ ಮಾಡಿಕೊಳ್ಳಬಹುದು. ನಾನು ಫಸ್ಟ್ ಪೇಷಂಟ್ಸ್ ಬಂದ ತಕ್ಷಣ ನಾನು ಹೇಳ್ತೇನೆ, ನಾನು ಯಾವಾಗಲೂ ನುಂಗುವಿಕೆ ತೊಂದರೆ ಬಂದಾಗ, ಜ್ಞಾಪಕ ಇದೆಯಾ ಸ್ವಾಮಿ ನಿಮಗೆ, ನೀವು ಚಿಕ್ಕವರಾಗಿದ್ದಾಗ ನಿಮ್ಮಲ್ಲಿ ನಿಮ್ಮ ಅಜ್ಜಿ ಏನು ಹೇಳ್ತಾ ಇದ್ರು, ಊಟಕ್ಕೆ ಕೂತ್ಕೊಂಡಿದ್ದಾಗ ಎಲ್ಲ ಏನು ನೆಲದ ಮೇಲೆ ಕೂತ್ಕೊಂಡಿದ್ದಾಗ, ತಲೆ ಬಗ್ಗಿಸಿ ಊಟ ಮಾಡ್ರೋ, ಇದು ಫಸ್ಟ್ ಡೈಲಾಗು. ನಮ್ಮ ಅಜ್ಜಿ ಯಾವಾಗಲೂ ಬೈಯೋರು ನಮಗೆ, ತಲೆ ಬಗ್ಗಿಸಿ ಊಟ ಮಾಡೋ. ಸೊ ಚಿನ್ ಡೌನ್ ಪೊಸಿಷನ್ ಆಫ್ ಸ್ವಾಲೋ ಇಸ್ ಅ ಸೇಫೆಸ್ಟ್ ಸ್ವಾಲೋ ಮೆಥಡ್. ಸೊ ಹಾಗಾಗಿ ಆ ಥರದ್ದನ್ನು ನಾವು ಉಪಯೋಗಿಸ್ಕೊಳ್ತಾ ಬಹುದು. ಮೊನ್ನೆ ಒಂದು ಪೇಷಂಟ್ ಹೂ ಕಮ್ ಟು ದ ಕ್ಲಿನಿಕ್ ದೇರ್, let all know there were so many records. I didn't go through the records. I just asked him, what made you to come here? Sir, internet ಅಲ್ಲಿ ನೋಡಿದೆ, ನಿಮ್ಮ ಹೆಸರು ನೋಡಿದೆ, ಬಂದು ಕನ್ಸಲ್ಟ್ ಮಾಡೋಣ ಅಂತ ಅನ್ನಿಸ್ತು. So I said, okay, fine. Now what's your issue? I'm suffering from Parkinson's ಅಂತ ಹೇಳಿದೆ. ಸ್ಟಾಪ್ ಅಂದೆ ನಾನು. ಯಾಕೆ ಸರ್? ಯು ಆರ್ ನಾಟ್ ಸಫರಿಂಗ್ ಫ್ರಮ್, ಯು ಹ್ಯಾವ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್. ದ ಡಿಫ್ರೆನ್ಸ್ ಬಿಟ್ವೀನ್ ಯೂಸಿಂಗ್ ದ ವರ್ಡ್ ಸಫರಿಂಗ್ ಫ್ರಮ್ ಅಂಡ್ ಹ್ಯಾವಿಂಗ್ ಇಟ್. ಯಾಕೆ ನಮ್ಮನ್ನು ನಾವು ಮೊದಲೇ ಸಫರ್ ಮಾಡ್ಕೊಳ್ತಾ ಹೋಗಬೇಕು? ಐ ಟೋಲ್ಡ್ ಹಿಮ್ ನಾಟ್ ಟು ಯೂಸ್ ದ ಟರ್ಮ್ ಸಫರಿಂಗ್ ನಾವ್ ಆನ್. ಇಫ್ ಸಮನ್ ಆಸ್ಕ್ ಯು, ಐ ಹ್ಯಾವ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್. ಸೊ ಸಫರಿಂಗ್ ಯಾಕೆ? ಸೊ ದ ಪೇಷಂಟ್ ವಾಸ್ ಸೋ ಹ್ಯಾಪಿ ಟು ಹಿಯರ್ ದಟ್. He said, I have changed my attitude today. So we need to change the attitudes of the patient. We have to tell them how much that we can offer you the services, in what way it can help you out, but there are certain limitations which we have to accept it. ಈ ಧ್ವನಿ ಮಾತಿನ ಗುಣಲಕ್ಷಣಗಳನ್ನು ನಾವು ನೋಡಬೇಕಾದ್ರೆ ಸಾಮಾನ್ಯವಾಗಿ ಹೇಳ್ತಾರೆ, ನಮಗೆ ವಾಯ್ಸ್ ಸರಿಯಾಗಿ ಬರೋದಿಲ್ಲ, ಜೋರಾಗಿ ಮಾತಾಡ್ಲಿಕ್ಕಾಗೋದಿಲ್ಲ, ಮಾತಾಡ್ತಾ ಇದ್ದಾಗ ವಾಯ್ಸ್ ಕಡಿಮೆ ಆಗಿಬಿಡುತ್ತೆ, ಟೇಪರ್ ಡೌನ್ ಆಗಿಬಿಡುತ್ತೆ, ಕಡೆಯಲ್ಲಂತೂ ನಮ್ಮ ಮಾತು ಇನ್ನೊಬ್ರಿಗೆ ಕೇಳಿಸೋದೇ ಇಲ್ಲ. ಸಾಮಾನ್ಯವಾಗಿ ಕೇಳ್ತಾರೆ, ಮತ್ತೆ ರಿಪೀಟ್ ಮಾಡು ಅಂತ ಹೇಳ್ತಾರೆ, ಅಥವಾ ಏನೋ ಅಂತ ಕುಡ್ದೋ ಥರ ಮಾತಾಡ್ತೀಯ ನೀನು ಅಂತಲೂ ಅಂತಾರೆ. ಸೊ ಈ ಥರ ನಾನಾ ರೀತಿಯ ಗುಣಲಕ್ಷಣಗಳನ್ನು ನಾವು ಇದು ಧ್ವನಿ ಮತ್ತು ಮಾತಿನಲ್ಲಿ ನೋಡ್ಬೋದು. ಸರ್ರು ಇಂಟ್ರಡ್ಯೂಸ್ ಮಾಡಿದಾಗ ನ್ಯಾಷನಲ್ ಕಾಲೇಜಿಂದ ಶ್ಲೋಕವನ್ನು ಹೇಳಿದ್ರು. ತುಂಬ ಖುಷಿ ಆಯ್ತು, ಬಿಕಾಸ್ ನಾನು ಫ್ರಮ್ ನ್ಯಾಷನಲ್ ಕಾಲೇಜ್. ಅದಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ ಶ್ಲೋಕ ತುಂಬ ಫಾಸ್ಟಾಗಿತ್ತು, ಮಾಡೋದು ಫೀಲ್ ಬೆಟರ್ ಆಗಿತ್ತು. ಶ್ಲೋಕ ಯಾಕೆ ಫಾಸ್ಟ್ ಆಯಿತು, ಮಾತು ಯಾಕೆ ನಿಧಾನ ಆಯಿತು? ಸೊ ಇದು ಯೋಚನೆ ಮಾಡಬೇಕಾದ ವಿಚಾರ. ಶ್ಲೋಕ ಬೈ ಹಾರ್ಟೆಡ್, ಆದ್ರೆ ಪಾಡ್ಗದ್ ಬರ್ತಾ ಹೋಗ್ತಾ ಇರುತ್ತೆ. ಅದ್ರ ಬಗ್ಗೆ ನೀವು ಇದನ್ನು ಹೀಗೆ ಹೇಳಬೇಕು ಅನ್ನುವಂಥದ್ದೇನಿಲ್ಲ. ಅದು ಗುರುಬ್ರಹ್ಮ ಗುರುಷ್ಟ ಗುರುದೇವನ ಗುರುಸರಸ್ವತಿ ಗುರುವೇ ನಮಃ ಅದು ಆಗೋಯ್ತದ. ಬಟ್ ಅದೇ ಗುರುಬ್ರಹ್ಮ ಗುರರ್ ವಿಷ್ಣು ಗುರುರ್ದೇವೋ ಮಹೇಶ್ವರ ಅಂತ ಹೇಳೋದು ನೆಕ್ಸ್ಟ್ ಸೆಂಟೆನ್ಸ್ ಯಾವ್ದು ಹುಡುಕ್ತೀವಿ ಅದನ್ನ. ಅಂದರೆ ನಿಮ್ಮ ಆ ಆಟೋಮ್ಯಾಟಿಕ್ ಸ್ಪೀಚು ವಾಸ್ ಮಚ್ ಫಾಸ್ಟರ್ ದ್ಯಾನ್ ಯು ಥಿಂಕ್ ಅಂಡ್ ಪ್ರೊಡ್ಯೂಸ್ ದ ಸ್ಪೀಚ್. ಹಾಗಾದರೆ ಅನೀಶ್ ಸರ್ ಅಲ್ಲೋ ಒಂದು ಕಡೆ ಹೇಳಿದ್ರು, ಆರ್ಟ್ ಥೆರಪಿ ಬಗ್ಗೆ ಮಾತಾಡಿದ್ರು. ಅಲ್ಲೆಲ್ಲೋ ಒಂದು ಕಡೆ ಸಂಗೀತನೂ ಬಂದಿತ್ತೋ ಏನೋ ಗೊತ್ತಿಲ್ಲ. ಸೊ ಈ ಮ್ಯೂಸಿಕಲ್ ಮೆಲಡಿಕ್ ಪ್ಯಾಟರ್ನ್ಗಳನ್ನು ನಾವು ಯೂಸ್ ಮಾಡಿಕೊಂಡಾಗ ಮಾತನ್ನು ಸಾಕಷ್ಟು ಮಟ್ಟಿಗೆ ಅದಕ್ಕೆ ತರಬಹುದಾ ಸಾಧ್ಯತೆ ಇದೆ. ಇರಲಿ. ಸೊ ಇನ್ ಡಿಫಿಕಲ್ಟಿ ಇನ್ ಇನಿಷಿಯೇಟಿಂಗ್ ಸ್ಪೀಚ್, ರೆಡ್ಯೂಸ್ ಸ್ಪೀಚ್ ಆರ್ಟಿಕ್ಯುಲೇಟರಿ ಮೂವ್ಮೆಂಟ್ಸ್ ಆ್ಯಂಡ್ ಇಂಪ್ರಿಸೈಸ್ ಸ್ಪೀಚ್ ಆರ್ಟಿಕ್ಯುಲೇಷನ್. ನನಗೇನಾದರೂ ಬೇಕು ಅಂತ, ನೀರು ಬೇಕು ಅಂತ ಆ ವ್ಯಕ್ತಿ ಕೇಳಬೇಕು, ದಿಸ್ ಇಸ್ ದ ಪ್ರಾಬ್ಲಮ್ ಹಿ ವುಡ್ ಸೇ. what's happening here? Each sound of the word is not being articulated, and there's a co-articulatory effect. ಇನ್ನೊಂದು ಶಬ್ದದಿಂದ ಮತ್ತೊಂದು ಶಬ್ದಕ್ಕೆ ಹೋಗ್ಬೇಕಾದ್ರೆ ಆ ಜಾರುವಿಕೆ ಇದೆಯಲ್ಲ, ಆ ಜಾರುವಿಕೆ ಎರಡೂ ಶಬ್ದಗಳ ಮೇಲಿನ ಮೇಲೆ ನಿಂತ್ಕೊಂಡಿರುತ್ತೆ. ನೀರು ಅಂತ ಬಂದಾಗ ಬರೋ ಹೊತ್ತಿಗೆ ಈನು ಬಂದಿರುತ್ತೆ, ಊನು ಬಂದಿರುತ್ತೆ. ದಿಸ್ ಇಸ್ ದ ಕೋ-ಆರ್ಟಿಕ್ಯುಲೇಟರಿ ಎಫೆಕ್ಟ್. ಸೊ ಇದನ್ನೆಲ್ಲವನ್ನು ಅರ್ಥ ಮಾಡಿಕೊಂಡು ಸರಿಯಾದ ರೀತಿಯ ಕಾರ್ಯಕ್ರಮಗಳನ್ನ ರೂಪಿಸೋದೇ ಸ್ಪೀಚ್ ಪೆಥಾಲಜಿಸ್ಟ್ನ ಕೆಲಸ ಆಗಿರುತ್ತೆ. ಆ ಸ್ಪೀಚ್ ಥೆರಪಿಯ ವಾಕ್ ಥೆರಪಿಯ ಕೆಲಸ ಆಗುತ್ತೆ. ಸ್ವಾಲೋಯಿಂಗ್ ಡಿಫಿಕಲ್ಟೀಸ್ನಲ್ಲಿ ನುಂಗಿದ ಕೂಡಲೇ ಕೆಮ್ಮು ಬರ್ತಕ್ಕಂಥದ್ದು, ಸರಿಯಾದ ದೇಹದ ಭಂಗಿಗಳನ್ನು ಉಪಯೋಗಿಸ್ತಾ ಇರ್ತಕ್ಕಂಥದ್ದು, ನುಂಗುವಿಕೆಯ ವೇಗ ಹಾಕೊಂಡು ಅದಕ್ಕೇನು ಟೈಮೇ ತಗೊಳ್ಳೋದಿಲ್ಲ. ನಮ್ಮಲ್ಲಿ ಹೇಳ್ತಾರೆ ಅಗದು ತಿನ್ನು ಅಂತಂದರು. ನಮ್ಮ ಅಜ್ಜಿ ಬೈಗಳು 32 ಸಲ ಅಗಿಬೇಕು ನೀನು ಅನ್ನೋರು. ಅದೇ ಅಷ್ಟು ಸಲ ಅಗಿಂದ. ಅವಳು 6ನೇ ಕ್ಲಾಸ್ ಓದಿದ್ದು ಪಾಪ, ಬಟ್ ಶಿ ವಾಸ್ ಮಚ್ ಮೋರ್ ಹೈಯರ್ ಮೆಡಿಕಲ್ ಡಾಕ್ಟರ್ ದ್ಯಾನ್ ಎನಿ ಒನ್ ಆಫ್ ಅಸ್ ಹಿಯರ್ ಪ್ರಾಬಬಲಿ. ಕಾಲ್ದಾಗ ಕಾಲು ಹಾಕೊಂಡು ಕೂತ್ಕೊಂಡೆ ಸರಿಯಾಗಿ ಅಗದು ತಿನ್ನು ಅಂತ ಹೇಳೋಳು. ಆಮೇಲೆ ಅಗಿಯಲು ಮತ್ತು ನುಂಗಲು ಸೂಕ್ತವಾದ ಪ್ರಮಾಣವನ್ನು ಇಟ್ಟುಕೊಳ್ಳದೆ ಇರ್ತಕ್ಕಂಥದ್ದು, ತುಂಬ ಇಟ್ಕೊಂಡು ನುಂಗು ಪ್ರಯತ್ನ ಮಾಡೋದು, ಅಥವಾ ನುಂಗಬೇಕಾದಾಗ ಉಸಿರನ್ನು ಕೂಡ ಆಡಕ್ಕೆ ಪ್ರಯತ್ನ ಪಡ್ಕೊಳ್ಳೋದು. ಯಾರಾದರೂ ನೀವು ಉಸಿರಾಡೋಕ್ಕಾಗಲ್ಲ, ಬಿಕಾಸು ಆ ವಿಂಡ್ ಪೈಪ್ ಕ್ಲೋಸ್ ಆಗಲೇಬೇಕು. ಆ ಮುಡದೇನಾದ್ರು ಓಪನ್ ಆಗಿ ಕೂತ್ಕೊಂಡ್ರೆ ಒಳಗಡೆ ಲಂಗ್ಸ್ ಹೋಗುತ್ತೆ, ಆವಾಗಲೇ ಅದು ಕೆಮ್ಮು ಬರೋದು, ಆಸ್ಪಿರೇಷನ್ಸ್ ಆಗೋದು. ಸೊ ಸೇಫ್ ಸ್ವಾಲೋ ಟೆಕ್ನಿಕ್ಗಳು ಏನು ಅನ್ನೋದನ್ನು ಈ ಒಂದು ನಮ್ಮ ಪುನರ್ವಸತಿ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಹಾಕೊಳ್ತಕ್ಕದ್ದು. ಲಾಸ್ಟ್ ಅಫ್ಕೋರ್ಸ್ ಅರಿವಿನ ತೊಂದರೆಗಳು. ಇಫ್ ದರ್ ಆರ್ ಎಲಿಮೆಂಟ್ಸ್ ಆಫ್ ಡಿಮೆನ್ಷಿಯಾ, ಮೆಮೊರಿ ಡಿಸಾರ್ಡರ್ಸ್, ಸಲೈವ ಬಾಯಿನಲ್ಲಿ ಹಾಗೇ ಇರುತ್ತೆ, ಯು ವೋಂಟ್ ರಿಯಲೈಸ್ ಇಟ್. ದಟ್ ಮೀನ್ಸ್ ಇಟ್ಸ್ ನಥಿಂಗ್ ಟು ಡೂ ವಿತ್ ದಿ ಮಸಲ್ಸ್ ಹಿಯರ್, ಇಟ್ ಇಸ್ ದ ರಿಯಲೈಸೇಷನ್ ದಟ್ ಇಸ್ ನಾಟ್ ದೇರ್. ಸೊ ಅದನ್ನು ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕಾಗತ್ತೆ. ಆಸ್ ಎ ಥೆರಪಿಸ್ಟ್ ಐ ನೀಡ್ ಟು ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದೆಮ್, ವಾಟ್ ಆರ್ ಆಲ್ ದ ಫ್ಯಾಕ್ಟರ್ಸ್ ಆರ್ ಕಾಂಟ್ರಿಬ್ಯೂಟಿಂಗ್ ಟು ದ ಸ್ವಾಲೋಯಿಂಗ್ ಆರ್ ದ ಸ್ಪೀಚ್ ಡಿಸಾರ್ಡರ್ ಇನ್ ದಿಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಪರ್ಸನ್. ಸಾಮಾಜಿಕ ಶಿಷ್ಟಾಚಾರವನ್ನು ಪೂರೈಸೋದ್ರ ತೊಂದರೆಗಳು. ಸಾಮಾಜಿಕ ಶಿಷ್ಟಾಚಾರಗಳಿಂದ ಏನಾಗುತ್ತೆ, ಊಟ ಮಾಡ್ತಿರೋ ವ್ಯಕ್ತಿ ಊಟ ಮಾಡಿದಾಗ ಒಂದು ಚೂರು ರಸನೋ ಅನ್ನನೋ ಶರ್ಟ್ ಮೇಲೆ ಬಿದ್ದಾಗ ಎದುರುಗಡೆ ಕೂತಿರೋ ವ್ಯಕ್ತಿಗೆ ಹೇಗೆ ರಿಯಾಕ್ಟ್ ಮಾಡ್ಬೋದು? ಒಂದು ಮದುವೆ ಮನೆ, ಬಾಳೆ ಎಲೆ ಊಟ, ಈ ಮನುಷ್ಯ ತಿಂತಾ ಇದ್ದಾನೆ, ಸಾರು ಚೆಲ್ಲುತ್ತೆ, ಎದುರುಗಡೆ ಕೂತಿರೋನು ಅವ್ನಿಗೇನು ಗೊತ್ತಿರುತ್ತೆ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಇದೆ ಅಂತ. ಅವನಲ್ಲಿ ಆಗೋ ಮುಖದಲ್ಲಿ ವ್ಯತ್ಯಾಸಗಳು ಈ ಮನುಷ್ಯನ ಮೇಲೆ ಎಂತೆಲ್ಲ ಬದಲಾವಣೆಗಳನ್ನು ಬೀರ್ಬೋದು, ಎಂತೆಲ್ಲ ಪರಿಣಾಮಗಳನ್ನು ಬೀರ್ಬೋದು. So that person starts avoiding getting into the social interactions. So we need to understand all this, and we need to probably provide how best that you can maximize the situation and being better off in a social environment. Haganbit social environment cut ಮಾಡೋಕ್ಕಾಗಲ್ಲ, because social environment is very important for our communication and probably to keep our psychological this thing normal. They have some breathing issues. They use short breaths or holding breaths while attempting to speak. Say this, sir. What's happening here with your breath? So we know that now there's a problem in using the breath control. So we try to focus our therapy onto the breath control. ಸೊ ಚಿಕಿತ್ಸೆಯ ಗುರಿಗಳು ಇಂಪ್ರೂವಿಂಗ್ ದ ಬ್ರೀತಿಂಗ್ ಪ್ಯಾಟರ್ನ್. ಸೊ ಇದು ಟೆಕ್ನಿಕ್ಸ್ ಎಲ್ಲ ಅಂಥದ್ದು ಓದಕ್ಕೆ ಹೋಗಬೇಡಿ, 15 ನಿಮಿಷ ಬೆಲ್ ಹೊಡಿತಾರೆ ಈಗ ಅವರು. ಎನಿವೆ, ದೀಸ್ ಆರ್ ದ ಪ್ಯಾಟರ್ನ್ಸ್ ದಟ್ ವಿ ಕ್ಯಾನ್ ಯೂಸ್. ವಾಯ್ಸ್ ಎಕ್ಸಸೈಸಸ್ಗೆ ದರ್ ಆರ್ ಪ್ಯಾಟರ್ನ್ಸ್, ದರ್ ಆರ್ ಎಕ್ಸಸೈಸಸ್. ಪಿಚ್ ಬದಲಾವಣೆಗಳನ್ನು ಹೇಗೆ ಮಾಡ್ತಕ್ಕಂಥದ್ದು, ಪಿಚ್ ಬದಲಾವಣೆಗಿಂತ ಮುಂಚೆ ಪಿಚ್ ಐಡೆಂಟಿಫಿಕೇಶನ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು. ಅಂದರೆ ಏನು, low, high, low, high, high, low. So with pattern perception brain ಅಲ್ಲಿ ಆಗ್ತಾ ಇದೆಯಾ, ಡ್ಯೂರೇಷನ್ ಪ್ಯಾಟರ್ನ್ ಪರ್ಸೆಪ್ಷನ್ ಆಗುತ್ತಾ, ಲಾಂಗ್ ಶಾರ್ಟ್ ಲಾಂಗ್. These are temporal patterns. The brain has to, brain expert is there. ನಮಗೂ ಅವ್ರಿಗೊಂದು ಜೋಕ್ ಆಗ್ತಿರುತ್ತೆ, ಮೇಡಮ್ ನನ್ನ ಬ್ರೈನ್ ನಾನು ಖಂಡಿತ ಕೊಡಲ್ಲ ನಿಮಗೆ ಅಂತಂದರೆ ಅವ್ರು ಹೇಳ್ತಾರೆ ಏನೂ ಇಲ್ವಲ್ಲ ಸರ್ ಯಾಕೆ ಕೊಡ್ತೀರಾ ಅಂತ. ಗಂಟಲು ಧ್ವನಿ ಉತ್ಪಾದನೆ ಮತ್ತು ಅದನ್ನು ಭಾಳ ಹೊತ್ತು ಹಿಡಿದಿಟ್ಟಿದ್ದು. How long you can do that? Hard glottal closure, glottal attacks. ಯಾಕೆ ಅಲ್ಲಿ ಫೋರ್ಸ್ನೆಸ್ ಬಿಕಾಸ್ there is no closure of the vocal cord. ನುಗ್ಬೇಕಾದ್ರೆ ನಿಮಗೆ ನೆತ್ತಿ ಆಗುತ್ತದ್ದು, probably there is no good vocal cord closure, or the larynx is not rising up for the epiglottis to close down. ಅದು ಹೇಳ್ಬೇಕು ಮೇಲಕ್ಕೆ, ಅದಕ್ಕೆ ಎಪಿಗ್ಲಾಟಿಸ್ ಕೆಳಗೆ ಬರೋಕ್ಕಾಗಲ್ಲ, ಅದಲ್ಲೇ ನಿಂತ್ಕೊಂಡಿರುತ್ತೆ ಹಿಂಗೆ. ಇದು ಹೋಗಿ ಹಿಂಗೆ ನಿಂತ್ಕೊಂಡ್ರೆ ಅದು ಜಾಗ ಬಿಡುತ್ತೆ. ಅದು ಇದು ಹೇಳ್ಬೇಕು ಮೇಲಕ್ಕೆ. ಇದು ಹೇಳೋದಕ್ಕೆ ಏನು ಎಕ್ಸಸೈಸ್ ಇದೆ? ಮಲ್ಕೊಳ್ಳಿ, ದಿಂಬು ತೆಗೀರಿ, ಆರಾಮಾಗಿ ಇರಿ, ಎರಡು ಕಾಲನ್ನು ನಿಮ್ಮ ಎರಡು ಹೆಬ್ಬೆಟ್ಟನ್ನು ನೋಡಿದಿ, ತಲೆನ ನಿಧಾನಕ್ಕೆ ಮೇಲಕ್ಕೆ ಹೆಬ್ಬೆಟ್ಟನ್ನು ನೋಡ್ತಾ ಇರಿ. ಒಂದು 10 ಸಲ ಮಾಡಿ, ಒಂದೊಂದು ಸಲಿಗೆ ಆಟೋಮೆಟಿಕ್ಕಾಗಿ ಆ ಎಕ್ಸಸೈಸ್ ಬರ್ತಾ ಹೋಗುತ್ತೆ. Either hold the breath here and then produce a sound, or hold the breath. It's a glottal attack. ಇದನ್ನು ಎಲ್ಲರೂ ಎಲ್ಲವನ್ನೂ ಮಾಡೋಕ್ಕೆ ಹೋಗಬೇಡಿ, ನಾನು ಹೇಳಿದೆ ಅಂತ ಆಮೇಲೆ ಕೋರ್ಟಲ್ಲಿ ಕೇಸ್ ಹಾಕ್ಬಿಟ್ಟಿಲ್ಲ. ಇಟ್ಸ್ ಓನ್ಲಿ ವೆನ್ ವಿ ಸೇ ವಾಟ್ ಥಿಂಗ್ಸ್ ಟು ಬಿ ಡನ್, ರೈಟ್? ಓಕೆ, ಆಲ್ ದೋಸ್. ಇಲ್ಲೊಂದು DDK ಅಂತಿದೆ, ಶಬ್ದೋಚ್ಚಾರಣ ತಂತ್ರಗಳು. DDK ಅಂತ ನನಗೆ ಕಷ್ಟಪಟ್ಟು ಕನ್ನಡದಲ್ಲಿ ಟ್ರಾನ್ಸ್ಲೇಟ್ ಮಾಡಿದೆ ಇದನ್ನು. ನೆನ್ನೆ ರಾತ್ರಿ 12:15 ಕಣ್ಣು ಎಳಿತಾ ಇತ್ತು. ಪ್ರಶಾಂತನ ಕೇಳಿದ್ದೆ, ಸರ್ ಎರಡೂ ಮಾಡಿ ಸರ್ ಅಂತ ಪ್ರಶಾಂತ್. ಹೇಗಯ್ಯ ಮಾಡೋದಿತ್ತು ಅಂತ ನೆನ್ನೆ ರಾತ್ರಿ ತಲೆ ಕೆಡಿಸ್ಕೊಂಡು DDK ಅಂತ ಬರೆದಿದ್ದೀನಿ. ಕಾರಣ ಇಷ್ಟೇನೆ, ಇಟ್ಸ್ ಎ ಡೈಡೋಕೋಕಿನೆಟಿಕ್ ರೇಟ್ ಅಂತ ಅಷ್ಟೇ. ಹೌ ಫಾಸ್ಟ್ ದಟ್ ಯು ಕ್ಯಾನ್ ಡೂ ದಿಸ್ ರೇಟ್. ಇದಾ ಸೊ ಹಾಗೆ ಅಥವಾ ಪಟಕ 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 ಬಡಗ 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 ಪಟಕ ಬಡಗ ಪಟಕ ಬಡಗ ಪಟಕ ಬಡಗ. That's how that you have to exercise, so that the each sound that you produce you need to hear precisely articulate, get the speed to it. ಆ ರೇಟನ್ನು ಹೇಗೆ ಇಂಪ್ರೂವ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು. ಇಲ್ಲಿಂದ ಮುಂದೆ ಕನ್ನಡ ಮಾಡೋಕ್ಕಾಗಲಿಲ್ಲ, ದಯವಿಟ್ಟು ಕ್ಷಮಿಸ್ಬಿಡಿ, ನಿದ್ದೆಗೆ ಬಂದು ಹೋಗಿತ್ತು. ಹಾಗಾಗಿ ಇದಿಷ್ಟೇ ಇಂಗ್ಲೀಷ್ ಇದೊಂದು 3 ಸ್ಲೈಡ್ಸು. ಪ್ರಶಾಂತ್ ಬೈಕೋಬೇಡಪ್ಪ. ಪಾಸ್ಚುರಲ್ ಸ್ಟ್ರಾಟಜೀಸು ಏನಾದ್ರು ಮಾಡಿದ್ರೆ ಹಿಂಗೆ ಕೂತ್ಕೊಳ್ತಾನೆ, ಸ್ಟ್ರೈಟ್ ಇರಬೇಕಿದು. ನಾವು ಯಾವಾಗಲೂ ಇದು ಬುದ್ಧ ಪಾಸ್ಚರ್ ಅಂತೀವಿ. ಬುದ್ಧನ ಪಾಸ್ಚರು ಅಂದರೆ ಈಸಿ ಟು ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್. ಹೀಗೆ ಕೂತ್ಕೊಂಡ್ರೆ you get the respiration so beautifully because we have the thoracic support, diaphragmatic support. ಹಾಗೆ ರೆಸ್ಪಿರೇಷನ್ ತಗೋಬೇಕಾದ್ರೆ. ಸೊ you can probably go to yoga classes, they would teach you much better than me. But however, such postures are important. There are certain maneuvers like dynamic shaker, which I told you, lying down and raising the head is one of those. And there are many other such maneuvering exercises which you can adopt, which we will teach you to adopt, so that you will be able to swallow much better. ಇದನ್ನು ನಿಮ್ಗೆ ಈ ಥರದ್ದು ಇದೇ ಅಂತ ತೋರ್ಸೋಕ್ಕೆ ಸ್ಲೈಡ್ ಮಾಡಿದ್ದೇನೆ ಹೊರತುವೆ ಇದನ್ನೆಲ್ಲ ಮಾಡಬೇಕು ಅಂತಲ್ಲ. ಮಾಡಬೇಕಾದ್ರೆ ಅದನ್ನು ಸ್ಪೀಚ್ ಪೆಥಾಲಜಿಸ್ಟ್ ಹತ್ರ ಹೋಗಿ ಅವ್ರ ಹತ್ರ ಇವ್ಯಾಲ್ಯೂಯೇಟ್ ಮಾಡಿಸ್ಕೊಂಡು ನಂತರ ಅದನ್ನು ಮಾಡಿ. ಸೊ ಸಿಮಿಲರ್ಲಿ ಯು ಹ್ಯಾವ್ exercises to strengthen tongue and pharynx. Is a yawning exercise. Yawning ಅಲ್ಲಿ ಎಷ್ಟು ಅನುಕೂಲತೆಗಳಿದೆ. ಫಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ಲಿ ಗಾಳಿ ಚೆನ್ನಾಗಿ ಹೋಗುತ್ತೆ. ಸೊ ದ ಬ್ರೈನ್ ರಿಕ್ವೆಸ್ಟ್ ಆಕ್ಸಿಜನೇಷನ್ ಆ್ಯಂಡ್ ದಟ್ಸ್ ವೈ ಯು ಯಾನ್. ಎಲ್ಲರ ನಿದ್ದೆ ಮಾಡುತ್ತೆ, ಆ ನಿದ್ದೆ ಮಾಡ್ತಲ್ಲ ಅಂದ್ಬಿಟ್ಟು ದೊಡ್ಡ ಆಕಳಿಗೆ ಬಂದ ತಕ್ಷಣ ಮನೆಯೆಲ್ಲ ಬೈತಾರೆ, ನಿದ್ದೆ ಬರ್ತಿದೆಯಾ? ಯಾಕೆಂದರೆ brain is going to sleep because it's less oxygen there. So it wants more oxygen. And therefore you yawn and take more oxygen. Beautiful always. ಎಷ್ಟು ಚೆನ್ನಾಗಿದೆ ಸೈನ್ಸ್ ಇದು. ಅದೇ ಥರ ಎಫರ್ಟ್ಫುಲ್ ಸ್ವಾಲೋ. ಅದೇ ಥರ ಲೈಕ್ hold the tongue and swallow. Or resistive tongue exercises, Manderson exercise. There are so many other methods of swallowing to improve upon these swallowing functions. So probably you can use such things. There are exercises for tongue, the movement, lateral movement, lifting, rotating, inside, outside. So you basically ಈ ಎಲ್ಲ ಪೋರ್ಷನ್ ನಾವೇನು ಮಾತಾಡ್ತಾ ಇದ್ದೀವಿ ಇವಾಗ, ಈ ಎಲ್ಲ ಭಾಗವು ಮಾತಿಗೆ ಅಂತ ಭಗವಂತ ದೇವರಾಣೆ ಕೊಡಲಿಲ್ಲ. ಯಾತಿಗೆ ಕೊಟ್ಟ? ಬದುಕು ಕೊಟ್ಟ. ತಿನ್ನು, ಚೆನ್ನಾಗಿರು. ಅಂದರೆ ಮಾತು is a secondary function, it's a overlaid function of the primary function of the whole thing, system here. ಬುದ್ಧಿವಂತ ಮೆದುಳು ಕಲ್ತ್ಕೊಂತು, ಅದನ್ನು ಕಲ್ತ್ಕೊಂಡು ಲಕ್ಷಾಂತರ ಭಾಷೆಗಳನ್ನು ಉಪಯೋಗಿಸುವಷ್ಟರ ಮಟ್ಟಿಗೆ, ಆ ಭಾಷೆಯಿಂದ ಬರವಣಿಗೆನೂ ಮಾಡಿಸೋಕ್ಕಿಂತಿಗೆ, ಭಾಷೆ ಇಲ್ಲದೇ ಕಮ್ಯುನಿಕೇಟ್ ಮಾಡೋ, ಮಾತಿಲ್ಲದೆ ಕಮ್ಯುನಿಕೇಟ್ ಮಾಡ್ತಕ್ಕಂಥ ಸೈನ್ ಲ್ಯಾಂಗ್ವೇಜ್ಗಳ ಮಟ್ಟಿಗೆ ನಮ್ಮ ಸಿಸ್ಟಮನ್ನು ನಾವು ಬೆಳೆಸ್ಕೊಂಡಿದ್ದೀವಿ. ಬಿಫೋರ್ ದ ನೆಕ್ಸ್ಟ್ ಬೆಲ್ ರಿಂಗ್ಸ್, ದ ಲಿಪ್ ಎಕ್ಸಸೈಸಸ್, ಫೇಶಿಯಲ್ ಎಕ್ಸಸೈಸಸ್, ಇದೆಲ್ಲವೂ ಎಕ್ಸಸೈಸ್ ಫಾರ್ ಸಕ್ಕಿಂಗಾರು ಆಗ್ಬೋದು, ಬ್ಲೋಯಿಂಗಿಗಾರು ಆಗ್ಬೋದು, ಪಕರ್ ಎಕ್ಸಸೈಸ್ ಬೇಕಾದ್ರೂ ಆಗ್ಬೋದು. ಜಸ್ಟ್ ಟು ಗಿವ್, ಪ್ರತಿಯೊಂದು ಶಬ್ದಕ್ಕೂ ತನ್ನದೇ ಆದ ರೀತಿಯಲ್ಲಿ ಶಬ್ದ ಉಚ್ಚಾರಣೆ ಆಗುತ್ತೆ. ಭಾ ಆಗಬೇಕಾದಾಗ ಎಷ್ಟು ಅಮೌಂಟ್ ಆಫ್ ಏರ್ ಯು ಶುಡ್ ಹೋಲ್ಡ್ ಟು ಪ್ರೊಡ್ಯೂಸ್ ಭಾ. ಟು ಪ್ರೊಡ್ಯೂಸ್ ಭಾ, should you vocalize here, should you produce sound here or not? I don't produce a sound here. Bha, a. Bha, I produce it here. There's a sound already generated. For pa, there's no sound generation at all. ಆ ಸೈನ್ಸನ್ನು ಅರ್ಥ ಮಾಡಿಕೊಂಡು we need to develop the therapeutic procedures here. ಯಾಕೆ ನಾನು ಸೈನ್ಸ್ ಬಗ್ಗೆ 10 ಸಲ ಹೇಳ್ತಾ ಇದ್ದೀನಿ ಅಂದರೆ, ಸಾಮಾನ್ಯವಾಗಿ ಥೆರಪಿಗೆ ಅಂತ ಬಂದವರು ಟೀಚರ್ ಪಾಠ ಹೇಳ್ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ನಮ್ಮ ತಂದೆಗೆ, ನಮ್ಮ ತಾಯಿನ ಟೀಚರ್ ಹತ್ರ ಕರ್ಕೊಂಡು ಹೋಗ್ತೀವಿ, ಪಾಠ ಹೇಳಿಸ್ಕೊಂಡು. ಪಾಠ ಅಲ್ಲ ಇದು. ಅದಕ್ಕೆ ನಾನು ಸಾಮಾನ್ಯವಾಗಿ ಅದನ್ನು ಸ್ಪೀಚ್ ಥೆರಪಿಸ್ಟ್ ಅಂತ ಅಂದ ತಕ್ಷಣ ಹೇಳ್ತೀವಿ, ಸ್ಪೀಚ್ ಪೆಥಾಲಜಿಸ್ಟ್ ಅಂತ ಹೇಳಿ. ಯಾಕೆ ಅಂದರೆ ಪೆಥಾಲಜಿನ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ದೆ ಹೋದರೆ ನೀವೇನು ಥೆರಪಿ ಕೊಡೋಕ್ಕೆ ಸಾಧ್ಯ ಇದೆ. ಸೊ ಯು ಗಾಟ್ ಟು ಗಿವ್ ಥೆರಪಿ ಬೈ ನೋಯಿಂಗ್ ದ ಪೆಥಾಲಜಿ ಆಫ್ ಸ್ಪೀಚ್. ಒಂದ್ಸಲ ಐ ಹ್ಯಾಡ್ ಎ ಡಿಸ್ಕಷನ್ ವಿತ್ ಒನ್ ಆಫ್ ಮೈ ಡೈರೆಕ್ಟರ್ once. How can you call as a speech pathologist when we have pathologist means Anita, Mahadevan? So how can you be speech pathologist? Madam, pathology does not mean that you should read a specimen. Anything pathological is pathological. Your behavior is a pathological one, so you can say pathological behavior. That's it. So, anyway, ಪ್ರಮುಖವಾಗಿ, ಮುಖ್ಯವಾಗಿ ವ್ಯಕ್ತಿಯ ಸಹಕಾರ, ದ ಇಂಡಿವಿಜುವಲ್ ಕೋಆಪರೇಷನ್, ಪೇಷಂಟ್ಸ್ ಕೋಆಪರೇಷನ್, ಫ್ಯಾಮಿಲಿ ಸಪೋರ್ಟ್, ಫ್ಯಾಮಿಲಿ ಕೋಆಪರೇಷನ್, ಸೋಷಿಯಲ್ ಸಪೋರ್ಟ್, ಸೋಷಿಯಲ್ ಸಮಾಜದ ವ್ಯಕ್ತಿಗಳು ಮಾಡ್ತಕ್ಕಂಥ ಸಹಕಾರ ಹಾಗೂ ನಿರಂತರ ಪ್ರಯತ್ನ. ಯು ಗಾಟ್ ಟು ಡೂ ದಿಸ್. ದೇರ್ ಇಸ್ ನೋ ಅದರ್ ಆಲ್ಟರ್ನೇಟಿವ್. ಅಕ್ಸೆಪ್ಟ್ ಆ್ಯಂಡ್ ಗೋ ಹೆಡ್ ಆ್ಯಂಡ್ ಸ್ಟಾರ್ಟ್ ಡೂಯಿಂಗ್ ಇಟ್. ಪ್ರಯತ್ನ ಪಡದೆ ಹೋದರೆ ಸಾಧ್ಯನೇ ಇಲ್ಲ. ಸೊ ನಾನು ಫಸ್ಟ್ ಅವ್ರನ್ನ ಕೇಳ್ತೇನೆ, ನೀವು ಯಾವ ಭಾಷೆ ಮಾತಾಡೋದು ಅಂತ. ಕನ್ನಡನೋ ಅಂತೇನೋ ಹೇಳ್ತಾರೆ, ಹಿಂದಿನೋ ಹೇಳ್ತಾರೆ. ಹಿಂದಿನ ಐ ಆಮ್ ಸೋ ಸಾರಿ, ನನಗೆ ಹಿಂದಿ ಬರಲ್ಲ, ಮೇರಾ ಹಿಂದಿ ಬಹುತ್ ಖರಾಬ್ है, हिंदी में मैं नहीं बात कर सकता हूँ. हाँ साहब, तुम अच्छा ना माता, आप अच्छे से बात करना. ना ये बात अच्छा नहीं है, तुम्हारा आपका बात बहुत अच्छा है. सो आप जैसे बात कर रहे हैं वैसे मैं बात करने के लिए क्या करना है? साहब आप सीखना है. क्यों? कोई मेडिसिन नहीं है क्या? हिंदी को ट्याब्लेट, इंग्लिश को क्याप्सूल, कन्नड़ को ಟಾನಿಕ್, दड़ा ಎಲ್ಲರೂ ಮಾತಾಡ್ಬಿಡ್ಬೋದು. So आप सीखना है तो you have to सीखना है. You have to learn. The brain has to learn and the brain will execute it. Once you make the brain to learn, it will help you. If you do not make the brain to learn, it will never help you. That I thank Prashant for giving me this opportunity to be here. I think I am well within the time limits to allow Anita to come over to the stage. Thank you so much. Thank you.
Thank you, sir. That was a very useful talk. If there are any questions, we can take one or two. ಕನ್ನಡದಲ್ಲಿ ಕೇಳೋರು ಯಾರಾದರೂ ಇದ್ರೆ ಕೇಳ್ಬೋದು.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಡಾಕ್ಟ್ರೆ, ಒಂದು ಅಬ್ಸರ್ವೇಷನ್ ನಾನು ಮಾಡಿದ್ದೀನಿ. ಏನಂದರೆ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಪೇಷಂಟ್ಸು ಊಟ ಚೆನ್ನಾಗಿ ಮಾಡ್ತಾರೆ, ಎಲ್ಲನೂ ಮಾಡ್ತಾರೆ. ವೈ ಟೇಕಿಂಗ್ ದ ಟ್ಯಾಬ್ಲೆಟ್, ವೆನ್ ಇಟ್ ಈಸ್ ಹಾಫ್ ಟ್ಯಾಬ್ಲೆಟ್ ಆರ್ ಫುಲ್ ಟ್ಯಾಬ್ಲೆಟ್, ಸಮ್ಟೈಮ್ಸ್ ಹಿ ಆರ್ ಶಿ ಫೀಲ್ಸ್ ಅದು ಗಂಟಲಲ್ಲಿ ಕಟ್ಕೊಂಬಿಟ್ಟಿದೆ ಅಂತ ಹೇಳ್ತಾರೆ. ನೀವು ಹೇಳಿದ್ರೆ ಹೀಗೆ ಬಗ್ಗಿ ಊಟ ಮಾಡಬೇಕಾದ್ರೆ ಬಗ್ಗಿ ಮಾಡಿ ಅಂತ ಹೇಳಿದಾಗ ಮಾತ್ರನ ನಾವು ಯಾಕೆ ಹಾಕ್ಕೊಳ್ಬಾರ್ದು? ಅಥವಾ ಅವ್ರಿಗೆ ಆ ಫೀಲಿಂಗ್ಸ್, ಸೈಕಲಾಜಿಕಲ್ ಫೀಲಿಂಗ್ಸ್ ಇದೆಯಾ? ಸೈಕಲಾಜಿಕಲ್ ಫೀಲಿಂಗ್ಸ್ ಆರ್ ದೇರ್ ಆರ್ they are fearing for that to take the tablets. And one more thing, while you said speeching and all those things, that is natural. I have also seen that methodism. Suppose there is no teeth for the patient and he want to talk, how do you feel it, whether he is correct or not?
ಪೇಷಂಟ್ಸ್ ಯಾವತ್ತೂ ಕರೆಕ್ಟೇ, ನಾವೇ ತಪ್ಪು. ನಾವೇ ತಪ್ಪು. ಯಾಕೆಂದರೆ ಅವರನ್ನು ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋ ಯೋಗ್ಯತೆ ನಮ್ಗೆ ಇನ್ನೂ ಬರಬೇಕಾಗತ್ತೆ. ನಾವು ಬರೀ ಪುಸ್ತಕದಲ್ಲಿ ನೋಡ್ಕೊಂಡು ಬಂದು,
ದಟ್ ಮೀನ್ಸ್ ಅನುಭವದ ಮುಖಾಂತರ ಅನ್ವೇಷಣೆ.
ಅನುಭವನೇ ಬಹಳ ಮುಖ್ಯ. ನೀವು ಈಗ ಉಗುಳು ನುಂಗಿಲ್ಲ, ನಿಮ್ಗೊಂದು ಟ್ಯಾಬ್ಲೆಟ್ ಕೊಡ್ತೀನಿ ನುಂಗಿ, ಅಂಟ್ಕೊಳ್ಳುತ್ತೋ ಇಲ್ವೋ ಹೇಳಿ? ಅಂಟ್ಕೊಳ್ಳುತ್ತೆ. ನೀರು ಕೊಡಲ್ಲ ನಿಮಗೆ. ಉಗುಳು ನುಂಗ್ಬಿಡಿ ಫಸ್ಟು, ಆಮೇಲೆ ಟ್ಯಾಬ್ಲೆಟ್ ಕೊಡ್ತೀನಿ, ನುಂಗಿ ಅಂತೀನಿ. ನುಂಗೋದು ಅದೆಲ್ಲ ಹೋಗಿ ಗಂಟ್ಲ ಹತ್ರ ಅಂದ್ಕೊಳ್ಳಿ, ಆ ಸಾರ ಅಂದ್ಕೊಂಬಿಟ್ಟಿದೆ. ಸರಿ, ನ್ಯಾಚುರಲಿ ಸ್ಟಿಕ್ಕಿ ನೇಚರ್ ಅದು. ಹಾಗಾದ್ರೆ ಏನು ಮಾಡಬೇಕು? ಹೈಡ್ರೇಟ್ ಮಾಡಿ ಫಸ್ಟು.
ಟ್ಯಾಬ್ಲೆಟ್
ಫಸ್ಟ್ ಓವರಲ್ ಹೈಡ್ರೇಷನ್. ಒಂದು ತೊಟ್ಟೆ ನೀರು ಕುಡೀರಿ, ಸ್ವಲ್ಪ ಒದ್ದೆ ಆಗಲಿ, ವೆಟ್ನೆಸ್ ಬರಲಿ. ಆಮೇಲೆ ಟ್ಯಾಬ್ಲೆಟ್ ತೊಗೊಳ್ಳಿ, ಆಮೇಲೆ ನೀರು ಕುಡೀರಿ. ಕುಡಿದು ಬಗ್ಗೆ ಹೋಗುತ್ತೆ. ಒಂದಾಗಲಿಲ್ವೋ ಅರ್ಧ ಮಾಡಿ, ಅರ್ಧ ಫಸ್ಟ್ ತೊಗೊಳ್ಳಿ, ಆಮೇಲೆ ಇನ್ನೊಂದು ಅರ್ಧ ತೊಗೊಳ್ಳಿ. ಸೊ ಇಟ್ ಈಸ್ ಅದೇನಾಗುತ್ತೆ ಅಂದರೆ ಸೂಪರ್ವೈಸ್ ಮಾಡ್ತಾ 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 ದೆನ್ ವಿ ಕ್ಯಾನ್ ಪ್ರಾಬ್ಲಿ ಕಮ್ ಟು ಅನ್ ಆಪ್ಟಿಮಮ್ ಲೆವೆಲ್ ಆಫ್ ಸ್ವಾಲೋ. ಹೇಗೆ ಮಾಡ್ಬೋದು ಅನ್ನೋದು. ಬಟ್ ದೀಸ್ ಆರ್ ದ ಮೆಥಡ್ ವಿಚ್ ಕ್ಯಾನ್ ಬಿ ಅಡಾಪ್ಟೆಡ್. ಸೊ ಅದರಿಂದ ನಾನು ಒಂದು ಹೇಳೋದು ಮತ್ತೆ ಅಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ ಸ್ಲೈಡಲ್ಲಿ ಇತ್ತಲ್ಲ ಗೊತ್ತಿಲ್ಲ, ರೀಹೈಡ್ರೇಷನ್ ಆ್ಯಂಡ್ ರೀಹೈಡ್ರೇಷನ್. ನಾನು ಒಂದು ಬಾಟ್ಲ್ ನೀರು ಕುಡಿದೆ. ಬಿಕಾಸ್ ಆಸ್ ಯು ಸ್ಪೀಕ್, ನಿಮ್ಮ ಮಾತಿನ ಜೊತೆಗೆ ಗಾಳಿನೂ ಹೊರಗೆ ಬರೋದ್ರಿಂದ ಇದ್ದು ಬಂದು ವೆಟ್ನೆಸ್ ಅಷ್ಟು ಹೊರಗೆ ಬಂದು ಹೋಗಿರುತ್ತೆ ಆಕಾಶಕ್ಕೆ.
ಅದು ಎಲ್ರಿಗೂ ಆಗುತ್ತೋ?
ಎಲ್ರಿಗೂ, ನನಗೂ ಆಗುತ್ತೆ. ಸೊ ಆಲ್ ಆಫ್ ಅಸ್ ಶುಡ್ ರೀಹೈಡ್ರೇಟ್, ಪರ್ಟಿಕ್ಯುಲರ್ಲಿ ಆಸ್ ವಿ ಏಜ್.
ಓನ್ಲಿ ಫಾರ್ ಟ್ಯಾಬ್ಲೆಟ್ಸ್
ಅಲ್ಲಲ್ಲ, ಟ್ಯಾಬ್ಲೆಟ್ಸಿಗೆ ಸರಿ, ಬಟ್ ಅದರ್ವೈಸ್ ರೀಹೈಡ್ರೇಷನ್ ಈಸ್ ಗುಡ್ ಫಾರ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್. ಎಸ್,
ಥ್ಯಾಂಕ್ ಯು.
I don't understand Kannada. When you were talking, I felt as if I was listening every word of it.
Oh, thank you, sir. Thank you.
ಹಲೋ. ಮಾತ್ರೆ ತಗೊಳ್ಳೋದ್ರೊಳಗೆ ಥರ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಅದು. ಫಸ್ಟ್ ತಗೊಳ್ಳೋವಾಗ ಸಿಕ್ಕಾಕೊಳುತ್ತೆ, ಹಿಂಗೋಕ್ಕಾಗಲ್ಲ ಅಂತ. ಅದನ್ನೇ ಸೇಮ್ ನಮ್ಮ ಡಾಕ್ಟ್ರು ಪ್ರಶಾಂತ್ ಅವರು ನಮಗೆ ಒಂದ್ಸತಿ ಹೇಳಿದ್ರು, ನಿಮಗೆ ಪ್ರಾಬ್ಲಮ್ ಆಯಿತು ಅಂದರೆ ತಕ್ಷಣ ಅರ್ಧ ಟ್ಯಾಬ್ಲೆಟ್ ಕಡಿದ್ಬಿಟ್ಟು ನೀರು ಹಾಕೊಂಡು ಕುಡಿದ್ಬಿಡಿ. ಬಟ್ ದಿ ಸೇಮ್ ಐ ಫಾಲೋ ಸರ್ಟನ್ ಟೈಮ್ಸ್. ಬಟ್ ದಿ ಬೆಸ್ಟ್ ಥಿಂಗ್ ಈಸ್ ವೆನ್ ಐ ಗೆಟ್ ಅಪ್ ಇನ್ ದಿ ಮಾರ್ನಿಂಗ್, ಐ ಟೇಕ್ ದಿ ಟ್ಯಾಬ್ಲೆಟ್, ಬಟ್ ಐ ಬಿಕಮ್ ವೆರಿ ಫ್ರೆಶ್ ಇನ್ ಫ್ಯೂ ಮಿನಿಟ್ಸ್, like a baby. So this is the experience that I want to share with all.
Very nice, very nice, sir.
And the day I feel, see now I was not feeling well for the last half an hour, but now I am very fit to speak.
Very good, sir. That's what.
So the experiences that I would like to say, you have to be active all the way, 24/7. Your mind should be active.
Correct. Correct.
Even in your dreams, you should remember the dreams. And while taking the tablets also, you should know, not put in a box, morning, night, afternoon. You should remember what you are taking.
Sure.
Then you take that one, it will be, you will definitely keep your mind very active, brain.
Very nice. Dr. Prashant ಅವರು
I'm following Prashant for the past 10 years.
ಅದಕ್ಕೆ ಪ್ರಶಾಂತ್ ಕಚ್ಬಿಟ್ಟು ನುಂಗಿ ಅಂದ್ರು. ಅವ್ರ ಅಮ್ಮ ಬೈದಿರ್ತಾರೆ, ಕಚ್ಬಿಟ್ಟು ನುಂಗಲ್ಲ ಅಂತ.
ಇಲ್ಲ, ಅವ್ರು ಹೇಳಿದ್ರು.
ಅದೇ ನಮ್ಮ ಅಪ್ಪ ಅಮ್ಮಂದ್ರೆ ಏನೇನು ಹೇಳ್ಕೊಟ್ಟಿರ್ತಾರೆ ಸ್ವಲ್ಪ ಯೋಚನೆ ಮಾಡಿ ಸೈನ್ಸ್ ಉಪಯೋಗಿಸ್ಬಿಟ್ರೆ ಅಲ್ಲಿ ಎಲ್ಲವೂ ಹೆಚ್ಚು ಕಡಿಮೆ ಸಾಲ್ವ್ ಆಗುತ್ತೆ. ಬೆಳಗ್ಗೆ ಎದ್ದ ತಕ್ಷಣ ನಾನು ತುಂಬ ಖುಷಿಯಾಗಿರ್ತೀನಿ, ಟ್ಯಾಬ್ಲೆಟ್ ತೊಗೊಂಡು ತುಂಬ ಲೈವ್ಲಿ ಆಗಿರ್ತೀನಿ. ನಮ್ಮ ಮಮ್ಮಿ ಹೇಳ್ತಿದ್ಲು, ರಾತ್ರಿ ಹೊತ್ತು ಓದಬೇಡ, ಬೆಳಗ್ಗೆ ಎದ್ದು ಓದು. ಕೇಳ್ತಿರ್ಲಿಲ್ಲ, ರಾತ್ರಿನೇ ಓದಬೇಕು. ಹೌದಾ? ಬೆಳಗ್ಗೆ ಎದ್ದು ಓದು, ಚೆನ್ನಾಗಿ ಅರ್ಥ ಆಗುತ್ತೆ. ದಟ್ಸ್ ಅನ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಅವಳೇನು ಪಾಪ MBBS ಮಾಡಲಿಲ್ಲ, ಏನೋ SLC ಮಾಡಿದ್ರು ಏನೋ ಪಾಪ ನನ್ನ ಅಮ್ಮ. ಅಲ್ಲ, ಕರೆಕ್ಟ್. ದಿ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇದೆಯಲ್ಲ, ದ್ಯಾಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ದೆನ್ ಎನಿಥಿಂಗ್ ಎಲ್ಸ್. ಆಮೇಲೆ ಜೊತೆಗೆ ಸ್ಪೀಚ್ ಥೆರಪಿಸ್ಟ್ ಬೇಕಾಗಿಲ್ಲ, ನೀವೇ ಯು ವಿಲ್ ಫೈಂಡ್ ದ ವೇ. You will try to, because brain is so intelligent, it finds its own way of dealing it. So it does it. ಎಲ್ಲೋ ಒಂದು ನಾವು ಕ್ಯಾಟಲಿಸ್ಟ್ ಆಗಿ ಒಂಚೂರು ಬರಬೇಕಷ್ಟೇ ಹೊರತದೆ. ಅದರ್ವೈಸ್ ಯುವರ್ ಬ್ರೈನ್ ಡಸ್ ಇಟ್, ಯುವರ್ ಬ್ರೈನ್ ವಿಲ್ ಲೊಕೇಟ್ ಇಟ್, ಯುವರ್ ಬ್ರೈನ್ ವಿಲ್ ಫೈಂಡ್ ಇಟ್. ಓಕೆ. ಎಸ್. ಸಫರಿಂಗ್ ಅಂತ ಐಡಿಯಾ ಸೈಕಲಾಜಿಕಲ್ ಫೀಲಿಂಗ್. ಯಾಕೆ ಐ ಆಮ್ ಸಫರಿಂಗ್ ಫ್ರಮ್ ಫೈನಾನ್ಷಿಯಲ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಕೇಳ್ಬಿಟ್ಟು ನಾನು ಐ ಆಮ್ ಸಫರಿಂಗ್ ಫ್ರಮ್ ಫೈನಾನ್ಷಿಯಲ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಹೇಳಿ ಕೊಡ್ತಾರ ದುಡ್ಡು? ಇಲ್ಲ, ಇಲ್ಲ ಅಂತ ಹೇಳ್ಬಿಟ್ರು. ಅನಿತಾ ಯಾಕೆ ಹಾಗೆ ಹೇಳಿದೆ ಅಂತಂದರೆ ಆದಷ್ಟು ನೆಗೆಟಿವ್ ಕಾನ್ನೋಟೇಷನ್ಸ್ ಇರ್ತಕ್ಕಂಥದ್ದನ್ನು ಉಪಯೋಗಿಸೋದು ಬೇಡ. ಸೊ ಹೆಲ್ತಿ ಅಟ್ಮಾಸ್ಫಿಯರ್ ಡೆವಲಪ್ ಮಾಡಿ ಅಷ್ಟೇ.
ಸರ್ ನಮಸ್ಕಾರ.
ಓಕೆ, ಜಸ್ಟ್ ಒಂದೇ ಒಂದು ಕ್ವೆಶನು, ಮಿಕ್ಕಿದ ಕ್ವೆಶನ್ಸ್ ಎಲ್ಲ ಕ್ವೆಶನ್ ಆನ್ಸರ್ಸ್ ಅಲ್ಲಿ ಕೇಳಿಸ್ಕೊಂಡು.
ಸರ್ ನನ್ನ ಮಗನಿಗೆ 18 ವರ್ಷದಿಂದ ಪಾರ್ಕಿನ್ಸನ್ ಬಂದಿದೆ. ಇವಾಗ 10 ವರ್ಷದಿಂದ ಡಾಕ್ಟರ್ ಪ್ರಶಾಂತ್ ಅವ್ರ ಹತ್ರ ತೋರಿಸ್ತಾ ಇದ್ದೀನಿ. ಅವ್ನು ಲೈಫ್ ಲಾಂಗ್ ಅದು ಇರುತ್ತಾ?
ಅವರೇ ಇದ್ದಾರೆ ನೋಡಿ, ಕೇಳಿ. ಅಮ್ಮ, ಈ ಕೆಲವು ಕಂಡೀಷನ್ಸ್ ಅಷ್ಟೇ. ಅದು ಅದನ್ನು ಎಷ್ಟರ ಮಟ್ಟಿಗೆ ನಾವು ಹದ ಮಾಡಿಕೊಳ್ಳಬಹುದು, ಅದನ್ನು ಎಷ್ಟರ ಮಟ್ಟಿಗೆ ಇಟ್ಟುಕೊಂಡು ಒಪ್ಪಿಕೊಂಡು ಅದನ್ನು ಅಳವಡಿಸ್ಕೊಳ್ಬಹುದು. ತಲೆ ಕೆಡಿಸ್ಕೋಬೇಡಿ, ಲೈಫ್ ಲಾಂಗ್ ಇರತ್ತೆ. ನಮಗೆ ಗೊತ್ತಿಲ್ಲ ಲೈಫ್ ಏನು, ಲಾಂಗ್ ಎಲ್ಲಿಂದ ಬಂತು, ಅದು ಎಷ್ಟು ಲಾಂಗ್ ಅಂತ ಗೊತ್ತಿಲ್ವಲ್ಲ ತಾಯಿ. ಪೋಸ್ಟ್ ಆಫೀಸ್ಗೆ ಹೋಗಿದ್ದೆ ಮೊನ್ನೆ. 70-80 ವರ್ಷದ ಒಬ್ಬ ವ್ಯಕ್ತಿ ಆಕೆ ಬಂದರು. ಶಿ ಈಸ್ ಎ ವಿಡೋ. ನಾವೆಲ್ಲ ಪುಟ್ ಪೋಸ್ಟ್ ನಿಂತಿದ್ದೀನಿ. ಜಾಗ ಬಿಡಿ ಅಂತ ಕೇಳಿ ಕೌಂಟ್ರಿಗೆ ಹೋಗಬೇಕಾಗಿತ್ತು ಆಕೆ. ನಾನು ಸ್ವಲ್ಪ ಜಾಗ ಬಿಟ್ಟು ಆಯ್ತಮ್ಮ ಹೋಗಿ, ಥಿಂಕಿಂಗ್ ನಾನು ಅವ್ರಿಗಿಂತ ಹೆಂಗಾಗಿದ್ದೀನಿ, ನಾನೇನು ಹೆಂಗಲ್ಲ. ಆಕೆ ಹೋಗ್ಬಿಟ್ಟು ಕೊಟ್ಟರು. ಅಡ್ರೆಸ್ ಏನಮ್ಮ ಅಂತ ಆ ಕ್ಲರ್ಕ್ ಕೇಳಿದ್ರು. ಯಾವ ಅಡ್ರೆಸ್ಸು ತಾಯಿ? ಈಕೆ ಅಲ್ಲಮ್ಮ ನಿಮ್ಮನೆ ಅಡ್ರೆಸ್ಸಾ? ಹಂಗೆ ಕೇಳಿ. ಮನೆ ಅಡ್ರೆಸ್ ಅಂತ ಕೇಳಿದ್ರೆ ಅಡ್ರೆಸ್ ಅಂತ ಕೇಳಿದ್ರೆ ನನಗೇನಮ್ಮ ಗೊತ್ತು, ಅವನು ಕಳಿಸೇನೆ ನಾನು ಬಂದಿದ್ದೀನಿ, ಅವನು ಯಾವ ಅಡ್ರೆಸ್ ಕೊಡ್ತಾನೆ ಹೋಗ್ತಿರ್ತೇನೆ, ನನಗೆ ಗೊತ್ತಿಲ್ಲ. ನಿಮ್ಮ ಮನೆ ಅಡ್ರೆಸ್ ಅಂತ ಕೇಳೋದು ನಾನು ಕೊಡ್ತೀನಿ. ನಾನು ಆ ತಾಯಿ ಕೈ ಮುಗಿದು ಇಂಥ ಬ್ಯೂಟಿಫುಲ್ಲಾಗಿ ಫಿಲಾಸಫಿ ಕೊಟ್ರಿ ಮೇಡಮ್ ನೀವು. ಹೌದು ಸರ್, ಎಲ್ಲರೂ ಕೇಳ್ತಾರೆ ನಿನ್ನ ಅಡ್ರೆಸ್ ಏನು, ನೀನು ನನಗೇನು ಗೊತ್ತು ನನ್ನ ಅಡ್ರೆಸ್ಸು, ಗೊತ್ತಿಲ್ಲದೆ ಬಂದಿದ್ದೀನಿ, ಗೊತ್ತಿಲ್ಲದೆ ಹೋಗ್ತೀನಿ. ಅಲ್ಲ, ಜೋಕಿಂಗ್ಲಿ ಹೇಳಿದ್ದು.
ಇವಾಗಲೇ ನಡೆಯೋಕೆ ಆಗಲ್ಲ
ಆಗುತ್ತೆ. ಅದಕ್ಕೆ ಆದಷ್ಟು ಮಟ್ಟಿಗೆ ಎಕ್ಸಸೈಸ್ಗಳನ್ನ ಮಾಡಿಸ್ತಾನೇ ಇರಬೇಕು. ಅದೇ ನಿರಂತರ ಪ್ರಯತ್ನ. 1 ದಿನ 2 ದಿನ ಮಾಡಿ ಮಾಡ್ತಾನೆ ಇರಬೇಕಿದು ಅನ್ನುವಂತಹ ಸ್ಥಿತಿ ನಾವು ಹೋಗಬಾರದು. ಅದನ್ನು ಇಟ್ಟುಕೊಂಡು ಪ್ರಯತ್ನವನ್ನು ಮಾಡ್ತಾ ಇದ್ದರೆ ಸಾಕಷ್ಟು ಮಟ್ಟಿನ ಸುಧಾರಣೆಗಳನ್ನು ನಾವು ಕಾಣ್ತೀವಿ. ಆ ವ್ಯಕ್ತಿ ಒಬ್ಬ ಸೊಸೈಟಿಗೆ ಬೇಕಾದ ವ್ಯಕ್ತಿ ಅಂತ ಅವನಿಗೂ ಅನಿಸ್ತಾ ಹೋಗುತ್ತೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಪ್ರಯತ್ನ ಪಟ್ಟರೆ ಸಕ್ಸಸ್ ಇದ್ದೇ ಇರುತ್ತಮ್ಮ. ಹತಾಶರಾಗೋದು ಬೇಡ.
Thank you, sir. Thank you very much. As we are running short of time, we'll move on to our next talk.
Thank you so much. ಡಾಕ್ಟರ್ ಶಿವಶಂಕರ್ ಇವರು ನಮ್ಮ ಪೋಡಿಯಮನ್ನು ಒಂದು ಲೆವೆಲ್ ಮೇಲೆ ತೊಗೊಂಡ್ಬಂದ್ಬಿಟ್ಟಿದ್ದಾರೆ. ಸೊ ಅದರಿಂದ ನೆಕ್ಸ್ಟ್ ಸ್ಪೀಕರ್ ಭಾಳ ಕಷ್ಟ ಆಗ್ಬೋದು. ಸೊ ಐ ಆಮ್ ಸಾರಿ. ಸೊ ಡಾಕ್ಟರ್ ಶಿವಶಂಕರ್ ಬಗ್ಗೆ ನಾನು ಮತ್ತು ಇನ್ನೊಬ್ರು ಮಾತಾಡ್ಕೋತಾ ಇದ್ವಿ. ಅಂದರೆ ಕೆಲವರು ಮೇಷ್ಟ್ರುಗಳು ನೋಡಿ ಅವ್ರಿಗೆ ಗೊತ್ತಿರುತ್ತೆ, ತುಂಬ ನಾಲೆಡ್ಜ್ ಇರುತ್ತೆ, ಅದನ್ನು ಹೇಳಕ್ಕೆ ಬರುತ್ತೆ. ಕೆಲವ್ರಿಗೆ ಏನು ಗೊತ್ತಿಲ್ಲದ್ರು ನನ್ನಂಥವ್ರು ಬೇಕಾದಷ್ಟು ಮಾತಾಡ್ತೀವಿ, ಆದರೆ ಎರಡು ಒಟ್ಟಿಗೆ ಇರೋದು ತುಂಬ ಕಷ್ಟ ಅಂತ. ಕಾಳಿದಾಸ ಒಂದು ಶ್ಲೋಕ ಹೇಳಿದ್ದಾನೆ ಕೆಟ್ಟ. ಗೊತ್ತು ಕೆಮಿಸ್ಟ್ರಿ ಮೇಸ್ಟ್ರಲ್ಲ ಅವರು.
ಇವತ್ತು ನಮಗೆ ದೇಶಕಾಚಾರ
90 ವರ್ಷ ಮೊನ್ನೆ ಹೋಗ್ಬಿಟ್ಟಿರ್ತಾರೆ. ಸೊ ಇದು ಕಾಳಿದಾಸ ಒಂದು ಶ್ಲೋಕ ಹೇಳಿದ್ದಾನೆ, ಅಂದರೆ ಮತ್ತೆ ಶ್ಲೋಕದ ಬಗ್ಗೆ ಹೇಳ್ತೀನಿ. ಸೊ ಈ ಸರ್ತಿ ಸರಿ ಹೇಳ್ಬೋದು ಅಂತ ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ. ಸೊ ಶ್ಲಿಷ್ಟ ಕ್ರಿಯಾ ಕಸಚಿತ್ ಆತ್ಮಸಂಸ್ಥಾ ಅಂದರೆ ಕೆಲವ್ರಿಗೆ ಚೆನ್ನಾಗಿ ಗೊತ್ತಿರುತ್ತೆ ವಿಷಯನ. ಸಂಕ್ರಾಂತಿ ರನ್ನಿಸ ವಿಶೇಷ ಯುಕ್ತ ಅಂತ ಅಂದರೆ ಕೆಲವರು ಮಾತಾಡೋಕ್ಕೆ ಇನ್ನೊಬ್ರು ಆರ್ಟಿಕಲ್ ಆಕ್ಷನ್ ತುಂಬ ಚೆನ್ನಾಗಿ ಬರುತ್ತೆ. ಆದರೆ ಎಸ್ಯೋ ಭಯಂ ಸಾಧು ಸ ಶಿಕ್ಷಕ ನಮ್ಮ ಧುರಿ ಪ್ರತಿಷ್ಠಾಪಿತವ್ಯವ ಅಂತ ಅಂದರೆ ಯಾರಲ್ಲಿ ಎರಡು ಇದೆ. ಎಸ್ಯೋ ಭಯಂ ಸಾಧು ಕರೆಕ್ಟ್. ಎಸ್ಯೋ ಭಯಂ ಸಾಧು ಸಹ ಏನು ಸರ್? ಎಸ್ಯೋ ಭಯಂ ಉಭಯಂ ಸಾಧು ಸಹ ಶಿಕ್ಷಕಾಣಾಂ ಪ್ರತಿಷ್ಠಾಪಿತವ್ಯ ಏವ ಅಂದರೆ ಎಲ್ಲರಿಗೂ ಯಾವನಿಗೆ ಕೇಳಿಸ್ತಾ? ಓಕೆ ಕರೆಕ್ಟ್. ಥೆರಪಿ ಆಗೇ ಹೋಯ್ತಿಲ್ಲ ನನಗೆ. ಸೊ ಹೀಗಾಗಿ ಅವರು ಹೇಳಿದ್ರು ಕಾಳಿದಾಸನ ಶ್ಲೋಕದಲ್ಲಿ ಏನು ಹೇಳ್ತಾನೆ, ಕೆಲವ್ರಿಗೆ ಚೆನ್ನಾಗಿ ಗೊತ್ತಿರುತ್ತೆ ಮಾತಾಡೋಕ್ಕೆ ಬರುತ್ತಲ್ಲ, ಕೆಲವ್ರು ಮಾತಾಡೋಕ್ಕೆ ಬರುತ್ತೆ ಆದರೆ ಏನು ಗೊತ್ತಿರಲ್ಲ. ಆದರೆ ಎರಡನ್ನೂ ಇಟ್ಕೊಂಡು ಹೇಳೋವಂಥವ್ರು ಭಾಳ ಕಡಿಮೆ. ಅಂಥವ್ರನ್ನ ಶಿಕ್ಷಕರ ಇದ್ರಲ್ಲಿ ಅಗ್ರಗಣ್ಯರನ್ನಾಗಿ ನಿಲ್ಲಿಸ್ಬೇಕು ಅಂತ ಹಾಗೆ ಡಾಕ್ಟರ್ ಹೇಳಿದ್ದಾರೆ. ಸೊ ವೆರಿ ವೆರಿ ವಂಡರ್ಫುಲ್ ಆ್ಯಂಡ್ ಫ್ಯಾಂಟಾಸ್ಟಿಕ್ kind of a support from Dr. Shivashankar. So our next speaker is Dr. Anita Mahadevan Tanbittu. She is working in IIS NIMHANS as a faculty since November 2007. So NIMHANS faculty agirbeku antandre we know she has to be of some higher caliber. I hope so. I have not put any. I don't. Endri? ಹಂಗೆ. ಸೊ ಅದ್ರ ಬಗ್ಗೆ ಏನು ಹೇಳಲೇಬೇಕಾಗಿಲ್ಲ. ಸೊ ಪೋಸ್ಟ್ ಡಾಕ್ಟರಲ್ ಫೆಲೋ ಮತ್ತು ಇನ್ನು ಸಾವಿರಾರು ಇದೆ ಇಲ್ಲಿ. ನಾನು ನೋಡ್ತಾ ಕೂತ್ಕೊಂಡ್ರೆ ನನಗೆ ಗೊತ್ತಾಗಲ್ಲ. ಸೊ ಎಲ್ಲ ಇದೆ. ಸೊ ಇನ್ನು ಕೀರ್ತಿ ದೊಡ್ಡದು. ಹೌದೌದು ವಿಪರೀತ ದೊಡ್ಡದಾಗಿದೆ. ಸೊ ವೆಲ್ಕಮ್ ಯು. ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್. ಪ್ಲೀಸ್ ಕಮ್.
ನಮಸ್ಕಾರ. Do you know who is the most unlucky person in this room? Me. To have to come to speak here after that master lecture, I can only say no thanks, Prashant. I am not good at Kannada. ನಾನು ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡಿದ್ರೆ ಸರ್ ಬಂದು ಒದೆ ಕೊಡ್ತಾರೆ, ನೀವೆಲ್ಲ ಕಲ್ಲು ಹೊಡಿತೀರಾ, ಪ್ರಶಾಂತ್ ನನ್ನನ್ನು ಒದ್ದೊಡಿಸ್ತಾರೆ. ಸೊ I was unfortunate that I didn't get a seat in National College. ನಂಗೆ ಕೊಡಲಿಲ್ಲ. ನಾನು ಓದಿದ್ದು NMKRV. But I will try to speak very simple English. Anything that you don't understand, raise your hand. And I will request my mentor, Dr. Shivashankar, to translate. Okay? Okay, na? Right. So, ಇಡೀ ದಿನ you learned so much about research, advances, so many things that have happened in Parkinson's disease. ಆದರೆ at the end of all this, ಒಂದೇ ಒಂದು ಪ್ರಶ್ನೆ ಕೇಳ್ತೀನಿ. How did they find out about all this? How? So if I was to name the most important milestone, ಯಾವುದು ಅಂತ ನನ್ನನ್ನು ಕೇಳಿದ್ರೆ, I will say 4 things. One is the very first description of the disease itself, and that was, it's not as old as me, it's older than me, 1811, more than 200 years. Dr. James Parkinson ಅವರು first describe ಮಾಡಿದ್ರು, and that description, it seems, yeah, exactly, 56 pages description ಕೊಟ್ಟಿದ್ರು ಅವರು. ಆವಾಗ that description sold for 3 shillings. Okay, but ಅದಾದಮೇಲೆ 1895 ನಲ್ಲಿ the part of the brain which is actually involved in Parkinson's disease. Adana mid-brain antivi. It's a very small area. It's right in the center. Adike adana mid-brain antivi. In this small area, one black line kanista idya. A black line, it's called substantia nigra. Andre substance black, nigra andre black. This black substance is normally there in the midbrain. Adre Parkinson's ali they found that it has become lighter. It's no longer dark black, light aitu. Yake andre adrolagiro neurons have died. Degeneration, sir. Saita ide. Okay. But more importantly, that was first observation. Adadmele 1912 ಅಲ್ಲಿ Dr. Louis anta he identified a nerve cells ಒಳಗಡೆ ಈ ತರ eosinophil ಅಂದ್ರೆ pinkish round structures ಇರುತ್ತೆ. Okay, that is very important because it helped us make a diagnosis of Parkinson's disease. How do you recognize, Prashant? So many markers, no? Like that, for us to recognize disease, we also need many markers. This was the first marker, most important marker that was described. But entire Parkinson's, ella sikkapate therapy ella helidru, is all to do with dopamine. And it was this gentleman, Carlson, Swedish neurologist, very young. He had just finished his neurology PG, yes sir. Kannadadalli heltira ankonde. PG. And he discovered that e chemical is important for movement. He was looking at flies. But it was this person, Hornikeyev, is the giant, is the father literally of Parkinson's disease. Avare ಕಂಡುಹಿಡಿದಿದ್ದು ಆ mid brain area ನಲ್ಲಿ dopamine, that chemical is very less because ಅಲ್ಲಿರೋ nerve cells ಯಾವುದು dopamine what makes dopamine dies. Okay, and that led to first treatment with levodopa. ಅವ್ರಿಗೆ ಗೊತ್ತಾಯ್ತು dopamine ಕಮ್ಮಿ ಆಗಿದೆ, you have to replace levodopa ಅಂತ. So this was the first clinical trial where he actually said that bedridden patients, I am reading it out, who were unable to sit up, patients who could not stand up when they were sitting, patients when standing could not start walking, performed all these activities when they were given L-dopa. So that was the very first trial, and they found that L-dopa helps to treat Parkinson's disease. But remember, idella henge, how did they find that out? Was all thanks to families of patients who donated the brain to science research. Okay, Parkinson's matra illa, so many other disease like Alzheimer disease, even that was a lot of things were discovered about Alzheimer. This is normal brain. Idon slice, so it's like a bread loaf. If you can compare, it looks like a walnut, shrunken walnut. Ade agodu Alzheimer alli. All because again one more chemical, it's called acetylcholine, adu kammi agutte. So they are trying to treat Alzheimer with that. Okay, again because somebody donated, patients with Alzheimer's donated their brain for research. That led to a lot of PET scans, ways of trying to diagnose Alzheimer and so on. But despite all this, since hundreds of years we are having brains being donated, we are having research going on in the brain. You may ask me, why brain? Why not use the fly and the cell culture on the petri dish? Why don't we use that? Because we had so many talks in the morning. Fact is, a fly brain and human brain are not the same. We evolved. A fly doesn't develop Parkinson's by itself. A mouse does not develop any form of dementia. It is blessed. Only humans. It's a price we are paying because we wanted the most evolved brain. So whatever research, it is ideally done in human brain. Okay? Despite all that, of course, lot of questions ke answers illa inna. Research has to continue, and we need more and more material for research. Of course, why our scientists don't like human brain is very simple. Helid mat kelalla, alla sir? You can train a mouse, you can make a fly the way you want it. You can't do that to humans. But more important than that is whatever brain we get after death. Remember, like the clinicians say, And the last, finally what happens? That information, Dr. Prashant always says, "Neev kodo information is too late." We want to know what is happening early on. I think Dr. Anish was talking about early treatment. Early treatment, early diagnosis beku. How are we going to diagnose? How do we make out the first time point at which disease starts? That is what they want to know. And for us to understand that, we still need to do a lot of research. Okay? So although the brain we are getting at end point, it still gives us a lot of information, and based on that information only you're having a lot of treatment. So how do we get to know the earliest changes? One thing you should remember, our brain, when we look at it under a microscope, our cell, we don't know that nerve cell, how it was functioning. Was it like Dr. Shivashankar's dramatic talk, or was it like me, don't know. That cell is under a microscope, it is fixed. So we need to know before death how that patient was during life. So adikke now research is all about people during life signing up for donation, and they will be followed up for 20 years, 30 years. The most best example is, it's called the nun study. Ivrella nuns, they are Roman Catholic sisters. Notre Dame anta on church ide idralli, US alli. They all signed up for donation when they were very young. They were followed up for 30, 40, 50, 60 years, however long they lived. And when they died, that brain was most precious because we knew how that brain was functioning during life. That is what we need. Idanella cohort studies antare, and it's nice that India is now starting those kind of cohort studies, for which we need to enroll beforehand. It's like you say that I want to be an eye donor, you enroll during life. It's the same thing with brains. So brain bank, and you've heard of lots of banks. Dr. Shivashankar was talking about money bank. I'm talking about brain bank. So this is a bank where we store brains that are collected so that everybody in the country, in the world can do research and try to find eventually, maybe not tomorrow, a cure for all of these diseases. But for this, we need two things. One, donors who want to donate so that the next family can benefit, and clinicians who can educate all of us. Okay? So across the world, there are several brain banks. If you look at United States, there are 82. There is 38 in Europe. Asia has 60% of the world's population. Allirodu nalake bank. India nalli onde ondu. Why do we need a bank in India? Namdella made in India. You talk about made in India for everything. We have made in India for brain diseases also. I think Dr. Falguni was saying about Parsi community where Parkinson's is high. There are different communities in India have different types of diseases which are more common there. Okay? So we need to have our own brains. And the person in India who we all believe is the father of brain banking is Professor Shankar. He was our teacher, mentor, teacher to many of us here. He in 1985 thought that brain bank irleveku. India should have a brain bank. He had to work 10 years to convince the funding agency, brain bank we have to make anta. He made that bank. And today all the research that is happening in our country is thanks to that one man. So what did he want to do? He wanted to provide scientists, because scientists will ask, if I tell them don't use fly, don't use cell, they'll ask me, give me human brain. So who's going to do that? That's what he did. Okay? He provided it free of cost to anybody in the country. He didn't do it for his own research, he did it so that others can do research. And it also helps the family, because Dr. Prashant will tell you that various forms of degeneration can be very similar. Avaru eneno heltare, PSA heltare, MSA heltare, eneno heltare, but finally, till date also, no PET scan, no blood test can tell you for 100% certainty yav tara dementia. That still remains examination of the brain. So families also tend to benefit. There are a lot of questions that you may ask about brain donation. So I'm just going to go very quickly. Legal issue ಏನು ಫಸ್ಟ್ ಅದೇ ಕೇಳ್ತೀರಾ ನೀವು. ಇಂಡಿಯಾನಲ್ಲಿ 1994 ಅಲ್ಲಿ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟೇಷನ್ ಆಫ್ ಆರ್ಗನ್ ಆಕ್ಟ್ ಅಂತ ಮಾಡಿದ್ರು. ಅದಾದ್ಮೇಲೆ ಏನೂ ಮಾಡಿಲ್ಲ. ಬಟ್ ರಿಮೆಂಬರ್ ದಿಸ್ ಆಕ್ಟ್ ಇಸ್ ಓನ್ಲಿ ಫಾರ್ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟೇಷನ್ ಟು ಗಿವ್ ಲೈಫ್. It has nothing to do with research. brains can never be transplanted? Dr. Prashant? Ganapati. There is only one Ganapati, okay? We all cannot be Ganapati. So fact is, we cannot. So whatever brain ನೀವು ಕೊಡೋದು is only and only for research. Since there is no legal on this, it is left to the individuals and their families to give consent for research. I have said that, but still, today I am going to sign, I have already signed, that I want my brain to be taken for research. Okay? When I die, my family can say no. Final, who has the word, is only the families. Even if I say I want to give when I die, ನನ್ನ ಮಾತಿಗೆ ಬೆಲೆನೇ ಇಲ್ಲ ಅಲ್ವಾ ಸರ್? ಹೌದು ಅಂತಾರೆ. It is only the family. Keep that in mind. So if you want really to donate your brain, your family has to consent. So the question that you will ask is, ಅಯ್ಯೋ ನಾನು ಹಿಂದೂ, whatever last rites or ಮಾಡುವಾಗ the Purohit will say that brain ತೆಗೆದ್ಬಿಟ್ರಾ, next birth you will be born without a brain. Those kind of beliefs are there. So the question often asked, does our religion forbid? Answer is no. This is a group from Uttaradi Mat, Shankar Mata. ಇವರೆಲ್ಲ ಬಂದರು ನಮ್ಮ ಬ್ರೈನ್ ಬ್ಯಾಂಕ್ಗೆ about 5 years back. I thought ಮುಟ್ಟೋದೇ ಇಲ್ಲ, ಹತ್ರ ಬರಲ್ಲ ಬ್ರೈನ್ ಹತ್ರ. We allow them to hold brains. Anyone who come into our this thing, they can hold the brain. We thought they will not touch. They came, they sat for 3 hours, they held the brain. They told me so many things in scriptures about the brain, which is already there, which we don't even know. ಅದಾದಮೇಲೆ ಸೈನ್ ಮಾಡಿ ಹೋದರು. They willed their brains for research. Forget about religion forbidding it. This is the Pavamana mantra I think all of you know about. Mrityorma Amritam Gamya, that's all I'm going to tell you about. Keep that in mind. Organ donation, like Dr. Prashant said, is not new. We know about Dadichi, who is supposed to have given his vertebral column na kotru Vajrayuda Madake. We have Bedara Kannappa, I don't need to tell you about that. He is the first eye donor. And as Dr. Prashant said, we have Ganesha, first successful organ transplant in the world. Okay? But it has never been replicated. So fact is, no religion bans. Hinduism, Bhagavad Gita says it's the greatest act of generosity, self-giving. Sikhism also says the same thing. Islam initially said no, then they reversed their position. Ivaga avaru they encourage. Okay, it says actually in the Holy Quran, whoever saves the life of one person would be as if he saved life of all mankind. Right? Buddhism says the same thing. So essentially no religion bans organ donation of any kind. Do we use it for transplantation? I've already said. What is the answer? Very good. The other thing I've already covered, it's the final is consent from the family. We have no say in our own. I'm finishing quickly. So, ಯಾರು enroll ಮಾಡಬಹುದು? Do I need to have a disease to enroll? Answer is no. ಯಾಕಂದ್ರೆ controls are more important. You have to compare with something. That's control, normal, is much more valuable, much more important than disease. Okay? Is it different from other organ donation? Answer is yes. Most organ donation for transplantation, I have to die in the hospital. Dr. Prashant will put me on a ventilator. He will go around Bangalore asking who can take my organs. And until that, I have to be maintained on ventilator. This is not like that. It is not for transplantation. Even if death occurs on the road, at home, we can take, provided within 24 hours, we take it. Disfigurement agatta is a question you ask. We never make cuts on the face. It's only from one ear to the other. We stitch this back and it's a beautiful, hair covers it, so absolutely no scar. How soon? I've told you within 24 hours. Yen madadu, if you want to, soon after death, you just need to call the brain bank. I am available 24/7. I have a fantastic team available 24/7. We make all the arrangements to bring. We will take 2 hours from the time that we bring to the mortuary and we return it. Okay? With full respect. What do we do with it? We bread loaf it and we put it into these minus 80 degrees Celsius. We can do all kinds of tests. Whatever was described today, everything can be done with it. Now, 25 ವರ್ಷದಿಂದ ಇದೀವಿ, ಏನೇನು ಮಾಡಿದೀವಿ, lot of people from across India have taken tissues from us. Lot of new findings have been given to the world thanks for thanks to using tissues from the brain bank. Neurodegenerationally, Parkinson's-alli, HIV-nalli, COVID-alli, epilepsy-nalli, lot of things that the brain bank has contributed to. All thanks to the families who willingly donated their loved ones. We also have a brain museum. This is open to schools and to public. So any of you who want to come, please come. It gives joy. It has given children, their textbooks actually come alive. It has given hope. So it is not just the nuns we spoke about. We have our own Hall of Fame. These are all people from different walks of life. All of them, many of them are teachers, and they continue to teach us even after death. The biggest example, of course, is Dr. Shankar himself, who's donated his brain to the brain bank. We also have a body donation program at NIMHANS, and this is used by neurosurgery residents, Kaliyake, how to do surgeries, how to become perfect before they touch a living human being. So this is a small poem that was written by a father whose son had just died. I'll leave this poem with you, you can read it. But before ending, I want to thank my entire team, which includes our mortuary staff, who are the most respectful that you can ever find. Professor Shankar, clinicians who think that it's very important for research, and every family that has donated to us, and Professor Shankar, who's the father of biobanking. So thank you very much for your attention. Sorry for it.
Thank you, ma'am. Thank you for that wonderful talk. We can take one or two questions. Any questions, anybody?
I want to share. Which I was doing my MPTP Parkinson research. I took it, as you told, our all mentor, especially Professor Shankar. I took that basal ganglia, vitamin globus pildis, and so substantiating from Professor Shankar from during 95, 98. I remember my token of respect to him, he's a mentor, as you told, with a token of respect.
I hope there are many more like him.
I'd like to share, ma'am. In 2014, I donated my husband's brain for research in JIPMA.
Hats off to people like her, because it's thanks to them that research in India is happening. Yeah, I'll share that with you. You can just take a picture of this. All information is there on this.
Yes, can
you can also go to that brain bank. You can take this picture. Yeah, it's a QR code.
Doctor,
yes,
one more last question from my side. Yeah, Gokul. I would like.
Yes, sorry. Yes,
sorry.
Doctor.
Yeah. So what I would like to say is, the DBS, which we normally use it as a surgical procedures for this, right? And I have a very costly device implanted in me. I mean, I always joke around that, I have a 10 lakh worth of device or 12 lakh worth of device inside me, and if some terrorist
18 lakhs is a correction there.
Whatever, right? Okay, fine. So because of that, can I donate the device if I die or something? Like, is it going to be useful to somebody, or is it going to be kind of...
the device itself?
Yeah.
Dr. Prashant, I think question is yours.
Oh, okay.
Second is we don't know how the tissue has to be utilized and managed, and companies will never give guarantee for those things. And that is where if someone is going to use it, it becomes a very sensitive question about that, right? So that is where currently we don't do it. And both there is issues from legal perspective, and there is issues from ethical perspectives, and from medical perspectives. All there are different issues are at different levels for us to give answer. Thank you, Dr. Anita. Excellent talk, and Dr. Shivashankar, excellent talk.
Mobile number.
And yes, we have a lot of pamphlets, other things. We'll have a lot of questions. I think everyone will. Lunch break is all the question break. That's what we'll have it.
Thank you, ma'am. I request Mr. Gokul to introduce the final speaker for this section.
So it's my pleasure to introduce Dr. Professor KVS Hari, and he is part of the CBR here, that is the Center for Brain Research, and he's about 30 years of experience in teaching and leadership, with a PhD in System Science from the University of California, San Diego, and he's been a faculty member of the Department of ECE since 1992, and he served as a chair from the 2015 to 2017. Okay. So, I mean, I do share some of those research topics that he has done. But of course, I mean, I'm a very low-level student, in the sense that some of those signal processing and stuff like that he has done, and also some of the system-related things that he has done. I think it's going to be very, very useful. And I welcome Dr. K.B.S. and take the podium. So, thanks.
Good afternoon. Welcome. So I know that we are short of time, so I will not take too much time of yours because the next session is more important. Center for Brain Research is basically focusing on activities on the neurodegenerative diseases of the elderly. So our primary focus is on Alzheimer's disease, Parkinson's disease. And therefore it is very appropriate that, and I thank all of you to assembled here and learn about the causes and maybe the developments in trying to cure, if possible, these diseases. We have been engaging in cohort study, like the previous speaker referred to, longitudinal studies on aging. So we are looking at urban and rural cohorts where we are trying to track healthy subjects above 45 years of age to understand how their cognitive skills progress over the years, so that we can then understand maybe the mechanisms of these diseases. So I'm an electrical engineering or professor of signal processing. I know a little bit of neuroscience, but I don't claim to be an expert in neuroscience. But we all know that the brain is such a complicated, I would call it an organ. Therefore, one approach alone will not be enough to understand its functioning and the cause of disease. So in CBR, we are very focused on a multimodal approach. So we look at this problem from multiple dimensions, multiple facets, and therefore we have a team across disciplines. So we have clinicians, we have chemists, we have genomics experts, we have machine learning and deep learning experts, and all of us are trying to understand how we can explain, maybe understand the functioning and the degeneration of the brain, so that we can come up with some interventions. So the center's focus is a mission mode approach to understand. That means we need to know how to diagnose the disease early, and then see whether we can, if already we are too late to diagnose, then how do we manage, and maybe find interventions to delay the onset of the disease. So in that context, all our efforts, and we are committed to that, and we obviously seek the help of all of you to volunteer in our cohort studies and also share your experiences. And we would like to actively work with clinicians who are interested in the research part, deal with the patients of the diseases, so that we can come up jointly with a strategy for ensuring the public health of India is addressed in terms of effective policies of interventions. So thank you all once again for coming here, and look forward to interesting session after this. Thank you very much.
So we'll move on to our next session, that is patient experiences. We have a video sent by Professor Mahadevan from who was an IISc faculty. Currently he is in US. He would be sharing with us his experience of treatment with levodopa and deep brain stimulation.
Good morning. Let me extend a personal welcome to all those who are interested in attending this half-day symposium on Parkinson's disease. Parkinson's is a very debilitating and crippling disorder particularly related to movement. It's considered as a movement disorder. It affects the life of person who suffers from the disease. Also close family members who are who try to provide support to the individual, the patient. In my case, so first let me introduce briefly about myself. I'm a retired professor of genetics from the Institute of Science, and I was diagnosed with Parkinson's disease about 15 years ago, 2009 to be sure. Okay, in the month of March actually, quite late March. If I remember, 28th was the day. March 28th was the day that I had gone to the hospital to get the confirmation. So from that point, at the time of the diagnosis, symptoms are very, very minor, hardly anything at all. People can see me and then don't think that I have any serious disorder at all. But as time progressed, it's a progressive disorder and relates to the loss of cells in the brain in a region called substantia nigra, which makes a neurotransmitter called dopamine, which is necessary for functioning of the neuromuscular junctions. Wherever the neurons and muscles meet, and at the point, it's the neurotransmitter. And dopamine levels drop means all the movements become extremely slow and rigid, and some cases it can lead to tremors, in some other cases rigidity. Two types of issues. So in my case it's more of rigidity dominant, not so much tremor dominant. So you won't see my hands trembling as in the case of several other people that you may have noticed. But in my case it's not so. So in my case it's rigidity, so as a result when the dopamine levels dip, then my movement becomes completely slowed down, totally slowed down. And so much so that in fact, let me just retrace something. So for a long time the symptoms were reasonably under control. I could even drive my vehicle, even though I prefer to walk on a sunny day to the institute. And but the thing is, after some time the symptoms began more and more severe. And at this point of time, when I consulted my neurologist, he said almost all the cells in the brain are dead, all the brain cells making dopamine are dead, and therefore I have no recourse to any other medication other than externally added dopamine. But the thing is, dopamine cannot be treated, cannot be injected or anything because it cannot cross the blood-brain barrier. That's a major limitation. So the only medication that I have is the Syndopa. This is medication. This is tablets. So I have to pop one every 3 hours. My doctor said do not take more than 6 tablets per day because it can induce hallucination and other side effects. And the other major side effect you can see is I can't sit and talk to you because of what are called dyskinesia. Dyskinesia is the non-intended targets are triggered by dopamine in the peripheral system. It goes in and then gets absorbed, and dopamine in the brain goes to other receptors that are not necessarily involved in movement, and as a result total unwanted movements are there, unwanted aspects are there. So that's why I can't sit and talk to you properly. I have to keep on fidgety. I'm very, very fidgety. Many ask what this guy is doing. Why is he so fidgety in this issue? Okay, so another thing is, as the progression worsens, what happens is you can now clearly distinguish two types. So you need to have dopamine, externally added L-dopa, that is to be taken, medication. And if you don't take the medication, you go downhill. Really you can't move. So it's called bradykinesia, so total lack of movement. And as a result of the lack of movement, and then it's not just lack of movement, so you feel terrible also. It's a very difficult to describe the situation. In fact, I have many postings. One of the postings I have said, it almost feels like I'm attacked by the Dementors. This is Harry Potter books. I don't know, J.K. Rowling's novels you may be familiar. In that she describes a situation where you're attacked by Dementors. They suck out all the happy thoughts from you. So fighting them you need really something called Patronus charm, which is a lot of light produced, light repels them, and you have to come up with all the kinds of wonderful friends, love, friendship, love affairs, love that you have for other people, your friends, love for your friends, all that is brought up. Then only you can repel this dementor. So I almost feel like that every day when the level goes up. It's very difficult to describe. Even caregivers many times don't understand. They get, oh, what's the guy doing? So where's keep on saying that, oh, I feel low, I feel low, I feel low. Because dopamine, in addition to being a neurotransmitter necessary for movements, also a neurotransmitter that makes you happy. When you hear a nice piece of music, like Beethoven's Ninth Symphony or beautiful music or Raghudi's Tilanas, anything like that, then the joy that you experience comes from the fact that you have dopamine secreted in the brain. So it's called a pleasure hormone. So when that reduces, then you have serious case of clinical depression. So people go into depression, serious depression. So my doctor has actually advised me, in addition to L-Dopa, asked me to take some medication called Nexitol, something like that. Nexito, yes. It's a mood elevator, so it increases the natural secretion of all other hormones necessary for keeping your mood. An important aspect that I want to present today has to do with the treatment, the therapy for Parkinson's for people who are somewhat late into the onset of the disease. This is called the invasive procedure called deep brain stimulation, DBS for short. It involves a surgical procedure where it's like implanting a brain pacemaker in the body of the individual. For that it requires the person is operated with minimum penetration, so that in my own case, first they have to make an MRI scan of my brain, or a Google map, so that the doctor, neurologist and the people involved in selling you the product to be implanted, they decide on the exact location, and this is done by taking MRI 1 day before the surgery. There's no such substantial changes in the position, and it involves, they had to anesthetize the patient so that because of the dyskinesia, a lot of movements are there. They don't want any movements in the exact determination of the location. Once that is determined, then they had to cast the next day. I had to clear my head, completely torn shirt hair, and they put a sort of a crown. I call it a crown because it's a steel frame, and that's clamped there in my head. And then the surgeon, after local anesthesia, he puts 2 holes, the place where the bump is located. So drill with, of course, local anesthetic, so you don't feel much pain at all. But it's kind of weird having to listen to the sound of the drill going, and then nothing, no pain at all. But then you have to be kept conscious, because then they insert the electrodes, and the positioning is very critical. So the neural keeps on asking me questions. Based on the answer, the fastness of the answer, the accuracy of the answer, they determine whether the position is correct. And then the wires are taken up and subcutaneously, 2, one from the right side and one from the left, 2 electrodes are implanted. Each electrode has 2 prongs, anterior and posterior. So there are 4 parameters in general to be considered in this case. Left electrode, right electrode, anterior, posterior. And then the wires are drawn from the left and the right and come together, and they implant under the collarbone, the chest, this side of the chest. And then once the power is turned on, it keeps constantly supplying pulses, electrical pulses to the brain continuously. Throughout the rest of your life you need to keep that. And how does it work? This works by aiding in a parallel pathway to the dopamine. So you still have to have dopamine, and the dopamine levels have to be reduced considerably, because supposed to work with very much less dopamine. The idea is that dopamine also stimulates, as I said, so many other neurons, so all that has to be blocked. So the DBS voltage that you supply is supposed to block those negative impact, negative pathways in some way. This help the patient to regain a reasonably normal life. But in my case, to my surprise, shock and surprise, I still need to use very high levels of dopamine, almost as much as sometimes even more, 6 to 7 tablets maximum per day. So when I discuss this with my friends in the PD group, they say, "What the hell, man? Something wrong seriously, you have to consider what's going on." According to them, one possible solution to this is that the voltage is not simply voltage and current. The pulsing, the frequency of the pulsing, so many parameters can be changed. And at present there is no knowledge, very little knowledge to the doctors as to how this works. So everything is empirical, so they trial and error method. Oh, let's try this. Increase voltage 0.1 millivolt and then decrease by 1 and so on. So my request is made to all demand through our doctor to the companies that make these manufacture these devices to come up with practical solution to the problem so the patient can get maximum benefit, because I paid our money for this procedure but I have not derived maximum benefit as was promised to me. When I consult the neurologist, the neurosurgeons are very gung-ho about it. He said they may make wrong statement because for them it's a corporate structure and they need to get so many patients to the, and there's a pre-evaluation of that long procedure. You have to be sensitive. It's only motor neuron deficiency that can be corrected. No other thing can be corrected. In the case of Parkinson's, and also it has to be dopamine sensitive. Not dopamine sensitive. There are many dopamine insensitive sort of Parkinson's. So whole spectrum of disorder. This work only with limited cases. In my case, after all evaluation, I said yes, we are a good candidate, and apparently I answered all the questions very rapidly. And the neurologist posed them, and they were happy at that time. But I must say that I'm still not very happy, but I still have to take a large amount of medication. Medication on-off times are terrible. Off times are terrible. As I mentioned earlier, off time I go through sort of every day I go through in a right away I have to know articles that I go through whole audio like that. Every time my medicine goes off, I'm dying, almost like 90-year-old man, 100-year-old man. And when I take the medicine within half an hour, I regain my childhood, goes through the whole cycles 5-6 times a day. That's no fun, I must say. And the doses are enormous. And the high doses also lead to dyskinesia that you see. So I would like to plead with all the doctors to help us out by putting pressure on the manufacturers of the device so they can.
Moving on, I'd like to welcome Harish Kulkarni, Senior Manager at Cape Gemini from India, to share his experience on young onset Parkinson's disease and how I overcame the hurdles.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಹಲೋ ಆಲ್. ಕನ್ನಡ ಮತ್ತು ಇಂಗ್ಲೀಷ್ ಎರಡೂ ಮಿಕ್ಸ್ ಮಾಡ್ತೀನಿ. ಹೋಪ್ಫುಲ್ಲಿ ಐ ಟಿಯಲ್ಲಿರೋರು ಕನ್ನಡ ಮಾತಾಡೋದು ನಿಮ್ಮ ಹತ್ರ ಕಲಿಬೇಕು ಸರ್. ಐ ಟಿ ಕನ್ನಡಿಗರು ನಿಮ್ಮ ಹತ್ರ ಕನ್ನಡ ಕಲಿಬೇಕಾಗಿದೆ. ಸೊ ಇಟ್ ಇಸ್ ಅ ಗುಡ್ ಸಾಂಗ್ ಯು ಪ್ಲೇಡ್ ಸರ್. ಒಳ್ಳೆ ಹಾಡಿತ್ತು. ಇನಿಷಿಯಲಿ ಜಮೀಸೆ ಆಸ್ಮಾದ ನಮಗೆ ನಾವು ಐ ಕಮ್ ಫ್ರಮ್ ರಾಯಚೂರು, ಪ್ಲೇಸ್ ಕಾಲ್ಡ್ ರಾಯಚೂರು. ಇಟ್ಸ್ ಇನ್ ನಾರ್ತ್ ಕರ್ನಾಟಕ. ಅದಕ್ಕೆ ಒಂದು ವೋಕಲ್ ಫಾರ್ ಲೋಕಲ್ ಅಂತಾರಲ್ಲ, ಅದಕ್ಕೊಂದು ಕನ್ನಡದ ಹೆಸರಿಟ್ಟಿದ್ವಿ ಆ ಸ್ಟೇಟಸ್ಗೆ, ಆನ್ ಸ್ಟೇಟಸ್, ಸಿಂಡೋಪ್ ಆನ್ ಸ್ಟೇಟಸ್ಗೆ. ಗೊಂಬೆ ಕೀಲಿ ಕೊಡ್ತಾ ಅಂತ. ವೆನ್ ವಿ ಆರ್ ಕಿಡ್ಸ್ ವಿ ಯೂಸ್ ಟು ಹ್ಯಾವ್ ಸಮ್ ಟಾಯ್ಸ್, ಗೊಂಬೆಗಳು ಇರ್ತಿತ್ತು. ಅದಕ್ಕೆ ಫುಲ್ ಕೀ ಆನ್ ಮಾಡಿ ಬಿಟ್ಟಾಗ ಎಷ್ಟು ಆ್ಯಕ್ಟಿವ್ ಆಗಿರ್ತಿತ್ತಲ್ಲ, ಆ ಸ್ಟೇಟಸ್ ಸಿಂಡೋಪ ತೊಗೊಂಡಾಗಿರುತ್ತೆ ಆನ್ ಸ್ಟೇಟಸ್. ಅದಕ್ಕೆ ಗೊಂಬೆ ಕೀಲಿ ಕೊಡ್ತಾ ಅಂತ ಕೇಳ್ತಾರೆ. ಸೊ ವೆನ್ ಐ ಟೇಕ್ ಸಿಂಡೋಪ ಆಫ್ಟರ್ ಸಮ್ ಟೈಮ್ ವೈಫ್ ಆಸ್ ವೆನ್ ಇಫ್ ಐ ಆಮ್ ಲೋ, ಇನ್ನೂ ಕೀಲಿ ಕೊಟ್ಟಿಲ್ಲ ಅಂತ ಕೇಳ್ತಾರೆ ನನ್ನ ವೈಫು. ಐಸೆ ಇನ್ನೂ 5 ನಿಮಿಷ, 5 minutes. ದೆನ್ ಒನ್ಸ್ ವಿ ಆರ್ ಇನ್ ಆನ್ ಮೋಡ್, ಇಟ್ಸ್ ಲೈಕ್ ಶಂಕರ್ನಾಗ್ ಸಾಂಗ್, ಸಂತೋಷಕ್ಕೆ ಹಾಡು ಸಂತೋಷಕ್ಕೆ. ವೆನ್ ವಿ ಕಮ್ ಟು ಆಫ್, ರಾಜ್ಕುಮಾರ್ ಸಾಂಗ್, ಬಾಡಿ ಹೋದ ಬಳ್ಳಿಯಿಂದ ಹೂ ಅರಳಬಹುದೇ. ಸೊ this is what we enjoy every day. I don't think we suffer. I promise I will not use the word suffer. So we enjoy every day. So, and Dr. Anish sir, you said about on dance therapy, it is quite interesting. I hope one day some channel will host Dance India dance competition for PD patients and we will participate in that. Yeah, I can do with count also. So I am Harish and I am around 49 years of age now. I have been enjoying Parkinson's since last 9 years, 8 to 9 years. 8 to 9 years. Yes, it was a shock. Let's be very honest. It was a shock because it's a prime age. When I was 40, I was diagnosed with Parkinson's. It's a prime age of your life when you are settling in life. You buy home, have loans, and your kids are studying. They just started studying in middle school or something like that. It's a shock, definitely shock. What helps is your family support. My wife, she also works. She said, if you want to take break, I'll take care of house. That gave me a lot of strength. Then I said, I'm not going to regret in my life. The first thing that you need to be that helped me a lot is, I'm not going to regret in my life, whatever happens. I'm going to enjoy my life. Whatever time I have, I hope I'll have some more long enough life. So I'll enjoy my life. So that's one thing. I'm not going to regret. But you need to adjust few small things in your life to deal with Parkinson. Few things that I do. I pursue my passion. I'm a columnist. I write articles in newspapers, web portals occasionally, along with my day-to-day 9 to 6 job. I am a columnist. I keep writing. I'm a history buff. I write about modern history, Indian history, and I write about historical figures, great people, historical people. I write that and I publish in the web portals. And one good part is, and I cherished for a long time, is one of my articles was quoted and appreciated by Foreign Secretary of India. So this happened after Parkinson's disease. He said one of the finest article that it was on international affairs. So Foreign Secretary of India had quoted it and said one of the finest article. And one small thing that help is, don't aim for doing big tasks. Do small things at home. Like, Amma heliddu, Ajji heliddu, batte onagaku. I started putting clothes on dry. It helps a lot. Batte onagakodu. Paatre ತೊಳೆದಿಟ್ಟು ಹೋಗಿರ್ತಾರೆ, ಪಾತ್ರೆ ಅದರ ಜಾಗದಲ್ಲಿ ಅದು ಇಡಬೇಕು. This helps a lot. And since I limit my travel, I work from home. When my wife comes back from office, by the time I'll make tea. Taking sugar, opening the box and putting sugar at the right measure and putting tea powder at right measure, mixing milk and all those things. It helps a lot. So these small things helps a lot. And since we have been listening to a lot of shlokas, that one shloka I always follow. Ashwam naiva gajam naiva, vyaghram naiva vachanaiva cha, ajaputram balim dadyat, devo durbalya ghatakaha. Now when you sacrifice, you won't sacrifice a horse, you won't sacrifice an elephant, you won't sacrifice a tiger or lion. It's always a sheep. So even God will not support who feel weak. So don't feel weak. Never feel weak. Whatever you are strong for yourself. I don't need to compare with somebody else. Whatever you are strong. We are strong to ourselves, and live a happy life. And one more thing I want to say is feel ease. Best thing is seek support, feel comfortable. Seek support and feel comfortable. For example, I am walking with my friends. They walk little fast. It's okay to ask them to be a little slow so that I can join them. No need to worry or no need to feel ashamed, no need to feel embarrassed or something like that. Seek support. Society is there to help you. Friends are there to help you. Family is there to help you. Seek support. Take care, but don't care. Take care, but don't care. This is a mantra I have been following since last 8 years. Take care, but don't care. I take care of myself. I don't care somebody feels odd about it. So these are the small things that I do. The best thing I want to repeat is do small tasks at home. It will help a lot. It will help a lot for your hand-eye coordination, hand-brain coordination, finger movements, and all those things. And as I said, I pursue my passion. I am a little adventurous guy. I love adventures. And I have photographs I was showing to doctor. I did a Shivashankar in Himalaya. This was after Parkinson. And in Goa I swam, I went deep into almost half a kilometer into the sea and I swam there in the sea. This was after Parkinson. And when I went to Rajasthan, I did horse riding. This was after Parkinson. So this will make you feel, I'm fine. The most important thing is to make yourself feel I'm fine. Then you will be definitely fine. Whatever you have limitations, you will be fine. And another thing is, one thing that helped me a lot along with my family, my workplace. Workplace, I have to thank my company, I have to thank my colleagues and managers, and they have been very helpful. They don't mind if I say, can I take a day more to complete this task? I ask them. I don't do it again and again, but when there would be some time that you might need some more time to work, complete your work. It's okay to ask, and they have been very helpful to say, yes, I don't mind, you can take one more day. And sometimes my manager, he says, okay, don't worry, I'll do it for you. So these things are very helpful. So don't misuse this in a professional life, but it's okay if you're honest to your profession. Your colleagues are ready to help you. At least I have experienced that. So this is my small experiences. I hope it will be helpful for you. Any questions? I can answer to the best possible extent to myself.
I have a suggestion.
Yes, madam.
Apart from tea, you can make biryani. No problem.
I can cook vegetarian food.
Just in a lighter way.
I can cook. I used to cook when I was a kid, but after marriage I stopped it. Now after Parkinson I started it again. After Parkinson I started it. Sir, ನೀವು ಹತ್ರ ಕನ್ನಡ ಕಲಿಬೇಕು ಸರ್. IT ಕನ್ನಡಿಗರಿಗೆ ಕನ್ನಡ ಹೇಳ್ಕೊಡ್ಬೇಕು ನೀವು. Thank you. Thank you so much.
Thank you so much.
He is a role model to all of us. Whether we do it even without even without PD also, he is a role model. Whatever he said, ಅಡಿಗೆ ಮನೆ ಅಥವಾ ಕಾಫಿ ಮಾಡ್ಕೊಡ್ಬೋದು, ಟೀ ಮಾಡ್ಕೊಡ್ಬೋದು, ಇದನ್ನು ನನ್ನ ಕೌನ್ಸಿಲಿಂಗ್ನಲ್ಲಿ ಎಲ್ಲ ಪೇಷಂಟ್ಸ್ಗೂ ಬೇಕಾಗುತ್ತೆ. ಯಾಕೆ ಅಂದರೆ ಅಡುಗೆ ಮನೆಯಷ್ಟು ದೊಡ್ಡ ಕಾಲೇಜು ಬೇರೆ ಎಲ್ಲೂ ಸಿಗುವುದಿಲ್ಲ. ಇಸ್ ದ ಬಿಗ್ಗೆಸ್ಟ್ ಯೂನಿವರ್ಸಿಟಿ ದಟ್ ಯು ಹ್ಯಾವ್. ಆ್ಯಂಡ್ ಮಕ್ಕಳಿಗೆ ಹೇಳಬೇಕಾದ್ರೆ ತಂದೆ ತಾಯಿಗಳಿಗೆ ಪೇರೆಂಟ್ಸ್ ಆರ್ ದ ಬೆಸ್ಟ್ ಟೀಚರ್. ಸೊ ಆ ಯೂನಿವರ್ಸಿಟಿನಲ್ಲಿ ನೀವು ಕೆಲಸ ಮಾಡಬೇಕು. ವೆರಿ ನೈಸ್, ವೆರಿ ನೈಸ್. ಸೊ ನೈಸ್.
Thank you so much. That was a very positive talk. Next we have Geetha R, health coordinator, talking about how to plan yourself when you have Parkinson's disease.
Hello dopamines. I mean it. Hello dopamines. Good afternoon. I think my topic is how to plan yourself. In contrary, Parkinson had a plan for me. When I was told that when I was diagnosed I had Parkinson, it did not come as a shock. Oh, I thought I had already some problem, hypothyroidism and some lymphatic drainage problem. I thought that's why I had a myth, because we have something bigger, nothing won't come. That myth was broken. I accepted, because someday in the 2020 December I was diagnosed. 2014 I lost my husband. That DAPDA, like denial, anger, bargaining, depression and acceptance. So in the depression stage I took 5 years. I used to go to work and be at home at nothing, simply sitting like that, not even watching TV. So it was that depression I took 5 years. Later, that is a different story. Let me come to the Parkinson. Why I say Parkinson had a plan for me, because life is to be understood from backwards, but life should be lived forward. So I have a story to tell about me. I do not know whether it will be interesting for you or not. I am a person who is always very fast. I do everything in haste. I cannot do anything slowly at all. And even when I eat, somebody, my colleagues used to say, "Why are you eating so fast?" As though somebody is going to grab from you. It was my habit. Even now I have that. But Parkinson, they used to say it slows down. But for me, I think it is not slowing. Still this persists. Dopamine is the pleasure hormone which is responsible for our body movement, speech, cognition, memory, awakening, alert, creativity. For me, it is a sleep disturbance. That is a challenge for me. But what is that? Being awake is my, I don't see as a problem, because I always enjoy being awake. But I came to understand for dopamine, I should preserve means I should sleep. So this is the challenge for me, not the Parkinson, but the sleep. It is not after Parkinson I had a sleep disturbance, even before. About the diagnosis, I would like to say, some years back, very, very long back, I do not know, it may be 10 years back or even more than that, I was having loss of smell. But strong smell I could have it. But that did not bother me at all. Later, when I was diagnosed in JIPMA in 28th December, I was called a COVID warrior. I am a medical professional, public health nurse, and I was very proud that I was a COVID warrior. So what happened when I was diagnosed this, sorry to going away. 1 minute. Because I was excited, too much excited, I think I should slow down. That's what in haste I make. After I was diagnosed, it did not slow me. Sleep disturbance was no, I can't call it a sleep disturbance. I thought after when it was diagnosed in 2020, 21st June 30, I retired from job. So for those 6 months, I was fully engaged before retirement. After retirement too, I am in a trade union movement I was in Pondicherry. So I was busy for 1 year. My son was here in Bangalore. So only once or twice in a year I used to visit him. So that 21 fully I was engaged. 22, as he said, after I got this diagnosis, in 22 I got, March 8th, I got the top 10 Women of Pondicherry Award. Then in April 30th, from Hyderabad, I got the Inspirational Women Award. Last year I got for Lifetime Achievement Award for Women in Government Service. I am a challenge to Parkinson. It does not slow me down. When it slows me down, because when I sit at home doing nothing, there I will be. But when I am outside, I will be very much active. I can call me also as hyperactive. So I thought, as I said, Parkinson has come to discipline me. Everyone will tell me you are very hyperactive, you are very dynamic. But adapting to a complex, long-standing disease, you have to adapt quickly. That is a very, it may be dynamic, but it is a very complex one. So for adaptation, how I engage myself. It was first when doctor, she was not a neurosurgeon, neuromedicine, but she was a general medicine doctor. She diagnosed. When there are so many diseases like myocardial infarction, AIDS, it is a complex one, but very easy to diagnose. Likewise, she diagnosed. But I had, how come within 5 minutes she diagnosed me, but she did the test and all. I was surprised. It was not a shock. I was surprised. How could she say like that? Then went to JIPMA. It was diagnosed properly. Then there too I did not believe. Then I came to NIMHANS. So it was. So I accepted. It was not. Is it so easy to diagnose Parkinson? Yes, it was easy. Then how I overcame. Normally I used to speak very fast, not slow at all. Then so that I could not differentiate the changes. But my sister saw the changes. Today when she is in Madurai, she went for tour. I asked her, see, I am going to speak in the meeting today. Actually, I thought of putting PowerPoints and mind map, so that because already you are all scholar, everyone knows about what is what. Then why should I repeat the same thing? Why don't we share my experience so that it will understand? And I asked her, how did you find that it was there? A subtle difference was there. I could not find even the doctor from Apollo, Dr. Shivashankar, friend of Dr. L.K. Prasad. He asked, how did you so early found out? She told, you had a slight, when you are walking gait, there was a difference. You often told you skidded from Activa Honda, and you were giving reasons that it was because of bike. I even thought like that only. So she saw the subtle changes. She asked me to go and she accompanied me. So that way I was diagnosed. Later, I see this, after diagnosing with Parkinsonism, it gave me scope to learn so many things. I started learning Kannada. I was already reading French. Again, I'm continuing that. I was not in, what to say, I'm not computer savvy. So I went in Kenpro Institute. I learned the computer basics. I understand. Yesterday I enrolled for advanced Excel and for business communication I enrolled. So what happens, my son used to say, not because of Parkinson, everyone after 60, they should live not the usual life which we lived before. It should be different. So this gave me an opportunity, change of place, change of environment, change of climate, everything. It gave me an opportunity. I should be very thankful and have a gratitude for my condition because it came as a unwelcome guest, but I befriended it. So I am not alone. We will say in a Parkinson community, you are not alone. We are all there. But at home, we will be alone. But they used to say, up to in our house, no, the gate, relations will come. Up to symmetry, sun will come. After that, no one will come. I think as long as I am there, Parkinson will be there. As long as I am not there, Parkinson will not be there. So why to fear? Let me have it by the side. Don't go before me, I may not follow you. Don't come back behind me, I may not lead. Be with me. So I am having it like that. So that way, it is not for flattery I am telling. Really, I feel that and I feel happy with being Parkinson's. And what I did, how to overcome, because I noted my handwriting everyone will used to appreciate me for my long handwriting, slanting. It will be very easy to read. But now what happens, even taking notes, what you call microsmia, very slow. So what I did, I took a 2-rule note and started writing in left hand. So again it came. Then the kicking off with medicine was not only with movement. I found myself and I started, whenever the kicking starts, I started writing. So it helped me. And it gave me a lot of scope to learn yoga, lot of scope to meditation, and I also suggest learning miming. So even when you learn miming, that masking of the face will not be there. So frowning, so for Bharatanatyam, so keep trying. So Parkinson gives us a lot of scope to learn so many things which we would not have chosen for that. So it is a very good opportunity. It gives us not like any other thing. It gives a great opportunity, and I'm very thankful for my condition because had I not have it, I would not have been here. So I'm a medical person. Only when I was studying in Madras Medical College, in a specialty paper, I had a question. What is body did you find in that neuron cells? It is Lewis. That is 1 mark answer I got. And how to care for the patient suffering with Parkinson. That knowledge only I would have had. But today when I was here, I am very proud that my friend has brought me here, and I will walk with my life with pride, and I think I will be a source of hope and knowledge for my fellow who are elder to me, seniors, my senior friends with Parkinson, and my friends who are newer to come, because in the Dr. Prashant clinic I saw it is the second largest disease. So many 100 million within the 10 years there will be these many friends will be there. So let us all join together in that. I would like to say, accepting, you have to accept the condition is not that easy. When doctor told you should don't say suffering, it is a positive attitude, and I think I took a right way. There is actually temptation trying to ignore and fight, battle, struggle with things that you could not have done before. Sometimes we ignore, we deny, no, denial stage what happens, you don't take care. So you have to pass the stage, denial stage. Adapting to oneself is a dynamic process. Recognize the symptoms early. Be an advocate for yourself and your loved ones. Life can only be understood backwards. And for this topic, I would like to say, first I gave my topic, Twist with Destiny. That was Nehru's famous thing. But now, after hearing everyone say, my unwelcome guest who became my friend. And what changes that's brought me? I am a person very active, but I am not a person who will sit and work. I will not refer anything. Only by sitting and working, desk work I will not. After I got this, I had a habit of writing lot of notes I used to take, and I learnt mind mapping. I engaged myself with 5 a.m. club. That club will start by 5 o'clock in the morning up to 5:30. From 6 o'clock, have built. There is a yoga. I will give that a very useful yoga therapist. And for Monday means upper part of the body, Tuesday lower part of the body, Wednesday core, like that he has a systematic thing. So I joined that. Apart from that, there is Infinity Karthik, there is an app, the advanced mind mapping. So those all help me to engage myself all the time and to be active. For even 5 minutes I cannot be without working. So, so I would try to explore myself, and I think I read the book which doctor gave me several days before, Dr. Prashant, this book called as Destination Unknown, My Journey with Parkinson's. After reading this, when I read, from 1 o'clock to 2 o'clock in the night I read, yesterday night. This gave me an inspiration to write about, as the topic I said, no, I want, next Parkinson's Day, I will come with my book. Everyone will say, each birthday, why you want to celebrate? Because your life is going on. Only if you are going to live for 70 years, means 60th second birthday represents me that only 8 years more. No, I am living every day, I am not dying every day. My dopamine would have died, but whatever dopamine is making me alive. So I see that there are 3 components: maximize, protect, and supplement. Maximize, only you can do whatever is available, dopamine, you can maximize it by doing exercises. It can be, those schedule you will know. So you have to maximize whatever dopamine is available. You have to protect whatever dopamine is available, how to protect it? By proper nutrition, by proper meditation, positive thinking and socialization, be in a group, go to doctor regularly, follow whatever he says, believe in the doctor, believe in the treatment, take the medicine, pray for the cure. That is the protection. For supplement, meetings like this, I feel this fully loaded dopamine. This meeting was fully loaded. I think afternoon I may not need my afternoon dosage, I think. So those are the dopamines. Because this, what is life after all? It's a movement. So we all can proudly say we are having life because we are moving, moving more than anybody else. So you can, life is movement and we are living. Don't say we are dying. Dopamine would have 70 to 80% of the dopamine we had lost when we are diagnosed, the symptoms may arise. But whatever 20% is still making us alive. We have survived COVID. I have survived my mentor. I have survived my husband. I have survived my father. So I can survive this also, along with my friend. As long as I am there, my friend will be there. I want to add life to years and not years to life. With this, I would like to thank you and would like to be, I would like to extend your friendship along with my friend Parkinson's. Thank you.
Thank you, ma'am. Thank you very much for sharing your valuable experience. Is anybody?
Any questions you can ask me? I had a lot to say, but I think I was too emotional. You have to pardon me for that.
Okay, we have the author of the book Destination Unknown here, Rajiv K. Gupta. So can you please stand up?
I read fully, sir.
a round of applause to all these people who are very inspirational. Moving on, we have a talk.
Any questions to me? You can ask. And I have many success stories which if I tell everything it would be like flattery. So rest, if we have the groups we can share, or else I can bring one video book also on that.
Just want to say, ma'am, it was truly inspirational what you said. I think one thing I want to tell is you need to stay active. Like what you say, pursue all your passion, pursue your dreams, pursue your hobbies. So what all you have said is absolutely amazing, ma'am. What I would say is you're not dopaminite, you're a dynamite.
Thank you for the compliments, sir.
One good thing about Parkinson is that before Parkinson, definitely we guys don't do any work at kitchen. So मने ಕೆಲಸಕ್ಕೆ ಬಾರದೇ ಇರೋನಾಗಿದ್ವಿ ನಾವು घर के किसी काम के लायक नहीं हो. After Parkinson, I started putting clothes into dry and put vessels into their places and make tea. मने ಕೆಲಸಕ್ಕೆ ಬರೋರಾಗಿದ್ವಿ ಇವಾಗ. घर के किसी काम के लिए लायक है हम.
So you are not alone, sir. Even I don't cook. Now I am cooking. Yeah, I am the person who, because always I am outside. No, now only I started cooking when I came to Bangalore.
Thanks to Parkinson, ಮನೆಯಲ್ಲಿ ಕೆಲಸಕ್ಕೆ ಬರೋರಾಗಿದ್ವಿ ಇವಾಗ.
Thank you, Dr. Prashant. Thank you, Dr. Vijay-Shankar, who introduced him to you. Thank you, Dr. Rupesh Kumar, who introduced Dr. Vijay-Shankar. And thank you, Parkinson, for introducing everybody to you.
Small tasks at home, it really helps. In my case also, I experienced just making a cup of tea, just folding the clothes, making your own bed and all that. It really helps. Just as an input, I mean, it really helps. It helps me also. I also do that. Thank you so much.
I welcome Dr. Prathima Kadiyala from Tirupati. She'll be talking on women and young onset Parkinson's
disease. Good afternoon, everyone. I'm Dr. Prathima. I wear two hats. I'm a doctor and as well as a patient. I just turned 44 yesterday. So I was diagnosed. I was diagnosed when I was 38. So this is my year 6 of young onset Parkinson's disease. So I'm going to talk about women and YOPD. So I'll be giving some advice to patients and giving some advice to the doctors as well, because they have to know the patient's perspective as well. So moving on. So why women? We know about the statistics. The prevalence of PD in India is around 15 to 43 per 1 lakh. That's the rough estimate. Now if you take around, if you see everybody under 50 years, like juvenile onset, young onset, as well as YOPD, it's around 40%, that is half. Now number of females, no statistics. We don't have any numbers. We know that women are less affected, but we are still there. Women are we are not the center of the universe, but we are still the center of the home. We are still the center of the family life. So we are important. And that's why we need to know. We are the caregivers. We are the mothers, we are the sisters, we are the daughter-in-laws, and we are the predominant caregivers. And having YOPD at this age, it really takes a toll on you. And it's a very largely unexplored area. We have our own unique needs. So then my next slide is mainly based on information from this paper. So what are the fundamental differences between YOPD? I'm only talking about YOPD between men and women. So with regards to the motor symptoms, we have more tremor dominant, there's more facial masking, and we have more dyskinesias compared to the men. This is all compared to the men. And the good thing is we have less disease progression. Coming to the non-motor symptoms, as women we are always more prone compared to the men for non-motor symptoms, depression, low mood, and so all these things are more in us. And the better thing, we have less cognitive impairment, we have less hallucinations, and we have less sexual dysfunction as well. Now psychosocial, this is the most important factor. We are prone, like females, we are more prone for psychological distress. We have a lot of negative image. Consider women as such, we like grooming. So we are always, that's why we have so many clothes shops, makeup shops, whatever you think, whatever it is. But we want to groom. Now, I had to factor anxiety. For anxiety is the family functions. Because I had to get ready, I had to get my kids ready, and I had to look brilliant. Right, so what is the cost? Now, being a caregiver as well as YOPD, the emotional exhaustion is huge. Now, women are predicted as this, multitasking. So I had to do everything, which probably will not happen. And like my previous speakers have already spoken about, like when you're on, you feel like a superwoman. You want to do everything, you want to, like talking in the seminar as well, but that was when I accepted this during my on period. And when I'm off, I keep thinking, why did I do this? I have so much other things to do and all those things. So when you're on, you feel like a superwoman, and you just try to do everything there. But here you have to understand, like what Geetha ma'am said, you have PD, you have to prioritize, we have to prioritize, and we have to walk along with PD, not before, not behind. Right, management-wise, there's always delayed diagnosis. YOPD as such has different presentations, and female as such are the last to diagnose because it's very rare in females, and they can have very variable presentations. And women don't speak. There's a lot of stigma. And they have this inability to articulate. You have to understand women can't express themselves when it comes to symptoms. When I was a medical trainee in UK, there is this syndrome called whole body syndrome, which they used to do it for the Asian females. Like when you ask them where's the pain, they say like it's everywhere. So majority of the females from the villages, they can't articulate. It's the clinician's job to extract the history. It's not the patient's job. History taking is an art, and it's the clinician's job to extract the history. Yeah, we talked about personalized care. So what about personalized care in women with YOPD? You always have to think about pregnancy, which is very rare, but we still have a couple of females in our WhatsApp group who had gone through pregnancy. And menstruation, obviously there's menstruation. The thing is perimenopause. We go through this stage. Anybody below 50 go through perimenopause, and you have a lot of mood swings. We don't know whether it's because of PD or whether it's our menopause, whether it's the hormones. Estrogen does affect the brain, and how does it affect? Whether it's good to give HRT, or is it good to just increase your dose for those few days? This is something subjective. This is something we need to explore. So estrogen, HRT as such is not a contraindication if you have PD and if you have symptoms. But this is largely unexplored. And along with that, women, when we go through perimenopause, menopause, you have to think about osteoporosis, your general health. May not be a neurologist, but go and see your gynecologist or a general physician, or the doctors. The neurologist should advise the female patients to go and see the other specialties as well. So wellness strategies have already been covered, but you need to educate the female patient more than the male. Emotional health is very important, and you have spiritual health, like chanting, singing, meditation. All these things give you a balance, even with all these adversities, you have a meaningful life, right? It's not all this ground you down. And in this huge universe, you do have a role to play, even with all your limitations. So I don't know whether you heard about neurographic art, but this is quite calming, and it's very easy. Anybody can do it. So it's a way of art therapy, mindfulness art. Well, that's a crappy art, but others have done it well. Yeah, like the previous speakers told, you have to develop your own interest. It is well known people on dopamine agonists and PD have more creativity. So yes, explore your creative work. I did write my book as well. Sorry to use this platform to promote my book. But That's not about PD, that's about interpersonal relations. Okay. Exercises, yes, we do have to rotate between cardio, yoga, tai chi, dance, boxing. We have a longer life. I was still at 38 when I diagnosed, so I learned boxing for 1 year, and then I went for dancing for another couple of years because it gets boring. Doing the same exercise, mandate, you have to rotate between all the different exercises. Yeah, finances. It's not a major issue for females in India because we are not the bread earners, but that's changing now. Now for the next generation, you probably need to make money as well. But the societal obligations, when you're a female and you have YOPD, you naturally give up on your career. Your family becomes your priority, and even if you work, you're not paid at the same rate as a male. I'm not trying to make this as a male versus female, but that's the truth. Fortunate or unfortunately, we know that women outlive men. So you always have to think about your pension schemes as well. So when I was just going to the literature, the top unmet need for men is the help with their employment. That's the YOPD patients. And the top unmet need for women is community more like me. We have very few numbers. YOPD in women is very rare, so we have very few numbers. But we need somebody to connect. Somebody in our age group, somebody going through the same problems. And women in India don't usually talk. I'm the one who talks everywhere. But generally women don't talk that much. They don't talk about these symptoms. It's kind of a big stigma for them. Right, so this is, I am very grateful for all my friends for this video. Just a little task for all of you. If you can identify me. Volume. Karthik? Did you guys identify me? Well done. Anyway, thank you. Thank you for giving me this opportunity, Dr. Prashant.
Thank you so much, Dr. Prathima. I think we have a few more experiences that had to be shared. There were a few requests. After that, we'll quickly go for the lunch. So we'll have whoever wanted.
Parkinson's ಅನ್ನೋ ಕಾಯಿಲೆಯ ಒಂದು ಪದದಲ್ಲೇ ಒಂದು ಮಿರರ್ ಇದೆ. ಆ ಮಿರರ್ನ ನಾವು ನೋಡಿಲ್ಲ. ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅಂದಾಗ ಅಲ್ಲಿ ಬರುವಂಥ ಆಲ್ಫಾಬೆಟ್ಸ್ ಏನಿದೆಯಲ್ಲ ಪ್ರತಿಯೊಂದು ಒಂದು ಜಂಪ್ಸ್ ಆಗಿದೆ. ಅದನ್ನು ನಾವು ನೋಡಿದಾಗ ಆ ಪದದಿಂದಲೇ ಇಡೀ ಪಾರ್ಕಿನ್ಸನ್ಸ್ನ ಕಲಿಬಹುದು. ಗುರು ಬ್ರಹ್ಮ ಗುರು ವಿಷ್ಣು ಗುರುದೇವೋ ಮಹೇಶ್ವರ ಗುರು ಸಾಕ್ಷಾತ್ ಪರಬ್ರಹ್ಮ ತಸ್ಮೈ ಶ್ರೀ ಗುರುವೇ ನಮಃ ಅಂತಂದ್ರಿ. ದಟ್ ಈಸ್ ಪಾರ್ಕಿನ್ಸನ್. ಈ ಪಾರ್ಕಿನ್ಸನ್ಸು ಬರೀ ಕೇರ್ ಗಿವರ್ಸ್ಗಲ್ಲ, ಪೇಷಂಟ್ಸ್ಗಲ್ಲ, ಈವನ್ ಫಾರ್ ಡಾಕ್ಟರ್ಸ್ ಆ್ಯಂಡ್ ದಿ ಸೊಸೈಟಿ, ಸಾಮಾಜಿಕವಾಗಿಯೂ ಇದೆ. ಈಗ ಫಾರ್ ಜಸ್ಟ್ ಐ ವಿಲ್ ಫಿನಿಶ್ ಫ್ಯೂ ಸೆಕೆಂಡ್ಸ್. ಪಿ ಫಾರ್ ಪಾಸಿಬಲ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಸೈಕಾಲಜಿ ಅಂತ ಹೇಳ್ತೀವಿ, ಪೇಷನ್ಸ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಯು ಸರ್ಚ್ ದಿ ವರ್ಡ್ಸ್ ಫ್ರಮ್ ದೋಸ್ ಥಿಂಗ್ಸ್. ನಥಿಂಗ್ ಈಸ್ ಇಂಪಾಸಿಬಲ್, ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ಪಾಸಿಬಲ್. ಪಿನಲ್ಲಿ ಆ ಥರ ಬರುತ್ತೆ. ಅನೇಕ ಪದಗಳಿದೆ. ನಾನೊಂದು ಆರ್ಟಿಕಲ್ಲೇ ಮಾಡಿದ್ದೆ, ಬಟ್ ಈ ಥರ ಇದೆ ಅಂತ ಗೊತ್ತಿರಲಿಲ್ಲ, ತರಲಿಲ್ಲ ಅಷ್ಟೇ. PPTನೂ ಮಾಡಿದ್ದೀನಿ ಅದಕ್ಕೆ. ದೆನ್ ಇಫ್ ಯು ಕಮ್ ಟು ದಿ ಎಬಿಲಿಟಿ, ಆ್ಯಂಗರ್, ಆಂಗ್ಸೈಟಿ, isn't it? All the glitters is not gold ಅಂತ ಕರಿತೀವಿ. Parkinson's and Proverbs are there. They are mingling with these things. Why I am saying all the glitters are not gold ಅಂತಂದರೆ, ಈಗ ನಾವೇನೋ ಕಾಯಿಲೆ ಬಂದ್ಬಿಡ್ತು ಅಂದಕ್ಕೆ, ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಆಗಲಿ ಯಾವುದೇ ಕಾಯಿಲೆ ಬಂದಕ್ಕೆ ಯಾರ ಹತ್ರನೋ ಹೋಗ್ಬಿಡ್ತೀವಿ. ಈಗ ಹೇಳಿದ್ರು ಅವರು, ಯಾರೋ ಡಾಕ್ಟರ್ ಹೇಳಿದ್ರಲ್ಲ, ಅದನ್ನು ಐಡೆಂಟಿಫೈ ಮಾಡೋದು ಬಹಳ ಕಷ್ಟ. ಅದು ವೆನ್ ಇಟ್ ಕಮ್ಸ್ ಟು ನ್ಯೂರಾಲಜಿಸ್ಟ್ ಓನ್ಲಿ ದೆನ್ ಇಟ್ ವಿಲ್ ಪ್ರಾಪರ್ ಅಂತ ಕಾಣಿಸುತ್ತೆ. ಯಾಕೆಂದರೆ ಆರ್ಡಿನರಿ ಡಾಕ್ಟರ್ಗಳು ಸುಮ್ಮನೆ ಏನೇನೋ ಒಂದು ಹೇಳ್ತಾರೆ, ಪಾಪ ಅವರ ಎಕ್ಸ್ಪೀರಿಯನ್ಸಲ್ಲಿ ಹೇಳ್ತಾರೆ. ಬಟ್ ಇದು ಏನಾಗುತ್ತೆ ಅಂತಂದರೆ, ಅದಕ್ಕೆ ಎಲ್ಲಿ ಬೆಳ್ಳಗಿರೋದಿಲ್ಲ ಹಾಲೆಲ್ಲ ಅಂತಾರಲ್ಲ, ಸುಮ್ಮನೆ ಎಲ್ಲೆಲ್ಲ ಪಾಪ ಗೊತ್ತಿರಲ್ಲ, ನಾಲೆಡ್ಜ್ ಇರಲ್ಲ, ಎಲ್ಲೆಲ್ಲ ಹೋಗ್ಬಿಡ್ತಾರೆ. ಆಯಿತಾ? ಏನೆಲ್ಲೂ ಸುಮಾರು ಪದಗಳು ಹಾಗೆ ಬಂದಿದೆ. ದೆನ್ ರಿಸರ್ಚ್, ರೀಪ್ರೊಡ್ಯೂಸ್, ರಿಫ್ರೆಶ್, ರಿಮೈಂಡ್. ಅದು ಕೇರ್ ಗಿವರ್ಗೂ ಆಗುತ್ತೆ, ಎಲ್ಲರಿಗೂ ಆಗುತ್ತೆ. ಐ ಆಮ್ ನಾಟ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಅಬೌಟ್ ದಿ ಪೇಷಂಟ್ಸ್ ಆರ್ ನಾಟ್ ಪರ್ಟಿಕ್ಯುಲರ್ ಅಬೌಟ್ ದಿ ಕೇರ್ ಗಿವರ್, ಈವನ್ ಫಾರ್ ದಿ ಡಾಕ್ಟರ್ಸ್. ಐ ಡೋಂಟ್ ವಾಂಟ್ ಟು ಟಾಕ್. ನಾನು ಅಷ್ಟು ದೊಡ್ಡವನಲ್ಲ, ಅದು ನನಗೇನು ಗೊತ್ತಿಲ್ಲ ಅದ್ರ ಬಗ್ಗೆ. ಬಟ್ ನಾನು ಅದನ್ನು ರಿಮೈಂಡ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಯಾಕೆ ಅಂತಂದರೆ, ಇಲ್ಲಿ ರಿಸರ್ಚ್, ರೀಪ್ರೊಡ್ಯೂಸ್, ರಿಫ್ರೆಶ್ ಅಂತ ಕರಿತೀವಿ. ರಿವಾರ್ಡ್ಲೆಸ್, ಹೂ ಎವರ್ ಮೇ ಬಿ, ವೆದರ್ ಇಟ್ ಇಸ್ ಕೇರ್ ಗಿವರ್ ಆರ್ ಡಾಕ್ಟರ್ಸ್ ಆರ್ ಹೂ ಎವರ್ ಬಿ, ಯು ಮಸ್ಟ್ ಫೈಟ್ ಫಾರ್ ಇಟ್. ರಿವಾರ್ಡ್ಲೆಸ್ ಆಗಿ ಕೆಲಸ ಮಾಡಬೇಕು. ದೆನ್ ಕಮ್ ಟು ಕೆ ಅಂದಾಗ ಇಲ್ಲಿ ಕೈಂಡ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಕೈಂಡ್ನೆಸ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಯು ಮೇ ನೋ ದಟ್ ಕೆಲಿಡೋಸ್ಕೋಪಿಕ್ ವಿಷನ್ ಅಂತ ಕರಿತೀವಿ ಅದನ್ನು. ಕೆಲಿಡೋಸ್ಕೋಪಿಕ್ ವಿಷನ್ ಅಂದರೆ ಯು ಹ್ಯಾವ್ ಟು ವ್ಯೂ ದಿ 360 ಡಿಗ್ರೀಸ್. ಯಾವುದನ್ನೇ ಆಗಲಿ ಅದನ್ನು ನಾವು ನೋಡಿದಾಗ ಆವಾಗ ಅದು ಗೊತ್ತಾಗುತ್ತೆ. ಅದರ್ವೈಸ್ ರಿಸರ್ಚ್ ಅಂತ ಹೇಳಿದೆ ನಾನು. ಐ ಮೇಡ್ ಸೋ ಮೆನಿ. ಇದು ಸುಮ್ಮನೆ ಒಂದು ಸ್ವಲ್ಪ ಸ್ಯಾಂಪಲ್ ತಂದೀನಿ. ನಾನು ಟ್ರೈನಲ್ಲಿ ಬಂದುಬಿಟ್ಟೆ. ಇಫ್ ಐ ಕೇಮ್ ಬೈ ಕಾರ್ ತುಂಬ ತರ್ತಾ ಇದೆ. ಇದು ಅವೇರ್ನೆಸ್ ಇಲ್ಲ, ಎಷ್ಟೋ ಜನಕ್ಕೆ ಗೊತ್ತಿಲ್ಲ. ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅಂದರೆ ಎಷ್ಟೋ ಎಜುಕೇಟೆಡ್ ಆಗಿರೋರು, IAS ಎಂಥವ್ರಿಗೂ ಕೆಲವು ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅಂದರೆ ಅದೇನು ಅನ್ನೋದೇ ಗೊತ್ತಿಲ್ಲ. ಸೊ ಐ ಮೇಡ್ ಆಲ್ ದೀಸ್ ಥಿಂಗ್ಸ್. ಐ ವಿಲ್ ಗಿವ್ ಇಟ್ ಟು ಸೋ ಮೆನಿ ಪರ್ಸನ್ಸ್ ಟು ಎನ್ಕರೇಜ್ ದೆಮ್. ಈಗ ಇದು ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅಂದರೆ ಇಟ್ ಮೇ ಕಾಸ್ಟ್, ಐ ಆಮ್ ನಾಟ್ ಫಾರ್ ದಿ ಮನಿ, ಸೋಷಿಯಲ್ ಸರ್ವಿಸ್ಗೆ ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಆ್ಯಂಡ್ ಯು ಸಿ ಐ ಮೇಡ್ ದಿಸ್ ಡೈಲಿ ಲಿವಿಂಗ್ ಹೆಲ್ಪ್ಫುಲ್ ಹಿಂಟ್ಸ್ ಅಂತ. ಅಂದರೆ ಅದು they may be seniors, they may be patients, or whoever may be, it will help also. Then you see why I am making it in, I am a carer. ಇದನ್ನು ಬೇಕಾದ್ರೆ ನಿಮ್ಮ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ಗೆ ನಾನು ಐ ವಿಲ್ ಗಿವ್ ಇಟ್, ಅದು ಕಾಪಿ ಮಾಡಿಕೊಡಿ. ಬೇಕಾದ್ರೆ ಐ ವಿಲ್ ಬೇರ್ ದಿ ಚಾರ್ಜ್. ಒಂದು 100 ಅಲ್ಲ 250 ಕೊಡಿ, ಪ್ರಿಂಟ್ ಮಾಡಿಕೊಡಿ. ಅದಕ್ಕೆ ಎಷ್ಟು ಏನಾಗುತ್ತೋ ಅದನ್ನು ನಾನು ಕೊಡ್ತೀನಿ. ದೆನ್ ಮಾರ್ನಿಂಗ್ ಎಕೈನೇಸಿಯಾ ಆ್ಯಂಡ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸೀಸ್ ಅಂತಂದೆ. ಇದು ಪರ್ಟಿಕ್ಯುಲರ್ ಆಗಿ ನನ್ನ ಮಿಸ್ಸಸ್ನ ನೋಡಿ ಮಾಡಿದ್ದು ನಾನು. ಯಾಕೆಂದರೆ ಮಾರ್ನಿಂಗ್ ಟೈಮಲ್ಲಿ ಮತ್ತು ಈವ್ನಿಂಗ್ ಟೈಮ್ನಲ್ಲಿ ಇಟ್ ವಿಲ್ ಗೋಸ್, ಅದು ಗ್ರಾಫಿಕಲ್ ಆಗಿ ತೊಗೊಂಡಾಗ ಇಟ್ ಇನ್ಕ್ರೀಸಸ್, ಮತ್ತು ಆಮೇಲೆ ಆಟೋಮೆಟಿಕ್ಕಾಗಿ ಅದು ಕಡಿಮೆ ಬಂದುಬಿಡುತ್ತೆ. ಸೊ ಇದು ಒಂದು ರಿಸರ್ಚ್ ಮಾಡಿದ್ದಾರೆ ಇಟಾಲಿನಲ್ಲಿ, 1 ಇಯರಿಂದ ಮಾಡಿರುವಂಥ ಪೇಪರ್ ಇದು. ಅದನ್ನು ಮಾಡಿದ್ದೀನಿ. ಆ್ಯಂಡ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸೀಸ್ ದಿ ಬೇಸಿಕ್ಸ್ ಅಂದರೆ ನೋಡಿ, ಇದು ಪವರ್ ಪಾಯಿಂಟ್ಸ್ ಎಲ್ಲ ಸಿಗುತ್ತೆ. ಇದು ಎಲ್ಲೆಲ್ಲಿ ಹೋದರೂ ನೀವು ಹುರ್ಕೊಡಿದ್ರೆ ಬೇಕಾದಷ್ಟು ಸಿಗುತ್ತೆ. ಆ್ಯಂಡ್ ದೆರ್ ಆರ್ ಸೋ ಮೆನಿ ವೆಬ್ಸೈಟ್ಸ್. ಒಂದು ಬುಕ್ಕೇ ವೆಬ್ಸೈಟ್ ಇದೆ, 2014ನಲ್ಲಿ ಮಾಡಿದ್ದಾರೆ. ಅದನ್ನು ಅಪ್ಡೇಟ್ ಮಾಡಿಲ್ಲ, ಆ ವೆಬ್ಸೈಟ್ನ ಅಪ್ಡೇಟ್ ಮಾಡಿಲ್ಲ. ಅದರಲ್ಲಿ ಡಾಕ್ಟ್ರಿಗೆ ಅವ್ರಿಗೆ ಕೊಟ್ಟಿದ್ದು ನನಗೆ ಗೊತ್ತಿಲ್ಲ, ಒಂದು ಸರಿ ಕಳಿಸಿದ್ದೆ ಅಂತ ಕಾಣಿಸುತ್ತೆ ನಿಮಗೆ. 2014 ಎಲ್ಲ ಮಾರ್ಬಿಟ್ಟಿರೋದು ಎಲ್ಲ ಇನ್ಕ್ಲೂಡಿಂಗ್ ಆಲ್ ರಿಗಾರ್ಡಿಂಗ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್ಗೆ ಏನೇನಿದೆ ವೆಬ್ಸೈಟಲ್ಲಿ ಎಲ್ಲ ಅಂತ ಪ್ರತಿಯೊಂದು. ದೆನ್ ಕೋರ್ಸ್ ಅಬೌಟ್ ಲಿವಿಂಗ್ ವಿತ್ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಡಿಸೀಸ್ ಅಂತ ಇವರು ಒಂದು ಡೈಲಿ ಒಂದು ಕೋಟ್ಗಳು ಮಾಡಿದ್ದಾರೆ ನೋಡಿ. ಇಟ್ಸ್ ಹೆಲ್ಪ್ಸ್ ಅ ಲಾಟ್, ನಾಟ್ ಫಾರ್ ದಿ PD patients, even to the entire who they are suffering from all these kinds of ಇದು. Then ಇದು 2 sides of the Parkinson's experience. It is a very beautiful article written by someone in the year 2021. Then ಈಗ ಕೆಲವು ಇಂಗ್ಲೀಷ್ನಲ್ಲಿ ಗೊತ್ತಿಲ್ಲ, ಅವ್ರಿಗೆ ಟರ್ಮಿನಾಲಜೀಸ್ ಗೊತ್ತಾಗಲ್ಲ. ನೀವೇನೋ ಬರೆದ್ಬಿಡ್ತೀರಾ PDS ಅಂದ್ಬಿಡ್ತೀರಾ. PDS ಅಂದರೆ ಈವನ್ ದೇ ಡೋಂಟ್ ನೋ ಎನಿಥಿಂಗ್, ಆಯಿತಾ. ಅದು ಇದು ಕನ್ನಡದಲ್ಲೂ ಮಾಡಿದೆ, ವೈವಿಧ್ಯ ಅನ್ನೋರೊಬ್ಬರು ಡಾಕ್ಟ್ರು AH ಮೋಹನ್ ಅಂತ ಬರ್ತದೆ. ಭಾಳ ಸಿಂಪಲ್ಲಾಗಿ ತುಂಬ ಇದಾಗಿ ಚೆನ್ನಾಗಿ ಮಾಡಿದ್ದಾರೆ. ಇಟ್ ಈಸ್ ಆಲ್ಸೋ ಅವೈಲಬಲ್. ಇದು ನಾನು ಬೇಕಾದ್ರೆ ಇಲ್ಲಿ ಯಾರಿಗಾರು ನಿಮಗೆ ಕೊಟ್ಟೋಗ್ತೀನಿ, ಅದನ್ನು ನೀವು ಪ್ರಿಂಟ್ ಮಾಡ್ಕೊಡೋದ್ರೆ. ಪಾರ್ಕಿನ್ಸನ್ ಡಿಸೀಸ್ ಆ್ಯಂಡ್ ಕೇರ್ ಗಿವಿಂಗ್, ದೇರ್ ಆರ್ ಪ್ಲೆಂಟಿ ಆಫ್ ದಟ್. ಹಾಗೆ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ನೋಡಿ, 10 ways to someone you love manage ಪಾರ್ಕಿನ್ಸನ್ ಡಿಸೀಸ್. ಇದು ನಾನು ಯಾಕಪ್ಪ ದಪ್ಪಾಕ್ಷರದಲ್ಲಿ ಮಾಡಿದ್ದೀನಿ ಅಂತಂದರೆ, ಬಿಕಾಸ್ ಸೀನಿಯರ್ಸ್ಗೆ ಓದಲಿಕ್ಕಾಗಲ್ಲ, ವಿತೌಟ್ ಕನ್ನಡಕ್ಕಾಗಲಿ ಅಥವಾ ಮತ್ತೊಂದಾಗಲಿ ಬೇಕಾಗುತ್ತೆ, ಹಾಗೆ ಓದಲಿಕ್ಕೆ ಅನುಕೂಲ ಆಗಲಿ ಅಂತ ಅದನ್ನು ಮಾಡಿದ್ದೀನಿ. ಆ್ಯಂಡ್ ದಿಸ್ ಈಸ್ ಆಲ್ಸೋ ದೇರ್ ಆರ್ 12 points ಆರ್ ಹಿಯರ್. ಅದನ್ನು ನಾನೇನು ನಿಮಗೆ ಆಲ್ಫಾಬೆಟಲ್ಲಿ ಹೇಳಿದ್ನೋ ಅದನ್ನು ಇಲ್ಲಿ ಕೆಲವರು ಕೊಟ್ಟಿದ್ದಾರೆ ಎಲ್ಲ ಕ್ಲೀನಾಗಿ. ಇದು ಅಷ್ಟೇ, ದಿಸ್ ಈಸ್ ಆಲ್ಸೋ ಹೆಲ್ಪ್ಫುಲ್ ಫಾರ್ ಈಚ್ ಆ್ಯಂಡ್ ಎವರಿಬಡಿ. ಯು ಶೇರ್ ಇಟ್ ಆ್ಯಂಡ್ ಯು ಸ್ಪ್ರೆಡ್ ಇಟ್. ದೆನ್ ದಿಸ್ ಇಸ್ ಆಲ್ಸೋ, ದೆನ್ ಐ ಮೇಡ್ ಇಟ್, ಬಟ್ ಮಾಡೋಕ್ಕಾಗಲಿಲ್ಲ. ಮೈಂಡ್ ಮ್ಯಾಪ್ ಮಾಡಲಿಕ್ಕೆ ಮಾಡಿದ್ದೆ. ಹೆಲ್ಪ್ಫುಲ್ ಇಂಟ್ಸ್ ಆ್ಯಂಡ್ ದೀಸ್ ಆರ್ ಆಲ್ ದಿ ಥಿಂಗ್ಸ್. ಈಗ ನಾನು ಹೇಳಿದಿಷ್ಟೇ. ಒಂದು, ಇದು ಅವೇರ್ನೆಸ್ಸು ಸರಿಯಾಗಿಲ್ಲ. ಆ್ಯಕ್ಚುಲಾಗಿ ಈ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಬಂದರೆ ಏನು ಅನ್ನೋದು ಜನಕ್ಕೆ ಎಷ್ಟೋ ಜನಕ್ಕೆ ಗೊತ್ತಿಲ್ಲ. ಆಮೇಲೆ ಅದನ್ನು ನಾವು ಏನು ಮಾಡಬೇಕು ಅಂತಂದರೆ ಆ್ಯಸ್ ಎ ಕೇರ್ ಗಿವರ್ ಅಥವಾ ಡಾಕ್ಟರ್ಸ್ಗಳಿಗೆ ಕಮ್ಯುನಿಕೇಟ್ ಮಾಡಲಿಕ್ಕೆ ನಾವು ಅದನ್ನು ಕ್ಲೀನಾಗಿ ಅದನ್ನು ಒಂದು ಡೈರಿ ಮೇಂಟೈನ್ ಮಾಡಿಕೊಂಡು, ಆ ಡೈರಿಯಲ್ಲಿ ಯಾವಾಗ ಏನೇನಾಗುತ್ತೆ ಅಂತ ನಾನು ಅದು ವೀಡಿಯೋನು ಮಾಡಿದ್ದೀನಿ. ನನ್ನ ಮಿಸಸ್ದು ಪ್ರತಿಯೊಂದು ಮಾಡಿದ್ದೀನಿ. ವೈಲ್ ಗೋಯಿಂಗ್ ಟು ಬೆಡ್ರೂಮ್, while going to bathroom and all those things, it is very difficult for them. Particularly women's ಗೆ ತುಂಬ ಕಷ್ಟ ಆಗುತ್ತೆ, ಅವ್ರಿಗೆ ಒಂಥರ ಮುಜುಗರ ಆಗುತ್ತೆ, ಆಯಿತಾ. ಆ ಶೇಕಿಂಗ್ ನೋಡ್ಬಿಟ್ರೆ ಬೇರೆಯವರ ಹೆದರು ಬಿಡ್ತಾರೆ. ಆ ಟೈಮಲ್ಲಿ ಮಾರ್ನಿಂಗ್ ಟೈಮಲ್ಲಿ ಇದು ತುಂಬ ಆಗುತ್ತೆ, ಆಯಿತಾ. ಹಾಗೆ ಅದನ್ನು ಒಂದು ಗ್ರಾಫ್ ಮಾಡಿ, ಎಸ್ ಅಂತಂದ್ರೆ ಅದರಲ್ಲೇ ಇದೆ ನೋಡಿ. ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅಂದಾಗ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್, ವಿ ಹ್ಯಾವ್ ಟು ಮೇಂಟೈನ್ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್. ಈಗ ಸಣ್ಣ ಮಕ್ಳಿಗೆ ಗೊತ್ತಿದೆ. ಇಫ್ ಯು ಗೋ ಟು 5 year 6 year ಚಿಲ್ಡ್ರನ್, ಅವನು 6ನೇ ಕ್ಲಾಸ್ ಓದ್ತಾ ಇದ್ದ ಹುಡುಗನಿಗೆ ಇವೆಲ್ಲ ಗೊತ್ತಿದೆ. ಯು ಯುಟಿಲೈಸ್ ಆಲ್ ದೀಸ್ ಫೆಲೋಸ್, ಆಯಿತಾ. ಆಮೇಲೆ ನಾನು ಹೇಳಿದೆ ನನ್ನ ಮಿಸಸ್ಗೆ, ನೋಡು ಪಾರ್ಕಿನ್ಸನ್ ಒಂದು ವರ ಕೊಟ್ಟಿದ್ದಾನೆ ದೇವರು, ನಿನಗೆ ಒಂದು ವರ ಕೊಟ್ಟಿದ್ದಾನೆ. ಯು ಟೇಕ್ ಇಟ್ ಆಸ್ ಎ ಚಾಲೆಂಜ್, ಆಯಿತಾ. ದೇವ್ರು ಯಾವ ಕಾರಣಕ್ಕೂ ಯಾರಿಗೂ ಏನು ಮಾಡಲ್ಲ. ಯಾಕೆ ಅಂತಂದರೆ ನಿನಗೆ ಕೊಟ್ಟಿರೋದನ್ನು ನಿನ್ನ ರೋಲ್ ಮಾಡಲಾಗಿ ನೀನು ಯು ಮಸ್ಟ್ ಎನ್ಕರೇಜ್ ದೆಮ್, ಯು ಮಸ್ಟ್ ಕರೇಜ್ ದೆಮ್, ಆಯಿತಾ. ನಾನಿದ್ದೀನಿ, ಐ ವಿಲ್ ಸಪೋರ್ಟ್ ಯು ಇನ್ ಆಲ್ ದಿ ಸೆನ್ಸ್. ನಾನು ಸುಮಾರು ಅವರಿಗೆ, ನಾನು ಐ ಆಮ್ ಎ ಸೋಷಿಯಲ್ ಸರ್ವಿಸರ್, ಐ ಆಮ್ ಟೀಚಿಂಗ್ ಫಾರ್ IIT ಫೌಂಡೇಶನ್ ಕೋರ್ಸ್ ಆ್ಯಂಡ್ ಆಲ್ ದೋಸ್ ಥಿಂಗ್ಸ್. ಐ ಆಮ್ ಎ ರಿಟೈರ್ಡ್ ಲೈಬ್ರರಿಯನ್ ಆ್ಯಂಡ್ ಲೆಕ್ಚರರ್. ವಿ ಆರ್ ಗೋಯಿಂಗ್ ಸೋ ಮೆನಿ ಸ್ಕೂಲ್ಸ್ ಆ್ಯಂಡ್ ಕಾಲೇಜಸ್ ಟು ಫ್ರೀ ಆಫ್ ಕೋಚಿಂಗ್ ಆಲ್ ದಿಸ್ ಥಿಂಗ್. ನನ್ನ ಮಿಸ್ಸಸ್ಸು ಬರ್ತಾ ಇಲ್ಲ, ಈಗ ಒಂದು 2-3 ವರ್ಷದಿಂದ ಬರ್ತಾ ಇಲ್ಲ. ಶಿ ಈಸ್ ಆಲ್ಸೋ ಡಬಲ್ ಗ್ರಾಜುಯೇಟ್, ಐ ಆಮ್ ಟ್ರಿಬಲ್ ಗ್ರಾಜುಯೇಟ್, ಆ್ಯಂಡ್ ವಿ ಆರ್ ಡೂಯಿಂಗ್ ಸೋ ಮೆನಿ ಥಿಂಗ್ಸ್. ನಥಿಂಗ್ ಟು ವರಿ ಅಬೌಟ್ ಇಟ್, ನಥಿಂಗ್ ಈಸ್ ಇಂಪಾಸಿಬಲ್, ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ಪಾಸಿಬಲ್. ದೆನ್ ನೆಸೆಸಿಟಿ ಇಸ್ ದಿ ಮದರ್ ಆಫ್ ಇನ್ವೆನ್ಷನ್ ಅಂತೀವಿ, ಎನ್ನಲ್ಲೇ ಬಂದಿದೆ. ಪಾರ್ಕಿನ್ಸನ್ ಅನ್ನೋ ಪದದಲ್ಲೇ ಎಲ್ಲ ಇದೆ ಕಂಪ್ಲೀಟ್. ಇಫ್ ಯು ಸರ್ಚ್ ಇಟ್, ಇಫ್ ಯು ಡೂ ಇಟ್, ಇಫ್ ಯು ಮೇಕ್ ಇಟ್, ಈ ಪಾರ್ಕಿನ್ಸನ್ಸ್ ಅನ್ನೋ ಹೆಮ್ಮರನ ಬುಡದಿಂದಲೇ ಕೇಳ್ಬೋದು. ನಥಿಂಗ್ ಈಸ್ ಇಂಪಾಸಿಬಲ್. ಯಾವುದು ಹೇಳ್ತೀನಿ ಕೇಳಿ. ಇವತ್ತು ಡೊಪಮೈನ್, ಇವಾಗ ಅದು ನಾನು ನೀವು ತೋರಿಸಿದ್ರಲ್ಲ, ಯಾರೋ ಮೇಡಮ್ ಎಲ್ಲ ತೋರಿಸಿದ್ರಲ್ಲ, ಅದೆಲ್ಲ ನಾನು ಮಾಡಿದ್ದೀನಿ. ಸುಮಾರು ಒನ್ ಆಲ್ಮೆರಾ ಇಸ್ ದೇರ್, ಒನ್ ಆಲ್ಮೆರಾ, ಐ ವಿಲ್ ಟೆಲ್ ಯು. ಅಷ್ಟು ಇದಿದೆ, ಅದನ್ನೆಲ್ಲ ಇಟ್ಟು ಮಾಡಿಬಿಟ್ಟು ಮಾಡಬೇಕು. ಆ್ಯಂಡ್ ದೇರ್ ಆರ್ ಸೋ ಮೆನಿ ವಿಡಿಯೋಸ್ ಆಲ್ಸೋ. ಡಾಕ್ಟರ್ ಪ್ರಶಾಂತ್ ಅವ್ರದ್ದು ನೋಡಿದ್ದೀನಿ, ಸುಮಾರು ಜನದಲ್ಲಿ ನೋಡಿದ್ದೀನಿ. ಸಿಂಪಲ್ಲಾಗಿ ಲೇಮನ್ ಕ್ಯಾನ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದೀಸ್ ಥಿಂಗ್ಸ್. ಯುಟಿಲೈಸ್ ಆಲ್ ದಿ ರಿಸೋರ್ಸಸ್. ಗ್ಯಾಡ್ಗೆಟ್ಸ್ ಇದೆ, ಬೇಕಾದಷ್ಟೇ, ಪಾಡ್ಕಾಸ್ಟ್ ಇದೆ. There are so many organizations, Parkinson's Foundations, American Parkinson's Foundation ಇದೆ, ಆಸ್ಟ್ರೇಲಿಯಾ, ಕೆನಡಾ ಎಲ್ಲ ಇದೆ, ಒಂದು 10-15 ಆರ್ಗನೈಸೇಷನ್ ಇದೆ. If anybody wants to share all these things, I will give my number, WhatsApp number, I will send it immediately without any 24/7. I will work for it. ನಾನು ಹೇಳಿದ್ದೀನಿ, ನನ್ನ ಮಿಸಸ್ಗೆ ಹೇಳ್ಬಿಟ್ಟಿದ್ದೀನಿ, ನಥಿಂಗ್ ಟು ವರಿ. ಅದನ್ನು ಹೇಳ್ತೀವಲ್ಲ, ಇಟ್ ಇಸ್ ಎ ಥ್ಯಾಂಕ್ಲೆಸ್ ಆ್ಯಂಡ್ ರಿವಾರ್ಡ್ಲೆಸ್ ಜಾಬ್. ಬೇಡ ನಮಗೆ ಯಾವುದು ಥ್ಯಾಂಕ್ಸು ಬೇಡ, ರಿವಾರ್ಡು ಬೇಡ. ವಿ ಮಸ್ಟ್ ಫಾರ್ ದಿ ಸೊಸೈಟಿ, we must do it. That's all. Thank you.
Caregivers want to share their opinion, but due to the lack of time, I request all of you to share your opinion. We have the lunch, and it will be arranged in a place where you can sit comfortably, you can take your time, please share your opinion and your feelings, all those things, please. But because of the shortage of time and we have to stick to this thing, so we have to bring a conclusion to this meeting. So it was a very, very exciting meeting. I think all of us learned a lot. So I just want to take a couple of minutes to thank the people who are involved. So the central focus, the Kendra Bindu, ನಮ್ಮ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮದ ಕೇಂದ್ರ ಬಿಂದು ಅಂದರೆ ಪಾರ್ಕಿನ್ಸನ್ ಇರುವವರು ಮತ್ತು ಅವರ ಕೇರ್ ಗಿವರ್ಸು. ಅವರು ಬರೀ ಭಾಗವಹಿಸೋದಷ್ಟೇ ಅಲ್ಲ, ತುಂಬ ಉತ್ಸಾಹದಿಂದ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಅವರಿಗೆ ನಮ್ಮ ತುಂಬ ಧನ್ಯವಾದಗಳು. The central focus of our today's function was people having Parkinson's and their caregivers. I really want to heartily thank you for their very active participation in this function. And you are our motivation for the people who are working on Parkinson and the movement disorder. You are the motivation for us to work and try to find cure or remedy for this disease. So beyond this, I want to thank all our speakers, clinicians, geneticists, basic science biologists. All of them have taken their valuable time. They have come and very actively participated, interacted with patients, caregiver, and I want to thank them, all of them, give them a big applause. So beyond that, I actually want to thank our volunteers who have really worked wonderfully, tirelessly whole day and even before that. And I really want to thank all the volunteers who are inside and outside. All the volunteers, let's give them a big hand. So I want to thank Professor Harish, just left. So I want to thank him. When we proposed this, and he was very supportive, and he actually encouraged to have this meeting here and give all the support. And I want to thank Professor Hari and the administrative team of CBR. Particularly, I want to thank the IT team, particularly Karthik, who is there even before all of us. So let us give a big hand to Karthik. And Mr. Anand and his team, he's worked tirelessly to arrange everything. I want to thank all the team members of Mr. Anand. So beyond that, of course, I want to thank my co-organizers, Dr. Prashant and Dr. Ravi Manjithaya. Actually, they are actually the force and brain, heart, muscle, everything of this meeting. I am just there. So actually, I'm kind of odd man out because I don't really personally work on movement disorder, but they are very kindly keep me in the loop. So
Ravi, you're the dopamine.
Hopefully, so I'm always interested in dopamine. I want to work on it. Someday I will, definitely. But I want to thank Dr. Prashant and Dr. Ravi Manjithaya. And beyond that, I want to thank all of you. Thank you very much for making this a wonderful day and have a wonderful session here. And this we want to keep continuing. Most importantly, this meeting brought together clinician, basic scientists, and the patient. So it gives a different perspective for each of us. So let's keep this together and keep moving forward. Thank you very much.
Yes, I can.